I still to this day on my out of hospital, like my arrests that come in, they'll take entitle off by moving somebody over the bed and not slap them on. And like in a full arrest, every single person should be on entitle, period. And we'll show you why that's important. But, I do think they don't truly understand that. But say they do. Say you go and, you walk in there and somebody's septic and they pop them on entitle and their entitle's like 12, 15. You should be very, very worried about that patient. You don't know what's going on. They may be pneumonia, they may be meningitis, they may be renal failure, but whatever it is, something bad is going on. And I think that's the important thing to take from this is that it'll tell you, how sick. And it's kind of like, I always compare entitle to ultrasound in that ultrasound doesn't really rule anything out, but it rules things in, right? When you do a fast scan, like an ultrasound looking for fluid in their belly, if you see fluid, obviously that's very sensitive that, there's some sort of bleeding spleen or something like that. It's not sensitive enough usually to say, well, this is where it is, or if you don't see it, that there's nothing going on there. And entitle's the same way. It'll say, you know what, this patient's very sick. I don't know what the hell's going on with them, but I know they're going to get sick on me. And there's still very valuable information that way.
Okay. Well, all right, that's right. Carmen, click the other screen.
And so the other thing you want to watch is like a trend for it too. So if your normal entitled to, and this is even wrong here, but your normal entitle is like 35 to 45. If you come in to see somebody and they're in that like 22 to 29 range, you're worried. If they're in that 12 to 22 range, you ought to be real worried. And if they're less than 12, you ought to be, getting your pads out, getting ready to intubate, things like that. And the other thing, and I'll talk about this, is you need to watch the trend. So we're talking about shapes of entitled CO2, right? So as you're going down, see boom, boom, boom. This is somebody gradually moving from this range to this range, and you need to be prepared to intervene. So. On next one too. The one thing that the reason why you can get so much metabolic information is number one, in order to get a reading of entitled CO2, you have to still have perfusion to the lungs. Okay, so if you don't have any blood flow to your lungs, you're not going to get any results, and that's going to be the number one determining factor on what your reading is, especially in what they call low flow states. So what would be a situation where you're not getting any good blood flow back to your lungs? Anybody? What's that?
Cardiac arrest.
Cardiac arrest for sure. PE, that's a big one right there. PE, good. Like severe heart failure, somebody with an EF of like 10%, they're not getting good output, it's not coming back either. In those situations, actually your entitled CO2 is really going to be more of a result of the metabolic side of things than the respiratory side of things. Now you're like asthmatic, COPD, things like that. That there's really typically not as much of a heart component to it. They're getting good blood return. So then in those patients, your CO2 results are more a result of their respiratory status. So you have to frame it in terms of what's going on with the individual patient. Now, obviously, we see the people who have all the above, right? They're in renal failure, CHF, they're on COPD. So it makes it a little tough, but understand what you're looking at and frame the patient's comorbidities along with what's going on.
I think you got it.
Yeah. So first one I'll talk about like specific conditions is asthma, right? With asthma, you got the normal tube. We always talk about the two different phases of asthma, right? You give the nebs, with to dilate the bronchioles, and then you give steroids to kind of help take the inflammation out, the swelling and mucus. What's that look like with entitle? Well, the biggest thing is you can actually diagnose, determine the severity, and show response to treatments all by looking at what the entitle shape looks like. You guys know that? Anybody look at your entitle shape when you're given a neb or anything like that? Good. So what do you actually see? So with asthma, you're going to get a prolonged expiratory phase. And what happens is, and even your COPDers, so you may see them do the pursed lip breathing, trying to get that air out. And asthmatics trap air, right? So you're going to get you're going to get that faster initial stage and then a longer next stage. And that's why you get this. You get a different kind of picture where it's the shark fin kind of thing. And the more it looks like a shark fin, the more severe it is, because it's taking them longer to get that air out. They're trapping more and things like that. So, if you watch somebody as they work their through a treatment, as you watch somebody work their through a treatment, you want to watch their progression through all that to see how that affects the shape there. So one thing, what do you do? Sometimes you see people hyperventilating all the time too, right? And sometimes you're like, is this really asthma, or are they just breathing real fast and need to calm down, right? And especially sometimes you can't hear good breath sounds and things like that. One thing to think about is if you see somebody who's very tachypnic and you look and that end tidal shape is that nice regular square every time, you can rest assured that that's not asthma, okay? Because if they're in that degree of distress and they are and they have a normal looking end tidal, it is not their asthma that's flaring it up like that. Now again, back to the whole thing, it tells you that something's off, doesn't necessarily tell you what it is. It could be hyperventilating. I say you need to think about another cause. It could be hyperventilating. We see that a lot. Also, though, it could be some of those other things we talked about, renal failure, CHF, some other things like that. But, again, compare it with what's actually your patient's comorbidities. If you see a healthy 25-year-old, no other medical problems, they're breathing 30 times a minute, their end tidal CO2 just looks like the perfect box. Chances are they're hyperventilating, or, PE could be there, things like that. But that's how you can use the shape to kind of figure out what's going on. In those situations, they will still have low end tidal because they're breathing off so fast and everything. But you want to coach their breathing down using the number and watch for other mimics. And some of the mimics that we talked about, sepsis, PE, DKA we'll talk about. There's some cool things you can do with end tidal from DKA. The other thing is, so if you're watching on the other side of things, you're talking about looking for mimics, but if they're not responding to treatment, this also lets you start preparing. So if you get somebody in respiratory distress, you're stacking some nebs, maybe you give some solumedrol, they're starting to progress. You're like, this is what I see, then this is what I see. You know that chances, and you're still 25 minutes out from your destination facility. You probably need to start progressing to, the ship is sinking, what I say, and they're going to need something a little more aggressive, whether that be, BiPAP, whatever armamentation, or CPAP, whatever armamentation you have available to you. One cool thing I think we're looking at doing, anybody mobile integrated health in here? We're looking at, you can even use these kind of things for home. You guys all know this. How many of you guys have an address you hear go out, it's going to be a breather at the same address, 3 or 4 times a week? What we're looking at from a mobile integrated health standpoint is going out there and saying, okay, this patient's getting discharged from the hospital for the 3rd time this month. Our MIH provider can go see them in the hospital and say, okay, let's see what their end tidal waveform looks like. What's their number on hospital discharge? Then they can say, okay, I'm going to go out there in 48 hours, do the same thing, and you can get a pretty good feel for, are they heading the right way or not? The other thing we're going to pair it with, and this is not a different topic for a different day, but there's a thing called auscultation mapping that's starting to become big. And basically, you hold a cell phone up to certain parts of their lungs and send it off to an AI kind of text thing, and it will actually give you results that are about 95% correlate with pulmonary function tests. So you can go out there, get an end tidal CO2 thing, get that auscultation mapping, and predict basically if they're going to get readmitted anytime soon. And so the whole goal is to keep some of our breathers out of the hospital. They don't want to, some of them are going to call no matter what. Some of them, though, desperately don't want to be in the hospital and wait till the last minute, and stuff like that too. So if you can do things like that, say, okay, they're starting to head the wrong direction. Let's look at their meds, maybe put them on a course of oral steroids for a few days, interventions like that. So this is a way you can use a cheap, non-invasive thing like end tidal actually to keep somebody out of the hospital, which is obviously a benefit. Like I talked about, a lot of the end tidal stuff is very sensitive but not specific. But the general rule of thumb is, the sweet spots are between 45 and 30. So if it's above 40, I say, that's why I got the Dumb and Dumber guys on there. Like, I always like to dumb it down. If they're over 45, you should be a little worried. If they're under 29, you should be worried too. They're starting to get very sick, one or the other. And so that's, that's a good rule of thumb. But as far as specific conditions, pulmonary embolus, we talked about this again. This is a restriction of blood flow to the lungs. So you're gonna see some changes. Your shape is actually going to be pretty much the same. You're going to see this nice box, nothing weird, no shark fins usually or anything like that. But say they have a PE, and I've never caught one like mid-in tidal like this or anything, but all of a sudden they're going along like this and boom, there's an acute drop. You would definitely have to worry about a PE in that situation. But this is where I think it gets cool. And again, this is one where it's more the number than the shape. So they're saying, can you exclude a pulmonary embolus just based on an end-tidal CO2? So if you have a certain end-tidal CO2 number, can you say there is no PE there? And the answer is yes. So they're saying that if an end-tidal is above 34, there is no PE. How nice is that? How many of you guys knew that? So if you got somebody you think might have a PE, you pop them on end-tidal and it is 40, there's no PE there, 100% sensitive. Done. You've got it off your thing you have to worry about. And that's what I'm talking about, where I'm saying it's cool that you can, some of these things can really help you work your way through your differential diagnosis. You get somebody, you're like, I don't know, maybe it's PE, maybe it's pneumonia, maybe it's CHF. You put them on there, end-tidal's 40. All right, PE's already off the radar. Pretty cool, right? And I mean, again, 100% sensitive. It beat out some of the scoring systems that we do in the ER to look at PE, things like that. So, I think that's interesting. It can also tell you severity. So without having to go through all this, basically, if end-tidal is less than 20 in the presence of a PE, these are also people who are going to get very, very sick. So they are going to be the ones that have to go to the vascular lab to get like catheter thrombolysis or some of those more aggressive procedures that they're doing and things like that. So not only can you rule it out on one end, but if it's really low and they have a PE on the other end, they're going to need some aggressive intervention. So that's kind of cool on that end, I think, as well. Obviously, you're not going to have a definitive diagnosis of PE a lot of times handed to you before you take them in. But think about even like, say you're out here at, Norton King's Daughters, is what you guys call it now? Norton King's Daughters. And you're transferring down to, Norton downtown to go to the vascular lab. And you show up for a known PE and their end-tidal is like 12. You're going to be a lot more worried about that patient between here and there than you are somebody whose end-tidal is 25, 30, something like that. So again, it can tell you a lot about what you're doing. So again, over 34, no PE, less than 20, you're worried about it. What about dialysis? How many of you guys pick up people who, like a sick dialysis patient, and they're hypotensive down in the 80s, and you're like, man, can I give them fluids? You're always worried about giving fluids to a dialysis patient, right? Because they're going to hold on to it. What about if you could use end-tidal to decide that? Be pretty nice, right? So same thing, dialysis patient, hypotensive in the 80s, you put the end-tidal on them and it's 35. They're in pretty good shape right now. They don't acutely need dialysis. So you probably give them a little fluid. They can probably handle a little bit. I'm a big fan of like little small boluses, 250 reassess, 250 reassess, but if they're not acidotic like that, right then and there, that they can probably handle a little bit of fluid. Conversely, if you put the end-tidal on them and it's 15 or 20, they're pretty sick and they're probably, they probably miss dialysis for a few days. They're probably fluid overloaded, so I'd go do other interventions. If it's real low, 5, 10, something like that, I'd be like, okay, I probably need to be prepared that their potassium is going to be 8.5, and things like that. So, get ready to treat for hyperkalemia and things like that. So again, you can get very clinical answers to questions very simply with end-tidal. So you start to see why I like it. I know it sounds dirty, but like you're putting these prongs in there that tell you all this information, and there's nothing else you can do in medicine that I think is so easy, cheap, non-invasive that gets this kind of information that can very quickly rule in and out pretty serious things and guide what you're doing. Sepsis is a big one. The hospitals are sepsising you to death, right? Everybody's got their protocols of, 30 per kilo of fluids and antibiotics as soon as you come through the door. I'll just go on my soapbox. Like, we all realize like 10 years from now, we'll be bitching that none of our antibiotics work because we gave everybody like Vanc and Zosyn as soon as they came through the hospital doors, no matter what was going on. That's neither here nor there. But when you do entitle, you can have a better feel for if they're septic and truly need that. We're starting to see some, and the reason I talk about that is we're starting to see some antibiotic protocols come out in the field. There are some services. Any of you guys giving antibiotics pre-hospital? Yeah, say we do see, yeah, we're seeing some. And I'm not against it. I just want to make sure that we, are using good criteria to decide when to pull the trigger or not. Like in a lot of ERs, if you have a 70-year-old with a UTI that has a fever of 101 and a white count of 11, they're advocating for these big gun antibiotics, and that probably isn't necessary. But if you don't, you become an outlier. The hospital gets done. You get a nasty gram from your sepsis committee and things like that. The better your times look, the more happier everybody is. So you're going to see this moving out into the pre-hospital field more and more because you guys can get fluids. No reason why we can't give antibiotics. And I'm for that, and the sickest ones are the ones that truly need it. And so anything we can do to identify those higher risk patients is worth its weight in gold. And again, entitled can do that. So, a lot of these folks, not to get into acid-base, but what happens in sepsis? Sepsis, you get metabolic acidosis, right? You're not getting good blood flow to the tissues during sepsis. So you get lactic acid that builds up. Just like if you're on a treadmill and your legs start getting sore when you're going too far. Same sort of deal. So you're getting a buildup of lactic acidosis. When you don't get enough, and then also when you have that sepsis, where you get the vasodilation, low blood pressure, you get poor tissue perfusion. You're not getting enough blood flow to your tissues. And in turn, you don't get good blood flow back to your lungs. And again, when that happens, you get a low end-tidal CO2. So sepsis, low end-tidal CO2. There's a thing called, anybody familiar with the Q-SOFA score? Yeah, it's basically, again, diagnosing a real quick, easy way to diagnose if they're at risk of sepsis. So you have three things: hypotension, altered mental status, and elevated respiratory rate. If they have two DCS less than 15, breathing more than 22 times a minute, or blood pressure less than 100. If you have either two or three of those, pretty sensitive for sepsis. Thing is, like tachypnea, I don't know where that spelling of tachypnea went, by the way. That's like extra vowels in there, but whatever. But like respiratory rate, I think that one's not a very real sensitive one sometimes. Altered mental status, what if you're picking somebody up for a nursing home? You don't know what their baseline is, so this isn't always as easy as it looks. But how about this? If you have an end-tidal less than 25, it's more sensitive than all that anyway. So instead of worrying about anything like that, you pop them on end-tidal CO2, you got your answer. They're at high risk of sepsis if they're less than 25. And if they're less than 25, that correlates very highly with a lactic greater than 4. And that's a big deal. Lactic greater than 4 is kind of the trigger at all the hospitals to pull out all the stops. They get they definitely get the fluids, they get the early antibiotics, they get the aggressive monitoring. Everybody has these protocols now when a lactic's over 4, where you're more aggressive. So right then and there, you can screen for the ones that truly need early antibiotics and things like that. So, if you pick up somebody who has a fever of 103, you put them on their end-tidals 20. Yeah, absolutely. Feel free to give them the fluids and antibiotics and start that process. DKA. I think this is one of my favorites as well. We all deal with DKA all the time, but how many times have you guys picked somebody up, blood sugar is critical high, and they're looking at you and don't look too bad? Are they in DKA, or are they just somebody who hasn't taken their insulin for a long time? And you really don't know that until you do blood work, right? I mean, sometimes with your 2 DKAs, they'll be breathing fast, have the fruity breath, all the classic things we're looking for. But, I think some places tend to call everything DKA that's, really hyperglycemic, and we know every single day I see people with blood sugars in the thousands that are fine. Well, how about this? If your Accu-Check's high and your end-tidal is greater than 35, again, rule out DKA. So again, you pop somebody on there and their end-tidal is greater than 35, they don't have a PE, they're not in DKA. You've already ruled out 2 of the big things. But so your Accu-Check's high, end-tidal greater than 35, you're not in DKA. Done. Don't have to think about anything else, don't have to do anything else. On the other side of things, if their end tidal is less than 21, 100% chance, 100% sensitive that they're in DKA. So right there, using end tidal, because we'll get them, they'll bring somebody back. I do it all the time in the ER. They'll bring somebody back to me and they're like, man, this guy blood sugar, right, critical high on the meter out there, triage. We need to get him back. I think he's in DKA. And I always be like, well, put him on end tidal. And they always look at me like I'm crazy, like, why in the hell would we put him on end tidal? Exactly that, because in about 10 seconds, I can tell you how worried we should be or not. And if I do see this and pop them on there and their end tidal is 15, I can say, all right, go ahead and start working on an ICU bed, because that's where they're going. Because almost all DKAs have to go there just from the frequency of monitoring things. So right there, within 10 seconds of arrival, you can start working on a bed and things like that. Even if it's less than 26, 90% chance that they're in DKA. So pretty high risk too, even at that level. So again, as soon as you get a diabetic, pop them on there. They can tell you exactly what's going on, how sick they're going to be, and things like that. I'll stop there real quick. Any questions on us where I'm going? Does that make sense? Yeah.
Well, I have a question.
Yeah.
For DKA, a lot of people are not always one way or the other. Sometimes they're a roller coaster effect.
The roller coaster effect, yeah. And that's one thing that is a challenge is in certain cases, early sepsis for one. Sometimes early sepsis, you'll actually start out on the high side and then trend through normal all the way to low. So it's one of those where like a DKA person, if they're low, you're done, you know it's there. If they're high, you can't rule it out. So they may be somewhere on that continuum. Somebody's bouncing back. You're exactly right. So what I'm saying is if it's over 30, you're still going to be low if there's any kind of DKA, but maybe not all the way down there. So like when I showed you, so say their end tidal's 32, then this probably goes down to coin flip if they're in DKA. They still may well be in it, but you can't definitively say it. So it's kind of the whole thing of like this will help rule in or rule out some things. There's still some gray area, in those middle numbers sometimes, and that's where the challenge is. But on the flip side, sometimes it's still awful nice to pop that up there and hopefully start crossing things off the differential list based on your values. Yep, it's a great question. Any other questions? Here's another study, predictive value of DKA. So basically, anything greater than 24, they say here, allow the exclusion of DKA in the ER. So again, you can even go lower. So there's all these studies out there that are helping you diagnose these things. This is a big one for me. How many of you guys use end tidal in your trauma patients or think about it? Good. A lot of times we don't, and like even down at U of L, that's our only level 1 in the area, right? I never hear them looking at tidal. And we'll talk about where a tidal can be really beneficial there too. But again, we talked about you have to breathe, but you also have to get blood back to your lungs. So what happens in trauma? You don't get blood back to your lungs because you're not perfusing, right? And so if your other organs aren't perfused, neither are your lungs. So if you've got a bleeding spleen, if you've got some sort of stab wound that's bleeding in the lungs, things like that, you're going to get a low end tidal. The other thing I say is it not only can be used to monitor your resuscitation, but it can help you decide where to go. So like I think one of the toughest things, and correct me if I'm wrong, but one of the toughest things you run into every, day in, day out is when you go on the patient that you're like, there's some that are no-brainers, like I need to fly this one or go to the trauma center. But there's some of those that are kind of in that gray area where like, do I call a helicopter? Do I just need to go to the closest facility? Things like that. You always get armchair quarterbacked after the fact, right? If you take them to a trauma center and they get a man scan, there's nothing wrong with them. You're like, shit, did I really need to go there? On the flip side, if you go to your local place and they have like 15 atrocious injuries, you're getting an asterogram the next day, right? Why'd you bring this patient here? They always have the benefit of that hindsight. Well, end tidal is one way you can help make that decision and help justify your decision after the fact and say, hey, they had a hell of a traumatic mechanism. I was worried about internal injuries. Their end tidal was 15, which told me something was going on. So I felt like I needed to be more aggressive with that patient. Real hard for somebody to second guess you on a decision like that when you use that justification. Like if I'm your medical director and somebody calls and complains, I'm loving it because I'm like, well, here we go. Let me educate you right back, because my crews did what they were supposed to. Whole blood. is a big thing. If you ever hear me talk and I don't mention whole blood, you probably are at the wrong lecture because I managed to work that in every time I talk. I'm a big believer in whole blood, air and at the ground level. I believe in 10 years or so, it's essentially going to be the standard of care with the caveat of it's going to be hard to get enough blood product out there where everybody can use it. We have 4 systems in Indiana that are using it right now. All 4 have had some really, really good saves with it. When I talk about system ground-based EMS systems that are using it, a lot of our flight ones are. One of the big challenges, the first thing we hear is the trauma centers get worried, right? You're going to take all our blood supply, things like that. The biggest thing that can happen to threaten these programs is some indiscriminate use of blood pre-hospital. So if you if you have a trauma patient, maybe you get one wonky blood pressure, you give whole blood, they get there and the patient looks fine. Trauma surgeons are going to throw a fit. They're going to, they can torpedo a whole program. One of our 4 had that happen with their very first one. They had a good mechanism, but they had like one blood pressure that was low. And then the patient, when the time they arrive at the ERs, smiling and waving at everybody, I think they probably vagaled or something like that, and everything was fine. Trauma surgeons who are a little bit wonky on giving it in the first place through a fit almost canceled their whole program. So if you can find other parameters to use when you're deciding whether to give blood or not, mechanism, hypotension, I agree with both those, but it's nice to have a third confirmatory, right? Some places I know can do blood, so obviously a low H&H is, gold, but, that takes a little time and things like that, especially in your other transfers. So if you find some other sort of third parameter to use to decide in your protocols, okay, this is a patient who gets blood, you're going to have much more sensitivity for using it in the appropriate situation. Well, what do you think that third parameter should be in my eyes? Entitled. It's very easy, it's right there, it's cheap, right in front of you, and it's quick. So, in low entitle in a trauma patient predicts severity of tissue injury. So if you have a low entitle, you are not perfusing somewhere in your body in a trauma patient. It predicts impending shock, and again, it can guide your blood transfusions. One of the first things, so in low entitle pre-hospital, the lower it is, the worse outcomes they have in the hospital. So you've already got immediate justification for using that in your protocols. One of the things that happens in U of L, if I get a bad trauma patient, bleeding spleen, broken ribs, flail chest, whatever, the whole spectrum of things that you see. One of the first things trauma surgery says is, let's get an ABG because I want to see what the base deficit is. And the base deficit is the same thing as basically saying this patient is under resuscitated. So if they have a high base deficit, when I say high, it's a very negative base deficit. They are going to need more resuscitation. They will enact like the mass transfusion protocol and things like that. Well, guess what correlates perfectly with a very negative base deficit? Entitled. They're one and the same. So you can get that same number without doing an ABG in about 10 seconds. And if it is low, it correlates literally 100% of the time with a base deficit that would indicate blood transfusions and things like that. So again, as you guys are starting to see these out in the field, add that to your protocols because that just gives you one more thing to say to justify utilizing blood and things like that, justify your destination decisions, things like that. So I know we don't classically think about it in trauma, but it is very, very valuable. Overdose patients, or if you're, say you give somebody some pain medicine and you've got a 85-year-old that weighs 90 pounds with a hip fracture that's in misery, and you gave him a big dose of fentanyl, and you're like, I feel like I got to address their pain, but I'm also a little bit afraid that, Nana's going to quit breathing. This is a great way to watch that. You watch you will see, it'll look like this, or maybe even this, actually. If they're in a lot of pain, they'll probably be hyperventilating. As they slow down, longer and wider, and then eventually you'll see that. And if you see that, you're going to see that waveform about 2 minutes before your sats start to drop. So again, if you're watching closely, you can already, maybe readjust their airway, put a nasopharyngeal in. Sometimes that's all they need, get that tongue off the back of their mouth. Crank up their supplemental oxygen if they're on it. The minute you see that, you need to intervene, and it'll save you them ever getting hypoxia. If you see that, then say you got an overdose patient and you see that gradual hypoventilation pattern, they start to get more somnolent, that's time to maybe hit them with another dose of Narcan. Or say, hey, they may not wake up. I mean, think about intubation or something like that. Out of hospital cardiac arrest. This is obviously probably this is the one where I truly think Entitle is absolutely the standard of care. On some of those other things I talked about, yeah, it's cool. You can get a lot of great information. It can help you with your dispo. This one should really be one of the main forces that guides everything you do. So every full arrest should immediately be on Entitle. That should be one of your reflex actions, Entitle, along with everything else. And you don't see that a lot. I still have to ask for it in every cardiac arrest where I work. I really do. I have to say, hey, let's get them on Entitle, every single time. I'm not saying it never happens, but most of the time it won't unless I ask for it. Sometimes it's already there, but you need to make sure. So say you're pounding along doing CPR, and all of a sudden you see a waveform that looks like this. Exactly. It's that simple. If the other thing, when I say anytime you hear me talk, you'll hear me talking about whole blood pressures or whole blood. The other thing you'll hear me mention almost every lecture is I despise stopping CPR in a full arrest. If you watch any full arrest, you will be amazed at how much time no CPR is happening. And if you pay attention to detail and don't stop, you will immediately see an improvement in your ROSC rates. Absolutely. And this is why it's a big deal. Do you know what kind of blood pressure you have to have in your coronary arteries to have any chance of ROSC? You have to get to a blood pressure of about 20. Okay, not real high, but it takes 2 minutes of CPR to prime that pump to develop a blood pressure of 20. 2 minutes. If you stop, it takes 10 seconds to go back to zero. What do a lot of places do in every full arrest? They stop and do a pulse check every, 3 to 5 minutes? You guys still see that in a lot of places? Well, there's still a lot to do that I see that they will stop and do a pulse check every 5 minutes. All right, 5 minutes, time for a pulse check. Number one, I'll show you, I'll see if I don't think I have it with me, but if you look at actually your good old ACLS card, there's actually nowhere on there that says do a pulse check. That is not in there. It's a rhythm check. So if you're going to do anything and stop, you should come off real quick and say, are they in a shockable rhythm or not? That's really what you care about. As far as if you're worried about the termination of a pulse, you got everything you need right here. There is absolutely no need to check for a pulse if you've got Entitle on. No need. If their Entitle is 9, they don't have a pulse. They really don't. And so that's a big deal to me. Who knows the accuracy of a pulse check? It's about 50%. 50% in this day and age, especially as as a society, we're getting a little fluffier and things. It's harder to check and get an accurate pulse. 4 out of 10 times you think there isn't a pulse when there is, and you continue CPR. I'm not gonna say it's not a big deal. That's not a huge problem. There's some physiologic things where it's obviously not ideal, but it's not devastating to the patient. 1 out of 10 times you think there is a pulse when there isn't. You're either feeling your own or something like that. I mean, honestly, that's devastating to the patient. 1 out of 10 times you stop CPR when they needed it, that's game over. So you're talking about, number one, you're stopping every 5 minutes to do a pulse check, which is a test that has a coin flip accuracy. When you've got something that is, 90+% accuracy right there at your fingertips. So that's one reason I hate it. Every place they study pulse checks in major centers. How long do you think the average pulse check takes in a major academic center? The last 2 studies I saw were 22 seconds and 27 seconds. It's a lot longer than you think. So, you're stopping CPR for almost half a minute when it's probably not even accurate in the first place, and you don't really need to. So that's something I always preach about when you have an easy, non-invasive, cheap way to see it right in front of you. What about if you see something like this during full arrest? And you're probably going to have a little smaller amplitude. It's just hard to develop to get a big block from good CPR. But what if you see that?
Rearresting,
Could be rearresting, yep.
two problem.
2 problem. The other one, good. The other one, CPR fatigue. Person get tired. You got somebody on there pumping for 2 minutes, they're starting to get tired. So especially if you see, pretty uniform and then they just start to trickle down, that can tell you right there, it's maybe time to change compressors. So you can get even information on quality of CPR from that. Yeah, and you should, if you do see that, the big thing I said is you should start sweating because you know something's wrong. When you see that something has changed, it's a great point where either tube's gotten dislodged, they've rearrested, your compressor's getting tired, something like that. If you see a nice uniform waveform that starts to get less and less and less, something has changed that you need to be aware of. If you've stopped CPR and you see that, then yeah, you need to get ready that they've rearrested again, get your meds out, get ready to rock because something's going wrong again. So check your entitles or check your ET tubes. You guys check how many guys intubate in the field? You use the entitle to check your placement? Good. That's another one that has not really gained widespread acceptance in a lot of the ERs. I have to, I'll be like, hey, can we get them on entitle so we can verify tube? And they're always like, well, you saw it on the glide scope or, the detector changed. And I'm like, yeah, there's still some ways that can go wrong. So this is it right there. Again, foolproof way to be sure. So that's what it looks like, right? You get a pretty nice, nice uniform waveform, especially early. You'll just see little tiny humps because you'll still get a little entitled CO2 just out from their stomach from air that's been in there from either, bagging or something like that. But it's not going to be that nice square because you don't have those expiratory stages and things like that you do, with a normal breath. So, what about this one?
Spontaneous breathing.
Innovative taking breath.
Exactly. So say you paralyze somebody and they're starting to come out a little bit, and they're breathing over their paralytic. So their paralytic's starting to wear off. So say you see this. So say how many guys are RSI out in the field? So say you RSI somebody, you see this pattern and, you gave them, what do you guys use? Like, what do you use? Ketamine or what's your induction agent? First aid ketamine. Either one of those. So, and do you use rock or suds? Rock. So, rock will last a good hour, right? How long do you, depending on what dose you gave, ketamine or Versed doesn't last that long a lot of times, right? So say you RSI'd somebody and you start seeing this, you need to get some sedation meds on board too, to make sure that they are not paralyzed but not sedated because they're starting to come out of it. So you need to make sure that they're sedated because you can reasonably assume that you're needing some sedation meds. If you are super into capnography, like if this is, this is my jam, this is really interesting. There's a book called Capnography, More Than Just Numbers. Really good book. And it'll explain, go way in depth on each one of these individually. It's pretty good. So, and it's not crazy long and crazy in depth. So I really recommend that one if you're into it, because you'll rapidly become an expert in it. And again, I would say it's kind of nerdy why I like it. For guys who don't know, it's Revenge of the Nerds. That was like my favorite movie growing up. But, I didn't realize now how inappropriate the movie is. I showed it to my kids and I was like, oh my gosh, there's full frontal nudity and everything. I'm like, oh, out of the year here. So, but anyway, it's nerdy to entitled, but you can get so much information on so many different things, rule things in and out quickly, easily, and cheaply. And that's the one thing I always say is the true measure of what a great test is it's cheap, it's versatile, it's non-invasive. And all these things I've just been babbling for an hour about. I mean, think about all the big diagnoses, big bad diagnoses we covered. We did cardiac arrest, DKA, PEs, sepsis, all those things. And we have ways to rule them in and out on just a thing that's looks just like a nasal cannula, right? Cheap, easy, quick. I mean, that's why I think this is a great test to use, to have, to understand what it's telling you and things like that. And again, there's certain, hard, fast rules that I told you, but the main thing is just get used to using it every time, interpreting it the same way every time, and then framing it with what the clinical situation looks like. And you can make some really valid inferences from that. So that's why I think it's great. So, any questions or anything I can tell you? That makes sense? Feel like you'll have some new tools to do in title? You kind of look like a wizard, right? Like if you come in and you say, yeah, I've already ruled out pulmonary embolus in this patient. And the ER's gonna be like, you're full of shit. And you're like, oh no, here, let me show you this study that shows that, you're good. There's good ways to do it. I do think our pre-hospital understanding of title is quite a bit ahead. So you may get some funny looks when you roll into place and start spouting some of that off, but that's good. The more you can educate your local partners, the better. Any other questions? I like to get out and about. I am not an office guy. I'm already down here. So please reach out to me as far as like coming and talking at your in-services. You just want me to stop by your station, talk to your mess, things like that. I do like to get out and about. My job is to advocate for you guys all across the state, whether it be in Indianapolis, the legislature, rules, anything I can do. If I don't know what's going on out there, I can't do that effectively. I know what I think is important, but that doesn't always correlate with what's really going on in boots on the ground. I see in my few shifts what happens, but that's not always accurate. I need to know and hear from you guys what you're encountering and what I can do to help. And so by getting out there and hearing firsthand, I want when you call me and say, hey, I've got a problem, I want to picture you, your service area, and things like that. And I also think on the flip side, when I come out there, like some of you who are here today, if you had a problem a month ago, would you ever email me and say like, I got this going on if I'm somebody you've never seen before? Probably not going to, right? But like say after hearing me, knowing that I'm, pretty laid back, that if you have a problem a week from now, probably a little more comfortable using that email and get in touch with me, right? And that's what I want. That's what I want to be visible out there where you guys can see me, comfortable, let me know what's going on out there because that helps me be effective on what I need to do for you all. So reach out anytime. Last shameless plug, we do have a state in-service every month. So if any of you want to join that, shoot me an email. I have a master distribution list. I send out a reminder and a link and stuff like that. I don't always advertise it real crazily otherwise. I'm not the most, as you can tell, I'm not the most technologically advanced guy out there. And we had a county meeting that got sabotaged where they actually took over the meeting and started showing porn. And so I'm always like deathly afraid that like they're going to take over my state in-service and I won't know how to like turn it off or anything. So that's why I don't always advertise it anywhere. But if you want the link or to be added, let me know. We start out usually with like 5 or 10 minutes of just general housekeeping stuff. Hey, this conference is coming up. Here's what's going on at the state level. Or, and then also really important, we do provider of the month recognitions. So if you have somebody that goes above and beyond, and like a lot of times people are sending me like hero stuff, which is cool. Don't get me wrong. They'll be like, oh, this guy was hanging off a cliff and he darted a chest, Those are cool, great. I'm happy to, but it can be very, very simple. It can be this person is always a positive influence around the station, always willing to pick up and help, looking out for others. That is every bit just as important to me. So, and I never get as many nominations as I want. So please, please, please send me those. I want you guys to get recognition for what you're doing out there. I always say the backslap to butt chewing ratio is way off in EMS, right? You get yelled at about 20 times for every one time somebody says something good and positive to you. And we really want to recognize you for that. So that's there. And usually somebody talks for about 30, 40 minutes about a different topic that's relevant, and then Q&A at the end. All you have to do is put your PSID number into the chat and it gets loaded to a cadus for you too. So real easy way to get CME or CEUs. It's always the first Wednesday of the month at noon. So the only one that'll be different is January because I think that's New Year's Day or something. So I figured that's probably not the greatest time to have y'all out there. So questions, comments, concerns, anything like that? Thank you. I appreciate you.
Dr. Yazel, it's awesome you came. It's what's really great is because he does know EMS, as you've heard through some of his things, he can relate. And it's nice to have physicians come and talk to us instead of at us. So thank you for your time. Thanks for coming down. Thanks for considering the inactive status for old paramedics. All right. So we are going to sign in. So
That's my error, everybody.
Matt is going to set up something here real quick, and I know what my glider feels like, and I know yours too. So super quick, because we're gonna go right into our next presentation, a fantastic person from Gallatin, Kentucky. So please just take 2 or 3 minutes, run to the restroom, run right back. We're gonna have these things set up, and we'll be ready to go.
Oh, real quick, for your Kentucky folks, more than welcome to join. It's an Indiana in service. We love Kentucky folks on there too, so jump on there. And you can send any kind of like verification you need for your CEUs.
Actually, I'm kind of irritated. No, because as a paramedic student, you miss brief. This student, very beneficial for you.
He shows up.
Yeah, I want to see Nick who come down there. Talk to your clients.
So this is the QR code to sign in, please. Hey, Matt. So after they have scanned it, what is the next step? Because there's lots of things. So where do they go after they scan it?
It should just pop up, you'll just fill out a blank, whatever line on there, and then do the eval.
No, it's not working.
So you can't click in 5 minutes.
Yeah, I had my own set. It says 7:30. What did I do?
By the time he was. I didn't. By the time I got to the
Come on.
like, well. This is where it takes you.
Yeah, it's not letting anybody edit.
Looks like you have to get an app to.
Yeah, like if you go to Culver and be like, hey,
Shouldn't.
if you don't want to be gay because of this, he's gonna be like, you're stupid.
Talks about it and has my stuff.
You?
It's like, already stressed. Yeah. Yeah.
It's not even way for
He was
Yeah.
well, I don't carry a lot. And I don't have that. Well, the operations BC has a monitor, but his is next up for repair because the attack was. So like, I didn't know that, so he's getting.
Harder than.
I draw sometimes things. Street that thing
All right, now somebody try it. There's another button that there was not buttoning.
Was he using the capno trauma? Is that taking consideration compensating patients?
So usually if it's low, that means they're.
Same thing.
Okay.
Sometimes you can see, the thing with it is sometimes you will see that though before they show it. with hypotension. Right.
Other vials.
Right, so.
What they typically use.
Right, so you'll see that entitled will start, like, especially if you start training, like, say you have Scott, we have a, 25-minute transport down to U of L, they start out at, 30, and then they're 25, 20, somewhere, so that's where it's, so some of them will compensate just fine. So it's one of those, if the rule's in, it doesn't rule out, So if you got-
And the second part of that would be patients that with high levels of pain,
Mhm.
altering their breathing to compensate for that. Is that, you have to pair that with other parameters.
Yeah, it can throw that off a little bit. Now, it may cause them to get a little lower on their entitle, especially if that's what's going up. So, yeah, always tough, but you're exactly right. Like somebody's.
That was my two things, was like kind of, my two kind of caveats.
Yeah.
If those two would affect that using as a true diagnostic. Okay, fair enough. That's all. I'm going to talk to Nick when I get back to see if your schedule and our schedule can align, and you can come in and maybe go in a little further detail with our paramedic class over the entitle.
This one, like, I didn't need to do, something you could do, actually, almost for an individual condition. So, you know, I was like, gosh, I don't know if it's applicable, it's like, I don't know what's in and out and stuff like that. But I want you to work it all, how to reach all the way. That was on board, actually, I got 10. They want to do it, but they, you know, like, every time I see Miller, he's always like, you gotta sit down. I'm like, no, no.
And that makes me worried, you said somebody giving a wrong.
Scan that QR
I
code.
see a few of our providers that would be too.
Hard rate,
So if you open up your photos,
he didn't want to.
and then just put it up there, and then actually like hit the button.
Not bad, but one, low indication usage, you throw shit, good, and try to. So let's.
Point it up there.
You know, there's a big study that came out to show that you do it through hospital, it uses less blood. That destination.
I had it.
So that's been a nice one to be able to do it. So we get when you upstream, you know, shift it.
Hey, Matt, will you come up here, please?
You're only doing 3.
Matt Spicer is like the unsung hero of this entire
Yeah,
thing.
I want to try to get you in.
So what he's gonna do,
Classes meet 8 hours. I know you don't.
he's gonna explain how this QR code stuff
He's in
works.
the program, and I was like, the first thing is gonna piss at you.
And I think you have to do it for each speaker.
Yes.
So you do have to do it for each speaker, and please send, fill out the eval.
Like I said, I think it's slides, but there's not shit on there.
Oh, yeah, you just use it as the, what the lead into your next topic. And that's.
And Jennifer Dicko is not liking this at all.
No.
Yeah.
Can you tell by her face?
Well, this is actually his recommendation from last year, like, hey, can we do one of those QR
I
codes?
wanna get with you.
Paper, you know,
I wanna
just
try
say
to-
that.
Amanda got it, so.
But you get yours.
Yes, I do.
Yeah, put me in. I'm not that long.
Kyle,
Yeah.
Yeah.
Hey, John. How you doing, buddy? Okay.
I am.
Matt told me that's what they were getting paid for.
God's sakes, no, I'm getting, sit there and have good hair.
Are you gonna,
I don't know, I'm gonna find a hole and put it in. One or two things happen. See, I try to keep.
I know, right?
Right there.
That's what happens, buddy.
Certification number,
They said they were.
all that stuff.
They sent Leader on Zoom to get that administration done.
All right,
Stay behind me.
oh, don't stand behind me.
It is, because everybody's typing on it, it's like messing me up. Shut up. How do I type? Let me type.
Let's do it for him.
We will have these available, yes.
How do I
And also they're buying it for like $700. Selling it for
All right, so to keep somewhat on schedule, in between, we will be able to put these back up because there's a lot of confusion, and including myself, how to do this, how to fill it out. This is supposed to be the better way besides paper and passing it around, which it, all right, I prefer paper and passing it around. So
I will do that for next year, everyone, I'm sorry.
we will work in between to answer questions, and we can pop these back up. In the meanwhile, Matt, if you'll get this next thing started, or do you know how to do it?
I don't know how to do it.
What are you getting paid for?
I'm not getting paid.
Oh, yeah, okay, fine.
I'm $3.99 today.
All right.
That's your,
Hey, Matt, open up her presentation.
we got too many monitors.
All right.
which
So-
one did you plug into?
Our next presenter, and we're A couple of minutes behind, but that's all right, because we may have to adjust lunchtime a little bit to keep on the schedule, because we want to be respectful to your time, and we want to give the presenters their time. So our next presenter comes from Gallatin, Kentucky, where she is a training paramedic person for the state of Kentucky and also for Gallatin County. So this is going to be another very fantastic lecture. There's some things we just don't think about. And what about that end title presentation? There were some things that I just didn't know. We were talking outside, it's like, I thought there was a correlation between PEs and this, but all that. But when you see a very definitive, black and white, no questions, here's your numbers. I started taking some little notes because there's some aha moments. I grossly underutilized end title, as I'm sure most of us have. And this isn't in-hospital doctor stuff. This is our stuff. If you have this plus a black and white number, here you go. So that was just very fantastic. I expect nothing less from the eyes, the window to the soul. That's going to tell you some things, and there might be some things that pop in your mind immediately whenever you look at somebody's eyes, some things that you can and can't tell. So.
Technical difficulties. Keep talking. You're doing great.
No, you're good. I just have to change the view.
All right. So Callie Fox. Huh? I was going to talk.
So Matt's trying to fix that. Gave me a great introduction. I'm sorry if you're in the back. I'm not a very loud speaker, but I will try.
Will you please do so? Our speakers, we
And
need you
for
to pick up
the digital people.
for those out there in the world.
So my name's Callie. I'm full-time with Gallatin County EMS. I'm also their training coordinator, like he mentioned. I kind of got that by default because I'm the only full-time paramedic there that's also an instructor. In my spare time, I'm also a deputy coroner, so that's exciting. I've only been a paramedic for like 2.5 years, so still new on this side of it, still trying to find my footing in being the one in charge, right? Before that, I was an EMT for about 7 years. So I'm not a baby in EMS. Kayla, she had asked me, however many months ago it was, would you want to come talk? And I was like, I don't do that. I teach my shift. We kind of have open discussions. Talking in front of a big group of people is not my thing. So as this goes on, open discussion. If you have questions, comments, concerns, it's just us talking, right? But when she asked me about speaking, I didn't have a clue what I wanted to talk about. And about that same time, I was blessed or cursed, however you look at it, with 2 brand new EMTs on my shift. One had come from AMR, did not work 911 at all. The other one literally got his numbers and started working for us. It was a trauma run, and we were talking about their pupils. I was like, did you guys notice anything with their pupils? And they said, I don't really know what I'm looking for. I know I'm supposed to look, but what am I even looking at? I know if something's bad, if their eye's gone, right, from a head injury, but what exactly am I looking at? And I kind of started thinking, 9 years ago, almost 10 years ago when I went through EMT class, and even through paramedic class, there's really no emphasis on checking eyes. They tell you, this might happen, see if they're equal, round, reactive, and they carry on, right? It's kind of a brief thing. So I'm not an ophthalmologist. If you are welcome to come up here and talk for me. I kind of use this as an opportunity to teach myself something, because even I was like, yeah, I'm looking at their eyes, but why am I looking at their eyes? Why am I looking at their pupils? What goes on when one pupil dilates and the other one doesn't? So like I said, open discussion. If I don't know, we'll figure it out, right? So whenever they get this fixed, we'll carry on. Any questions so far?
Can you just switch to the next slide?
Yeah, there we go.
Sorry about that.
Thanks for finding the paper out. So,
Press on, floor is yours.
Are we good?
Yeah.
And we're gonna help you in the meanwhile.
So a real quick overview, I can't read that, I don't want my contacts. The anatomy of the eye, we know in ideal world, in utopia, we've all got two eyes, right? Obviously, sometimes you might not. They obviously both sit in orbital sockets. There's 6 muscles that are attached to the white part of your eye, the sclera, that control up, down, side, that kind of movement. The cornea is the clear protective layer on the outer portion of the eye. If you've ever had a corneal abrasion or tear, you know how painful that is. I empathize with you. The iris is the colored portion of the eye. It can obviously come in various colors. They can be 2 different colors, but it's utopia, so we're not talking about the eye of the ordinary people just yet. The iris also, I didn't even realize this, that the iris is what contains the muscles that are responsible for your pupils getting bigger and smaller. There's 2 of them. And the pupil allows light to enter the eye. Also, fun little fact, who's on the corner. So this vitreous body right here, kind of the bulk of your eyeball, contains vitreous fluid. That's one of the 3 fluids we pull post-mortem. Super freaky. You ever have the opportunity to see it done, and you're not squeamish with eyeballs, go watch it. It deflates like a balloon. It's really weird. So normal eyes, in adults, the people should be anywhere from 2 to 4 in bright light and 8 to 4 millimeters in dim light. Pupil size should change bilaterally. You shine the light into the left eye, the right eye should also change. They should be mirroring each other. And your sclera should be white. The cornea should be clear, non-cloudy. If you've been on a lot of DOA, you know that usually your eyes get cloudy. Both people should constrict if the eye is focused on a near object. So if you are standing in front of the stretcher, it's your patient, and you say, "Look at my nose," their pupils should constrict if you're close to them. And then hopefully we've all heard of pearl or perla. Are your pupils equal, round, reactive to light? And the accommodation part is, do they constrict when you're focused on an object close to you? Broke my clicker.
I didn't do anything. You're clicking.
You're clicking.
It's behind you.
Oh, 'cause I'm looking at
Don't look at that one.
Okay, well, that's weird. Anyways, so, yeah, eye dilation, the pupil expands as a result of less light. Like I mentioned earlier, there's 2 muscles that call it, they were really descriptive and they named these muscles. They're called the sphincter and the dilator muscle. Who would have thought, right? That wasn't me. So. Old news.
Perfect. You're set.
Okay, thank you. It's not something Gallup County unless it's broke. Okay. Sympathetic nervous system is responsible for the dilation of the iris dilator muscles. Again, something I didn't entirely realize is a lot of times when our eyes are dilated or constricted, it's the iris moving. It's in part the iris and the pupil, but a lot of times it's the iris that is moving. I should have put a picture in here. There's some thing called like inadequate iris, and it can literally make the color of your eye just fold in on itself. Freak me out. Don't ever look at it. So the muscle contracts, causing the iris to pull outwards, thus expanding the size of the pupil. So do we know what the sympathetic nervous system does?
The fight or flight.
Fight or flight. Okay.
Dilation.
So it's kind of like a stimulant, right? So what else do we see with the dilation of pupils? Like what other situation would we see somebody with dilated pupils?
Overdose.
Okay.
Opiate.
Meth, amphetamines. Yep, it's a stimulant, right? Stimulating that fight or flight. So like my dog, I don't know if dogs' eyes are the same, but when she gets scared, she gets really wide-eyed, and her pupils are really big, right, for fight or flight. I couldn't find a matching picture to the last one, and I have OCD, so I wasn't gonna go with a different one. But constriction is the opposite of what we just saw. Muscles in the iris are tightened, allowing less of the pupil to be visible. Less light is entering the iris, the parasympathetic response. So we know sympathetic is fight or flight, so what's parasympathetic? It's kind of your rest and digest, right, is what it's called. You can have constriction of pupils with your hypertension medications, opioids, organophosphate poisoning. So in the terms of an opioid overdose, you mentioned that, what else would we see outside of their pupils? If that's their rest and digest, what else are they gonna have? Probably slow respirations, right? Everything's slowing down. So anisocoria, if I'm saying that correctly, is unequal pupils. In this one, I'm speaking in terms of it's normal. Some people, 15 to 30% of people will have the physiologic anisocoria, whether that be induced by you were born with it, medications, a previous eye injury. This is where getting a history on your patients is huge. You go to a fall and you see this, holy crap, right? But then the wife is like, no, it's normal. Your eyes always look like that. Okay. So it also could be caused by trauma, brain aneurysm, tumors. Some migraines can cause this intermittently. Migraines won't necessarily cause it to happen for the duration of the migraine, but it can happen. So a blown pupil is basically what we just talked about. But does it respond to light is going to be your biggest definitive. If that patient that fell that had the anisocoria that they've had for 30 years, that pupil's probably still going to respond to the light. And a blown pupil, like we're used to in EMS, it's not really going to. It's not going to respond to light. It's often a late sign of damage to the brain. Meatball's not going to fall and our pupil's going to blow. Your blown pupil comes from damage to the third cranial nerve, which if we know and if we remember, I'm going to show how new I am because for some reason I remember this. It kind of runs midbrain, right? It's not on the outside. So put that with late sign. If you've got a blow to the side of the head, it's not immediately going to blow that pupil. That swelling is going to push inward on that third cranial nerve that causes the pupil to blow. Initially, it can present as an oval shape. Usually if they have that oval shaped pupil, they've got pressure on that third cranial nerve. And eventually it's going to progress into a blown pupil if not treated. Do we all remember from school, if we're paramedics, Cushing's triad? Or maybe you can tease, I don't know what they teach anymore. So Cushing's triad is kind of you're behind the 8 ball already. You're going to have bradycardia, hypertension, irregular respirations, and then you will have a blown pupil. That's a sign that the brainstem's herniating. And you're just going to maintain their symptoms at that point. If you can give them 3%, if it's in your protocols, hopefully you can lessen the blow that they're going to have long term. So do we all know how to assess an eye? How often do we do it? Do we just do it on trauma patients? Are we doing it on medical patients?
No, medical patients.
I'll show who taught me on this one. You should be looking at every patient's eyes, right? Even, the abnormal labs from the nursing home at 3 a.m. you should be looking her in the eyes. Mallory's laughing. Looking her in the eyes, you know, because yeah, her, you know, red blood cell count might be low, but why is it low? Does she have a bleed in the brain and that's why it's low? And I'm not saying just for, you know, trauma, but look every patient in the eyes because you can tell a lot. You know, are their eyes starting to yellow and they don't know that they have liver problems? Well, now that's something, you know, you can bring up. So you need to look and see, are they symmetrical? Do the pupils react in the presence of light? If you're in the back of your bright ambulance at 3 o'clock in the morning, dim your lights before you go shining a flashlight in their eyes. Otherwise, you're not going to see anything. Is there any eyelid drooping? And is that normal? Again, with histories, Papal had a stroke 15 years ago. The side of his face has never went back up. Don't call it stroke alert for that, right? Unless there's new symptoms.
And it's the same thing with a lazy eye.
Could be, yeah. I mean, if blow to the side of the head and they just happen to have a lazy eye that they've had the whole time. But no, I mean in like actual drooping of the face and get a history. I'm very short and sweet to the point. I promised Matt I would try really hard to go for 45 minutes. But, so we're just gonna talk about some scenarios. So your dispatch. So busy intersection for 2 vehicle head-on collision, 1 occupant is unresponsive. We're calling our friends in yellow back there. You arrive on scene to find an unrestrained passenger in 1 vehicle with a large abrasion to his forehead. His initial GCS is 3. You've done your C-collar, backboard, all that. Your pupils are unequal, the right is dilated and non-reactive. What do we think? Head injury. So, yeah. Do we remember why that pupil is now?
Intercerebral pressure.
Yeah, there you go. So I mentioned that it's a late sign. So we'll say this wreck was witnessed and your response time was 8 minutes. What's that make you think? They might have had to bleed before, right? And they went unconscious and that caused them to wreck. So as paramedics, EMTs, what are things we can do to help this patient with their ICP? Airway, yeah.
3% be indicated for that?
Yeah, 3%. What else? If you're a BLS truck, you don't have 3%. I'm still new to it. We just got it like 6 months ago. What else can you do? It seems silly. Yeah, raise their head up a little bit. You leave someone laying flat, all that pressure is staying in their head. Is it gonna make a world of a difference? Probably not. It can make a difference though.
Could be.
Yeah.
I'm so proud of you.
That's good. I don't need that very often.
Can you flip me to the next one?
Yes.
Scott, everything's going against it. That's true.
Maybe. I tried the clicker, it's not working.
Well, I might have clicked something.
There
There,
it goes.
please, sorry.
Thank you. Okay, so the second one. So you go to an apartment complex for a fall, elderly female sitting at the bottom of about 15 concrete steps. She's alert and oriented, but she's kind of nodding off. She does use blood thinners. While assessing the patient, you find her to be hypertensive with a heart rate of 48. Then she goes unresponsive and her breathing becomes irregular. If this happens, I apologize. This would be really bad. Do we remember Cushing's triad? She has all these things, right? She's unresponsive, she's bradycardic, she's hypertensive, and then her pupil is oval. Her left pupil is oval in shape. Yeah, and we've got pressure on that cranial nerve, right? So she's beginning to herniate. Dispatch, do I have any cops in here? Okay. So, you guys are great at bringing us things after the fact. Dispatch to a person down, you arrive on scene at the city park, find a male unresponsive, abdominal respirations on a park bench. Without reading the rest of it, what would you think immediately, just with that? Narcan, right?
18 milligram overdose.
What about his blood sugar? Don't be a cop, so we're in there just slamming Narcan in the diabetic lady. But while your partner's ventilating, they tell you the peoples are pinpoint. What do we know about pinpoint peoples? You did do that, right? And then the cops are like, hey, I found this Merc spear in the grass. What do you think? We already figured that.
I don't think it sounds like
That was my last scenario. Any questions, remarks, comments, anything? Did I confuse the crap out of anybody? No? Okay. I think it's break time.
Wait, that's my job. Are you done?
Yeah, I'm done.
All right.
Say something real fast?
Yeah.
Yeah.
It's also known in autistic patients that the pupils can be different.
Absolutely.
Stand up because you're only talking to the wall.
Autistic patients generally will have problems with their eyes being different. One could be different than the other one. It could be a lazy eye. You gotta look for that and ask him if the patient's like autistic.
Well, and that's where the history thing comes in. I mean, I went to a guy that had fallen down a ravine. You know, he hit every rock on the way down and looked at his eyes and he had like a teardrop eye and this side was kind of, sloping a little bit. And the wife, I was getting ready to put him on a helicopter. And the wife was like, oh no, that's normal.
Yeah.
Okay, well, disregard.
We have patients that are autistic or, got Down syndrome. And you can look at them and say, oh, the nurse is saying there's something wrong with him. It's like, no, he's got Down syndrome.
Yeah. Absolutely.
All right, round of applause for Holly Fox from Gallatin County.
And that's one of those things, is because we get focused, we're always in a hurry because industry standard dictates that you're on scene for 10, 15 minutes. And so some things we just don't do a great assessment because we're looking for other things. And me being on the helicopter, what you tell me is my primary assessment. If you're like, I found this, this, and this, so I'm going to move on to other things. So all of this stuff we kind of do, but we don't think that we're doing, and it's easy to overlook because we were taught. You start head to toe, and then the eyes and the mouth and and all of that. So we're doing it subconsciously, not really paying attention that we're doing it, but we just know if something doesn't look right. So Kali, I thank you for that presentation on the eyes. We are up against a break, and the fact that my partner Amy came up is indicative that there's something she wants to say.
Just what a fabulous job you're doing, Johnny, as always.
See, we'll listen to this all day long. All right, so we are a little ahead of schedule, but we're going to stay on schedule. So you have till 11 o'clock. Is that what? That's 11. Where the hell's the digital? 10 o'clock.
It's 9:37 right now.
I need a digital. But prior to doing that, we do have some more food outside. Nucor from Kentucky, they supply the breakfast. There are a lot of biscuits, sausage biscuits and some fruit and things like that. We do work closely with our factory people because that is where a lot of the big stuff is going to happen, where they're going to get smelted or crushed in between. So there's a lot of potential. So if you've got a major factory in your area, reach out because they have got some kind of first responder person in charge of that and work with them and see what kind of stuff and maybe try to do some education. We do education with Nucor and Gallatin Steel because when something happens, it's going to be big. And so we kind of provide education, they provide food. So we thank Nucor for the breakfast. Please help us out there. KDH, North Kings Daughters EMS, Jason Wright is the representative from them. He's the chief paramedic. They are supplying the lunch for us all. It is going to be some smoked meat and all kinds of fixings, I believe, right? I mean, it's going to be a picnic. So, you know, your guys' attendance and our participation and with our sponsors, this is fantastic. His wife works good. We've got great presenters. We've got 20 minutes to take a break. Be back at 10.
Because then we can add it to the calendar and we can send.
Oh, is there a sign in for her?
Yeah, I was pulling you up the agenda.
Salem Crossing, we all want to escape Saturday. How are you doing?
Hello.
That's my presentation.
Perfect.
Or well, there'll be stuff that pops up, but it'll be the advanced presentation.
Okay.
Louisville's been on one lately.
I'm gonna do this while you're sitting here.
Okay, so I'm getting ready to leave, so.
I got a picture of dispatch. Lady, she was not inside.
Page down. I'm sure this is right.
Oh, I know this. And for this,
Stand by.
it's coming back.
Yeah, it's gonna come back.
So we're gonna put the QR code up for the second speaker. Since we have some additional time, Matt Spicer is gonna be up here to answer all your questions, how to make this work, including myself, because I just can't. So the QR code will be up, and then he will tell us what we need to do.
Just minimize this, and then you'll get back, that gets you to your YouTube page, and then.
Okay.
That, okay?
Perfect. Thank you.
Do you guys need anything else before I?
No.
Fixed. Been a long time.
That's yours? It's just coming up to tell you bye.
Thank you for coming. Have a wonderful day.
If you don't want to go, we never saw, you were still here if anyone asked questions.
Y'all need to come back to the other one, let me know.
Have they asked you? Nope. I'm all for it. I'll find someone that's better than me.
Everything's on some emails.
Johnny, for the evaluation, have you put the symposium or do we do individual instructors?
Individual instructors.
I call them.
The question was about evaluations. Evaluation, it's not for the entire thing, it's for each individual speaker. That just helps validate your CEUs that you'll receive.
Yeah, she sent me a video. Pay for effort. I'm looking at it. Mine's about 17. That's all. Yeah.
What I ought to do is just keep hitting this button and pick up stop. He is my chief. Assistant chief. I'm trying to mess with him.
Tuck you away.
But everyone inside there for the last one.
I gotta do the thing. Don't take the evaluation.
It's the same eval for each one.
Okay, never mind.
Yeah, it's just, you just put in, every time you open it up, you put in a new name and lecture.
That's what you do, when you sign in your name, and then you just go away from it. You just
Yes,
exit
it
out.
takes it out.
Okay.
Yeah, once you sign in, you just exit out, then for the speaker one, it's the same thing. It's just you have to put it into the speaker. Same form. That's if you do Google Forms at least.
It's not really good. So if they can't say I'm not, they just sign it on the paper.
I mean, did you get it, man? Just like that. Okay. Yeah, they're. Okay, so Brian was okay with every time it's worried, my G, so he can't. Because I brought the papers too, if you need them, okay. I know. Sounds surprised. Yeah, so I'll just email you. Yeah. Okay, and then if he doesn't give that, it's what I know, he will text me. Yeah. That sounds like a bitch.
I'm trying to bring it up technical problems. Just so you know.
Yeah. When we're likely with better ones here, I can just talk.
Yeah. I've got all my hours already. I'm awesome.
Nothing. I'm constant, I'm just.
Oh, yeah. Yes, sir. It's all the same. It's all the same. QR code, it'll take you to Google Form, you just put different speaker and different. Hey, buddy, how you doing?
And the second page is no go. We have 2 classes left of lecture. The first week of December, we have a review day. We took our final January 7th. Gave us the whole month of December to study.
Didn't bring your doggy?
She's outside. I can bring her in here. I'm gonna bring her in for the hands-on part after this.
Long time no see, Paige. How are you?
Hi, good, how are you? I figured if I brought her in here now, everybody's gonna play with her and not pay attention.
Yeah, you got 10 minutes. If you want to get her out of the truck, walk her in.
Oh, I already did, yes. I already got her out of there.
Oh, okay.
Yeah. She'll come in here and visit everybody, but yeah, when we're done with this, when we have our hands-on portion, I'll bring her in.
He's got, nobody knew that.
Or actually, I guess I could just bring her in, leave her on her leash. She'd hang on.
Second page, the sign-in sheet. don't need it. Everything's anonymous, so I don't know. Please not delete any pages. I'm gonna try to get it working back. So going forward, if I don't delete anything, change anything, just fill out blanks, please. And we'll get it all figured out. So for right now, we're just gonna pull down this one. I can work on it. If for some reason it's not on there, we'll have do an Irish kids or anything. That works. That's what you gotta do for right now, yeah.
Was it in his medical document?
And you did put something virtual on online?
I sent them the link to do it.
Yes, sir.
What time are we doing lunch?
We are doing lunch at,
Should be right in.
yeah,
That's what I had it in there, yeah.
Okay.
If it's here early and depending on how fast we are, we can do it. If it's here late, we can adjust accordingly. Last year, it's the same stuff as last year. It's a different ball game, different team. As far as technical difficulty, switch up.
I'll text Dilk and see what time he plans on having me here.
Don't ask him, just tell him to be here by
11:30.
Yeah, 11:30, 11:40.
Anyone in the chase car with us?
Sure.
Do y'all have a portable extra suction?
Oh, sure, yeah.
Did you have to bring them up for the skills lab? Trumbull County wasn't able to come through there and using it. He quit. Got used last year with these. We don't have it.
We got a rig that's out, get a rig out, and so we should have an extra.
So yeah, if y'all want to bring that up, just have it here like.
Call.
Is that Monday?
Guys, like, where it's like,
Yeah, I think that one's in service, buddy. If we get a puke or one of those mice and cheese. He said, we're gonna need it. But those wall mounts in the
well,
I would say.
they don't see it like this.
They're having
On Monday?
He's like, anyway, which end do you insert it? I was like, what are you talking about, dude? He goes, well, you never know if you get stuck. They get stuck. Yeah, pop it on out. But you can turn up that big.
You're right. I only do good things when you're there, actually.
Do you have this screen up at your, back there?
I can. As far as just
That's what you did.
seeing what I can't log in or it will mess up the stream. I can go in as like a person here and just see what everyone else is seeing.
But you can see the chat.
Maybe.
So if you want to look at the chat, just make sure, just jot down the names in case something doesn't go right with the virtual.
So your card is there, keeps your heart in, so you can just stay on it. That'd be good.
And then you can type stuff in the chat.
I had it up there, I think I had it back there last year, so I think I can do it again. I just didn't. Bring up all the shit this morning so far. Maybe stayed off and on till 1:30 this morning. That's what I wanted. Pages next. Yeah, we'll have skills workshop lunch. Stephanie. Brian Franklin.
I know, whatever they do themselves.
Well, no, I just feel like I'm taking credit for something I had nothing to do with.
All 18 for. So. Everybody works in here.
Yeah, I think Paige went to get her Gucci Pooch. Yeah, so, yeah, go ahead and get her stuff. Carmen's not here, so don't mess it up.
Yes, sir.
Everybody's having a great time. Really jealous. Oh, I did this. Tell this lady she didn't need that. I don't have any patience. I brought y'all one in today. Scott, they were like, hey, she did that.
Yeah. They've taken a lot of slightly, but I was like, wow.
She was not.
She was.
Aha.
She was.
Not a, uh-huh.
Where I had to take
I want my chat finger instead.
So.
Here you go.
And I was like, oh, okay.
Oh, I want that over there. That doesn't, just let me make sure the clicker works. Okay.
Yeah, but I need to make sure that the YouTube people can see the YouTube.
I think this is what the YouTube people see. It's the screen.
And then, so we had her cracking a lot of she chilled. I guess after I left, she was like, I'm gonna leave the game. All right, I'll say.
Hold on real quick. I gotta fix
So. You get big. So I walked in and I was like, what's going on? Got it. So I sat down.
I'm still on Monroe.
I felt for her.
It wasn't a bad exit, sort of clear. I was never there because of that class.
I haven't been there all year. I don't have time. I don't have time.
I was never there, and I don't even live in the district, so I was just like, screw it. Wash my hands of it.
They wanted to keep me on their roster, so I was like, I don't care. I'm just telling you, like, I got to pick up shifts. I have training every weekend with her, and through the week I work Monday through Friday.
Medic class is just draining me, so I have no free time.
Well, come to medic class. It gets better when you graduate.
Hi, doggy. But yeah, I'm on Franklin Fire, because they're right down the road from me, South Boston.
Where are you at?
Franklin.
Oh, you take care of that.
South Boston.
I don't know.
Just get it back
Where
where
do
it
you live
was.
at?
I live on 160, I head towards Salem.
Oh, okay. I didn't know where you're at. Okay. I know where you're at. I just.
So, but they go like 200 runs a year, so it's
Not that bad.
not crazy. I start Clarksville in January.
I saw that. Congrats. That'll be fun.
Just go back to that previous.
Which one?
The one that had the
Stay
chats.
down. You don't jump. Stay down.
Other than that, just class and work.
Oh, we'll just get it back next time. We'll take care of the chat right there.
Yeah.
All right, I'm gonna hit the clicker.
Fill up the Jacksons.
I'm in Jennings.
All right,
Jennings.
click
I
on
knew it was a
that.
Jennings.
I live in Jackson County.
This one?
Yeah, just click.
Jennings County.
There we go.
There we go.
So many new people.
All right. Hey, Luke and Matt, hold on, please.
What?
So we're gonna get things going again. I'm gonna take a second to introduce your PHI Madison crew. And I don't see my partner Amy. Is Amy out there? Okay, well anyways, we'll go with what's here. So this is Matt Spicer from Kentucky. He's our paramedic. He is actually the head guy that kind of put this up, brainchild, and does all the behind the scenes stuff. So let's give him a big round of applause. And don't be humble. He really does spearhead this up. Amy McDonald is beside, that's my partner. Me and Amy started our EMS career, well, I was already there, but she joined KDH and I met her there in 06, 07. And then I was able to bring her back and join me in Madison. In the back, we have two fantastic nurses. On the left is Kayla Roberts. She is in the flight suit. And on the right is Jamie Nagengard. I I know how to spell it now because it goes on the chart. So it is Megan with an N and then Ard at the end. So this is your PHI group.
Hey, Brian.
And Brian's around. He's going to be a presenter here later. So this is your group. And next is up is going to be Paige. But before we do that, Tom George Johnson.
What about Luke? What about Luke? Yeah.
I was wondering if anybody pick up. This is a gentleman that I'm very proud to call my boss. He is over the Madison base medic that went to the dark side and became a nurse. So he is dual certified. Amy's dual certified. Kayla's dual certified nurse and medic. But our RN / medic / boss, Luke Lamar.
Johnny, that's got it.
All right, next up is a person that I've worked with for many years, Paige, double digits.
Yeah, since I was a baby, EMT.
So she has brought.
Nitro.
What?
Nitro.
So she's going to explain how a dog can really take part in our jobs. I had a partner who is part of the government search team that has the dogs, and you just think dogs are just dogs. But I've used canines for search and rescue personally, and I've used canines in the coroner's role because each dog has its own special talent that they're trained for. So when somebody goes missing or something, they know the cops have dogs, so they'll drag out the dogs for the cops. Those canines are trained for drugs and to fight. This dog is trained that one of us can leave. She will know who's in the room and then find the scent of the person who is not in the room. So it is very specialized and it is very awesome. They are underutilized. Are you part of a group in Indiana?
Yeah, so I'm on Jennings County Search and Rescue Team, K9 Search and Rescue Team, and then I'm starting one in Jackson County, which will be Tactic K9. And then I'm on a disaster response team. She's technically not yet, but as soon as she finishes her certifications, hopefully she will be too.
I know I'm stealing your thunder, but it's just dogs are underutilized. Canines, friends. I don't want to be demeaning calling her a dog, but the canines can be utilized so much more than what we do for reasons that she is going to tell us how and why. So, Paige Bush. Oh, and she's a paramedic.
Yeah, I'm trying to say you missed that.
Just a little minor detail. All right, like Johnny said, my name's Paige. I'm from Seymour, about 45 minutes. It's a bit west of here. I've worked for a couple different EMS services in the state. I do fire and EMS and search and rescue. I've been doing it for about 17, 18 years. I got Nitro. She just turned a year old the end of last month. I got her at the beginning of the year when she was about 12, just shy of 12 weeks old. I picked her up on a Wednesday. We went to training on Friday and never stopped from there. So she particularly does live find, area search, and cadaver both. We do a little bit of detection work, but we mostly focus on live find and cadaver. Today we're going to talk a little bit more about how canines help us in the first responder world, and then also if they get injured, how to tend to them. In Indiana, we do have protocols that in emergency situations, we are allowed to provide care to working canines. Kentucky, I can't speak for you, so I apologize.
The state veterinary board has endorsed it, but they're understanding state protocols.
Okay, fair enough. So this is just a little disclosure statement. This information came from Dr. Lisa Booth, who's a veterinarian. She owns Kids for Canines up in northern Indiana. I've done a lot of training with her on this side of things. Dr. Ellen Bertram, she is Nitro's canine as well as sees some of our other canines on our team. And then, of course, the Indiana State Board of Animal Health, and then the K9 TCCC guidelines. So first and foremost, canines are definitely underutilized in the first responder world. A lot of canines didn't really get their glory until 9/11. That's kind of when it seems like a lot of information about them came about. Reality is, in the military, they started in the 1940s. Law enforcement was about the 1960s. And then really search and rescue, fire EMS, they've all been around for a while. But like I said, they got their glory after 9/11, when a lot of the search and rescue dogs were helping find people from that. In today's world, they are definitely underutilized. There's so many cases that can be used, whether it be a search and rescue team or it be even in just EMS and fire. A couple questions, could we use them more? Absolutely. There's, like I said, there's a lot of times when canines can cut down the amount of work, what would take us 8, 10, 12 hours, they can make of easy work in an hour or less, depending on the situation. One thing with search and rescue teams, we don't self-deploy. Search and rescue is the same as everything else. We want to be there when the bad stuff happens, but we do not self-deploy. We have to be dispatched, usually either by the sheriff's department or EMA has to request us for that area, wherever we are wanted. And then the other thing is too, much like a helicopter, a lot of times, it's easier to get us coming and then cancel us if you don't need us or you find whatever it is, missing person, whatever, than to delay and wait to call us. Like Johnny said earlier, one of you could literally go anywhere in this building. I could give her a scent article, or even if you didn't leave anything, and send her off and she will find you. There's 2 other dogs out in the parking lot who are in crates who can do the same. And they can do land and water both, and live find or cadaver.
Sounds I'm messing y'all up.
It's all good. It works. One of the big questions though is, what do we do if they get hurt? Obviously, I think for most of us, the law enforcement canines are probably who we interact with 9 times out of 10. I get a lot of law enforcement officers that I do trainings for on how do I take care of my canine if they do get injured. For most of us, depending on where you're at, where we're at in Jackson County, it's an hour either way. So there's an emergency vet down in Louisville somewhere. I'm not exactly sure where it's at. And then there's one up on the north side of Indy. A couple of years ago, one of our law enforcement canines got a shot. And it was a pretty big deal. Thankfully, in his case, one of the helicopter crews actually flew him, which I think was kind of a big start to the improvements in Indiana for the canine protocols. Our scene size up, it's going to be the same just as it is in EMS. Obviously, the one thing we need to know though is it our handler that's injured or our canine or both? Obviously, our priority is humans, as bad as that sounds. Anybody who I know there's a few canine officers in here. Your canines, they're just as much your partner as your human partners. But the realistic part of it is our priority is humans. So if both are hurt, the handler takes priority over the canine, unless you have enough resources on scene to do both. If it's only the canine that is injured, you need to communicate with that handler. Most of these canines, especially your law enforcement canines, they're going to get aggressive. They're going to get apprehensive. Even Nitro, she's as sweet as can be. Most search and rescue dogs are. But if I get hurt, she's going to become aggressive if you try to mess with me, unless you make contact with her first or let her get to know you. That's just a dog's human nature. A lot of times that's mistaken. I'm sure some of you in here have had canine handlers who maybe have gotten injured in the law enforcement side. You know that you're not getting anywhere close to that handler until that canine is apprehended. In the event that you can't get close to the canine, if you can make contact with the handler, obviously they're not leaving their canine, and you can walk them through what needs to happen, then do so. A lot of times that's going to be probably the safer thing for you, unless they can get that canine muzzled or get them restrained, especially if they're still alert on any level. If for some reason both handler and canine are both injured and you've got enough resources, one crew takes the handler, another crew, or even if it's just a chase medic or whatever, goes with the canine, you still need to make sure that you take an agency representative for that canine, and that's for your safety as well as the canine safety. And just because even if it's not the exact handler, it's somebody who's familiar with that canine. When they get to the vet, it's going to work a lot of the same way as when we bring patients into the ER. A couple things to keep in mind, don't ever attempt to apprehend or don't ever attempt to manage a alert canine. You want to make sure that they either have a muzzle on or they're restrained in some way or another. Obviously, if you can keep the canine handler with you, that canine is going to be a lot more calm. Even the law enforcement canines, as long as that handler is there, they're going to be a lot more receptive to whatever it is that needs to be done than if you try to separate them. Secondly, no matter how well trained the canine seems to be, you want to get a muzzle on that canine. Nitro's probably not going to hurt anybody. She's never bit anybody. Hopefully she never does. But I can tell you when she's injured, there's still that potential because that's just a dog's natural instinct. So always muzzle the canine just for everybody's safety. And then if they have any kind of vest, harness, I know a lot of the law enforcement dogs usually probably have a vest or a harness on of some sort. Make sure you leave that on because that's going to play to your benefit in order to keep that canine restrained as you're tending to them. Like I said earlier, if both are injured, the handler is our priority on the EMS side of things. One of the other alternatives, I've only ran into it one time. One of our canine handlers got injured. He was the only law enforcement on scene. We took his dog with us in the ambulance. Wasn't ideal. It was a mountain wall, so they're very kind of scary if you're not used to them. But sometimes you may have to do that or wait until another law enforcement officer gets there to take over for that canine. Transporting canines, just like in EMS, we want to stabilize the best that we can. Obviously, our priority, once again, is humans. I can't express that enough. And the reason I continue to say that is because there are people who seem to think, oh, this dog got hit by a car, or this dog got injured in this car accident. I need to worry about that too. Unfortunately, just not the way it works for us in EMS. Either that law enforcement officer who is the handler or take another agency representative with you for that canine. Most of that's for safety reasons. Don't delay transport of that canine. If that canine is injured, our priority is just to do what we have to do to get them to one of the emergency vets. Any of you who work with canines know, once again, our canine partners are just like our human partners. They're family. And so on the EMS side of things in Indiana, like I said, we do have state protocols that Dr. Eric Gazel has signed off on, as well as the Indiana Animal Board of Health, that basically states if you can do it on a human, then you can do it on a canine as long as you're trained. Anatomically, they're about the same. It would be about the same as a human if you thought of a human getting down on all fours. Their front two legs are more like our arms. Their back legs are more like our legs. Their spine's a little bit different. Obviously, they're going to have a lot more vertebrae. Depending on the breed size is going to kind of dictate how many vertebrae, especially when you get down to their tail region. Anatomically, once again, if you think of a human getting down on all fours, it's roughly the same. There's obviously a few things that are going to be different. However, overall, it's still just about the same. Organ systems, same as ours. There's nothing really different. Dental-wise, this doesn't really matter much to us. The only thing to keep in mind, I really put this on here just to show you that if you're not familiar with canines, they have a lot more teeth than we do. They're going to hurt a lot more. And as you can see, their teeth are quite a bit larger. The last thing you want to do is be sticking your hand in a canine's mouth trying to apprehend them or help them, whatever, and then to bite you. This is just a little bit more close up of their anatomical as far as the skeleton system goes. Restraining the canine, like I said, there's a couple different ways. One is a muzzle, which should always happen regardless of whether it's law enforcement, fire, EMS. There are some fire departments. I know at least 2 in Indiana that have canines. I believe they're farther down south around Evansville. So it is becoming a little bit more common. Other than the muzzle, there's a sitting, you can restrain them sitting or standing, much like she is sitting now. And then just the lateral recumbency is also another. The muzzles, there's all different kinds of muzzles. Even if the canine handler doesn't have one, you can use gauze, anything, a triangular bandage to make a muzzle. As you can see in the one picture, I don't know if that works. There, it's pretty simple. The biggest thing is though, like I said, you want to make sure that canine is restrained for your safety as well as anybody else who's going to encounter that canine. Sitting or standing, like I said, there's a couple different ways to do so. A lot of it's going to depend on what is going on with the canine and why, what is it you're trying to treat. Sometimes it's going to be fine for her to sit like this. However, if she's with it enough that she's sitting like this, EMS doesn't need to tend to this. This is something I can handle on my own, or the law enforcement officer, they can take them direct. We're mostly going to be dealing with them in the event that if we don't tend to them now, they're going to die before they get to the vet. And then the lateral recumbency, this is where they're laying down on their side. You're basically leaning over top of them to hold them down like that in order to get apprehend them enough to get done whatever it is you need to. If you notice, her elbow there is kind of on its neck, just to keep that dog from whipping around and biting somebody. Whenever you evaluate the canine, you want the canine to face you. So if they're laying on their side, have the belly towards you. A couple big things to remember. Their femoral artery is going to be in the outside upper leg, and their heart is going to be right about the front of their elbow. So it's going to be whenever she's standing about right here where her heart is. Regardless of the size of the dog, it all kind of is still the same. So even your smaller dogs, their heart still is going to sit about where their elbow is. Make sure whenever you're approaching the canine, like I said, you can do one of two things. You can either, if they're completely unresponsive, you still want to be, still know that, hey, there's a chance that they're just a little out of it. You start messing with them, they're going to come to. So make sure that you have somebody there that's familiar with that canine just in case. Two ways that you can go about their assessment is either a typical head to tail assessment, which is probably the easiest. If you don't have a whole lot of knowledge on canines, that is going to be the route to go. Otherwise, you can do a systemic assessment, which is just organ system by organ system. Generally, since we're going to mostly encounter these canines in a tactical setting or in the field setting, it's a lot easier just to go by the March algorithm. Just because of the way, a lot of times canines, obviously their airway is important, but they're going to bleed out a lot faster than a human just because of the way everything works. Head to tail assessment, like I said, pretty generalized. Start at the head, literally work your way all the way through the tail. Make sure that you're touching the canine when you're doing this. One of the big things is when they get shot or stabbed, their fur, or if they get impaled by something, their fur is going to cover that up. So it's not going to be like a human where we may see a lot of blood. She could be impaled by something and I may not know it unless I'm actually physically touching her. So make sure that you're definitely running your fingers through their fur, trying to feel everything to make sure that you don't miss anything. And then it's just the same as humans. Look for deformities, look for any injuries, anything that feels out of place. Check your hands. Is there blood? Or anything like that. And systemic, like I said, I wouldn't recommend this unless you have a good knowledge on canines. And this is just kind of the same deal, except you're just going organ system to organ system, checking them that way. This takes a lot more knowledge. If you're a vet or work in a vet's office, this may be more your style, but I know at least for me, it's not. Understanding your canine. If you have a canine as your partner, you already know this, but we have to know our canines inside and out, just like if they were our kid. The better we know our canine, the more that we're going to be able to help them in the event that something does happen, that they do get injured or become ill during training. Vital signs for a canine, they do vary just a little bit different than a human. Your normal heart rate is going to be between 60 and 90 beats a minute. Their respiratory rate is going to be between 10 and 30. And a normal temperature for them is around 100 to 101.5. For canines, temperature is a big deal because when you hit about 103, they start having organ damage. And that organ damage starts taking place in a matter of just less than 30 minutes. Once you get up to 106, generally they're having intestines damage, and by 108, they're going to be in complete organ failure, and there's not going to be anything that we can do. This comes into play, especially around here, the summers that we have. If you've got your canine out, or you know that, hey, law enforcement's, working the canines or whatever, it's definitely a good idea to keep an eye on them, and definitely their body temperature. Chest sounds you're gonna hear when you listen to their lungs, it'll be the same as a human. That should be normal, but if you hear wheezing, crackles, or no breath sounds, then that needs to be an indicator that, hey, something's not right with this canine. Whenever you're doing the assessment, once again, just the same as we would with a human. Are there any life threats? Are they breathing? If they are, is it adequate? Is it too fast, too slow, not enough? Are they making noise? One thing with canines is they're pretty resilient, and the downfall is they're going to crash a lot faster and a lot harder. So that's the unfortunate part. That's where we kind of come into play as EMS, especially with the law enforcement canines, or your working canines in general. If they get injured, unfortunately, time is definitely of the essence. And something as simple as a stab wound to their upper leg, we may not think is a big deal, but it can be a matter of life and death very quickly for them. As far as alert level goes, if they're alert or, that's more, they're seem normal, this is where it comes into your canine handler knowing their canine. Are they more apprehensive and crying, or whining, just, not even doing anything? And then the difference is with that, are they whining because there's people around, much like she is now, and she wants to play, or is it a whine where, hey, I'm hurt or I'm injured? And then, this is where you might have a lethargic canine. This is one of the, things we need to be careful about as EMS. If we're tending to, especially law enforcement canines that are bite dogs, they may be laying there and seem okay, but as soon as you start touching them, they're going to come up and they're going to come at you because that's their natural instinct. And then, are they responsive to painful stimulation? So, when we're touching them, when we're messing with them, are they responsive to that, or, are they letting out a whine or a cry? And then, of course, is there no response at all? They're unresponsive, just laying there. Airway, so once again, anatomically, they're very similar to that of humans. The only difference is they're a lot more anterior. Your landmarks are going to be the same as far as if you have to intubate or trach canines. In the event that you have to make a surgical airway, you want to make sure it's a size 9 or a size 10 ET tube. And once again, the only time that we're going to be doing this is if this is their only hope for them to get to a bed. Otherwise, we're just going to put some oxygen on them and, let law enforcement take them, or whatever their protocol is. And as far as checking their O2 sense, obviously, to look at the dog, you can tell some. For them, we're going to look at, the mucous membranes in their mouth. We're going to look at their eyes, check their tail or their scrotum. Is where we're mostly going to see, one, are they perfusing well? And two, you can use a human O2 sensor. And those are going to be the areas that you're going to get your best reading on. With a human O2 sensor, if they're at 94%, that's sufficient. That's ultimately 100%. I know I highly doubt any of the EMS agencies carry canine O2 sensors, but if the officer has one, then use his orders. Airway obstructions. This is another big one for them. Are they gagging? Can you visually see something in the airway? Are they making a noise that's not normal? Or maybe they're not making any noise at all. They might be alert and oriented, but they're pouting at their mouth or their nose. That might be a good indication there's something going on. Or if they're continuously shaking their head. Heimlich maneuver on a canine. I know this seems crazy, but I've heard some of the canine officers in our area talk that actually have to do this because they ingested some narcotics they found on a stop. So basically, you can do it one of two ways. You can either hold the canine up like this, and you're going to find their last rib and ultimately do the Heimlich maneuver just like we would on a human. The only difference is it's going to be more of just a thrust in than in and up. The other option is to find their last rib and hit both sides of their stomach as hard as you can, and that will force that whatever it is they're choking on to come up. One of the big differences is, if they do go into cardiac arrest, it's not going to do us any good to jump straight to CPR. We have to clear their airway. If you don't clear their airway, you're not gonna get anything accomplished because unlike where a human might be able to compensate a little bit, or we might be able to force it down one way or another, with a canine, it's probably not gonna happen. Breathing, once again, can you see them breathing? Are they making any noise? Whenever a canine, some of our law enforcement canines, I've heard them be, where they've been exposed to drugs or whatever. They're going to have a lot of the same reaction that a human would, as far as, if they get into opioids, they're going to have a decreased respiration. You may not notice so much with, their pupils and stuff, but they're going to exhibit a lot of the same symptoms we do. Also looking at their mucous membrane, so inside their mouth, looking at their scrotum or their vulva. If that's turning colors, much like a human, it's going to tell you something. So if they have a grayish tint to it or blue, they're probably not perfusing very well. If it's yellow, it could be a liver issue. Once again, they're resilient 9 times out of 10. At that point, they've probably more than likely got into something than not. This is just to show you if you do have to give. So whenever if you have to give a canine rescue breaths, you're going to hold their muzzle shut like this, and you're just going to blow into their nose, and you're only going to blow in enough to see chest rise and fall. They also make canine, or I think they're just animal non-rebreather masks. We do carry those on our ambulance. Where I work at, our fire department has them as well, and they are pretty. Kind of neat to use. They work the same way ours does. It's just a longer, kind of a deeper non-rebreather to go over their muzzle. Canines have less than a 6% chance of survival if they do code. Usually their pupils will dilate within 1 to 2 minutes. Once their pupils have dilated, unfortunately that canine's dead. There's nothing we can do about it. There's nothing a vet can do about it. That's just the way it is. A couple ways to see, and this even goes for your overall assessment. If you're not sure what their level of responsiveness is for that canine, if you push in on their eye, you can roll it around. It does not hurt them. It sounds bad, but it doesn't hurt them, but it'll give you a good indication as to whether or not that canine's going to come awake, or if they truly are unresponsive. Same thing, whenever you're doing CPR to a canine, lay them on its side. You're going to put one hand under the dog's chest, because when you lay them on their side, there's going to be a void there. And the other hand's going to go over top, and you're going to literally just compress like this. Just like with a human, you've got to break their ribs. If you don't break their ribs, you're not doing them any good. Unfortunately, if a canine goes into cardiac arrest, regardless of the reason, their working days are done. But that's not to say that you can't still keep that canine alive for that handler. Compression, the breath ratio is the same, 30 to 2. It doesn't matter the size of the dog. Roughly, you want to keep your rate about 100 to 120 beats a minute, and you're going to check the heart cycle, or the heart or a pulse check after each cycle. And then the CPR protocol is just the same as it is for humans. So just follow your HCLS protocol. Circulation, this is a big one. Like I said earlier, if they start bleeding out, they're going to bleed out a lot quicker than we are. The downfall is they're going to lose a lot more blood, especially if it's internal, than before we realize it. So a lot of times, if they have an internal bleed and we don't pick up on that, or the canine handler doesn't pick up on that, by the time we do realize that, unfortunately, they've probably lost enough blood that there may or may not be anything that we can do for them. You want to make sure you check for a pulse. Even if they have a leg injury, once again, it's just kind of the same as your human assessment, except on a canine. Just the biggest thing is making sure that you're physically touching that canine, so you're not missing any kind of stab wound or gunshot or anything like that. Secondary assessment's the same. This is the information. This is where having an agency rep with you comes into play, because obviously you're not going to get much information. Sometimes some of the canines have a little on their collar. They have like a medical card, I guess you could say, but not all canines have that. Usually, you might see that on your search and rescue canines, but your law enforcement canines generally not. The other side to this is most of this information is all going to be in the canine handler's vehicle. So regardless of search and rescue, disaster response, task force team, whatever, The law enforcement guys, they usually have a folder or it's on their crate. There's information about that canine. IV fluids, once again, if you can do the skill on a human, you can do it on a canine. So even with IVs on a canine, even if you're training, you still have to be an advanced paramedic in order to do a IV on a canine, at least in Indiana, for our protocols. You generally want to just go with an 18. A lot of that's just because you got to think you've got to get through their fur. So you're going to have a little bit more resistance than if it just started an IV on a human. And then the area you're going to look for is going to be the cephalic vein, which is going to run. This is the front leg. It kind of runs right down the front. And the reason, not that there's not other veins you can use, but that's going to be the biggest vein. That's going to be the one that you're most likely going to feel on that canine and have the best chance of getting. One of the big things is, though, do not give canines saline. The reason is their kidneys are a lot more sensitive than ours, and their sodium levels will increase super fast. Saline has way too much sodium in it. If that's the only fluid you carry on your trucks, you're better off not to give them saline at all. Otherwise, primarily either lactated ringer or plasma light's going to be your best bet. And one of the other things is too, if you're not sure, call a vet. Whatever vet you're headed to or wherever it is you're heading, call that vet's office. They're going to give you the information you need, much like our what we call medical direction. Whatever that vet tells you is what you need to be following. You can do a 4-lead on a canine. You're going to put it on the bottom of their paws. The only thing that you're really going to see if you do a 3 or 4-lead on a canine is you're going to look for, you're probably going to see VTAC, either PVCs or AFib. Much beyond that, you're not going to see anything. Those rhythms on a canine should look very similar to that of what we would see in a human, but you're not going to be able to see, you're not going to be able to see a second-degree block or third-degree block. You're going to basically just be able to see, hey, yeah, they're probably in AFib or hey, they're in VTAC. Some other big emergencies that we generally may run into, hyperthermia is going to be a big one. This is just like humans. Core body temperature gets too hot. The biggest difference is they have a lot more sensitivity to that, so they're going to go into that a lot quicker. This is why a lot of times you'll see the canine handlers, even if they're tracking, they may stop that dog and make them drink water on that search, or even if they're looking for a suspect. If not, sometimes that's why the law enforcement guys, they'll run their canines for a certain amount of time and they put them up, and if anything, they'll get a second canine out. It's all for protection of that canine. You can monitor their temp best with a rectal temp. Just like human, it's not going to hurt them. And you can use a regular thermometer, a human thermometer on a canine. Hypothermia, same as it is for humans. One of the biggest things is they're going to be a lot more susceptible to frostbite, especially their ears, nose, tail, and their scrotum, their paws. If it's super cold outside, they're going to be a lot more sensitive to that, even though we may not think it's that bad. Something, such as them walking, I'm sure everybody's heard of, canines walking on the hot pavement, burning their paws. The same thing can happen when it's super cold outside. They're a lot more susceptible to getting frostbite to their paws, even when we may think that, hey, in reality, it's not that big of a deal. Allergic reactions, they can have allergic reactions just like humans. The biggest places that we're going to see is usually to their face. You may notice in their paw, on the underneath of their paws or their tail, or even in their eyes, you'll start to see them getting hives inside their ears, or they may start pawing at those places because they itch. You can give canines Benadryl. It's 1 milligram per pound. Benadryl's super safe for canines. So if you're kind of on that, do I give 25? It says they should only have 15 milligrams or, whatever it is, you can give 25. It's a super safe drug for them. It's not going to hurt them. Bloat is probably one of the most serious conditions. This can happen super easy. A lot of times this is generally where the stomach is going to start to expand, either because they've had a copious amount of water, food, or even just a big influx of gas. There's some breeds that are more susceptible to this. The law enforcement guys, your Malinois and your German Shepherds are two of the top dogs that are just predisposed to this. No matter how close you watch them, This can happen very easily. This is one of the important things with this is not feeding your canine right before you know you're going to you're going to run them. Obviously, in your guys' case, you never know when you're going to have to use them, so it's easier said than done. But some of the things that you're going to see is their chest or their belly is going to start swelling, and it's going to swell on a pretty rapid basis. There's not going to be any question. You may not know what's going on, but you're going to be able to look at your canine and be like, yeah, something's not right. This just kind of shows exactly what their stomach does. This is a normal stomach here, and as it grows, this is what happens. As you can see, the stomach tissue starts to die. A lot of times by this point here, you're all right. By this point here, their stomach can flip inside out, and the biggest thing is their stomach swells. It's ultimately cutting off blood supply to the whole lower end of their body. So if you are ever in a situation where you're like, I don't know, it could be blow, you're better off to get to the vet, and the vet be like, no, it's not, than to try to blow it off and just take care of it at home, because otherwise it's going to end up bad for your canine. One thing that we can do in the field, once again, if you're trained, and like I said, I'm speaking for Indiana, Kentucky guys, I'm sorry, I don't know all your protocols down there. You can decompress their stomach. So what you're going to do is you're going to find their last rib, and you're going to go about 2 inches past that, about where their stomach is. It works better if they're laying down. Generally, if a canine's in bloat, they're going to be laying down like this anyways because it hurts them to stand up. But you're going to basically make a triangle with 3 needles. You can use just the 18 gauge needles like what we would use, or a blunt needle like what we would use to draw up meds. And you're going to just make a triangle like that, and you're going to hear a big rush of air, just like if you were to needle decompress somebody's lung. The thing is, though, as soon as you do that, you want to pull those out because much, like when we decompress a lung, they're going to get the feeling better, and they're going to get up and want to take off. Obviously, if the needle's still in them, it just takes a bigger risk of they're going to start losing blood, and we're going to run into other issues. Run-ins with critter run-ins. Search and rescue, we run into this probably more so than not. But your venomous animals, snakes, probably being one of the bigger ones that we run into, being out in the woods. They're going to have a lot of the same symptoms a human would. You may notice some swelling wherever they were bit. They may start, pulling at that area, depending on what kind of animal it is that got them. It could paralyze them, or you may know that they're not using that leg at all. Or if it's that much, that they may just lay down. More salivation than normal, or also symptoms that you may see. Just like with a human, the biggest thing is you want to try to keep that canine as calm as you can, because the more they get going, the more that venom is going to spread. Rapidly get them to a vet. If you can see where they got bit at, draw a circle around it so you can monitor for the swelling. It'll give the vet some indication how quick, maybe they're having a reaction to whatever it is. And then if you can see what it is that bit them, obviously any characteristics like that, the vet's offices, I don't know about here. I know Jackson County, most of our vet's offices do carry anti-venom for copperheads. And obviously DNR has that as well. And then try to keep the canine cool, and then you can always give them Benadryl and Epi. One of the big things with Epi in a canine, regardless of why you're giving it, whether you're giving Epi in a cardiac arrest or for an allergic reaction, it has to be 1 to 1,000. Gunshot, stab wounds, like I said, just like with a human, you can pack those injuries. Tourniquets are kind of controversial on canines. That's another thing. If you put a tourniquet on a canine, their working days are done. And the reason being is because of where their tendons and ligaments are. If we're putting a tourniquet on one of their legs, it's usually going to cause injuries that they're not, they may be fine, they may live, but they're not going to go back on the street working search and rescue or law enforcement at all. Blunt injuries, just like a human, they can go into seizures. They could have fluid coming out of their ears. The downfall is if you know fluid coming out of their ears after an evident head injury, the unfortunate part is that canine's done. I'm not saying don't get them to the vet. The canine handler may disagree, but if they've already got fluid coming out of their ears, there's nothing that anybody's going to be able to do for them other than to keep them comfortable. Anytime they have a blunt injury, one of the big things is just keeping in mind that the possibility of them getting internal injuries, whether it be bleeding, or tension pneumo, is extremely high. Obviously, they don't have all the extra padding that we generally do as humans. So something is even, if they get into a fight with a suspect and that suspect rolls them or ends up on top of them, the chance of that canine having some internal injuries is a lot higher. As far as fractures or anything like that goes, you can splint it just to remove or to decrease motion for that limb. But in the end, a lot of times, especially canines, if that's the only injury they have, they're going to compensate for themselves and they're just going to, walk on 3 legs or whatever and probably load themselves back up. Open chest wounds, you can put chest seals on canines. You'll treat those just like you would for a human. The biggest thing to remember is even, the good chest seals, you're going to have to probably tape them down to get through their fur. But you're going to apply those just the same as you would for a human. If it's a through and through, make sure you get one on both sides. If you have to needle decompress canine, it's the same as a human. The only difference is your landmarks are going to be a little bit different. If you find their last rib, just know that their last rib is the 13th rib. And you're going to count towards the head, and you're basically going to be between the 7th and 8th rib to do that decompression. You can use the 18 gauge needles, once again, like a blunt tip needle, or you can just use the 14 gauge IV needle, would be big enough as well. And then eye injuries, you can just flush their eyes with water. If there's something impaled in their eye, just like with a human, try to secure it as best you can, get them to the vet. Wounds, like I said, we're going to take care of these very similarly to that as we would for a human. The biggest thing to remember, like this bottom picture, it's a stab wound on their back leg. We just need to keep in mind that, their arteries are going to be in a little bit different spot. So although that doesn't seem to be that big of an injury, they very well could be super deep, maybe something that you have to pack, and they may be, bleeding inside their leg, because they're going to absorb a lot more of that blood a lot quicker than what we can keep up with, probably. Fractures, you're going to look for the same things in their limbs, just like you would for a human. The only difference is if it's their upper leg, you may have a harder time noting that, just because to look at them, we may not be able to see it, but, like I said, they're going to be probably walking on 3 legs. A lot of times, the canines will compensate for themselves. Bandaging and splints, you can do a lot of the same bandages and splints for a canine that you can for a human. You just have to be a lot more creative, because especially if they're awake, they're not going to like that. And then obviously you have fur to deal with. So if you're trying to do some sort of adhering dressing, just like with a chest seal or something, you're going to have to tape it down extra good. Sutures and glue, if you're willing to do that while they're awake, have fun. I don't know that I would want to try to suture a dog awake, but it's just me. And then, you can do dry to dry, wet to dry, whatever it is, considering on, whatever instance they're in. Some other medications, these are other big medications that we would more than likely use with their dosages. There's a whole list of medicines. There's very few medications that we can use as humans that canines can't have. 2 of the big ones is our paralytics cannot be used for canines because the concentration of them is different. And then Tylenol, you cannot give a canine, should not give a canine Tylenol. It needs to be aspirin if it's just something over the counter. Otherwise, to give a canine Narcan, you're going to administer it the same way. Intranasally, you can give it intramuscular. Usually, you want to go in their upper legs, either front or back up here. And then you can also give it IV if you do have an IV in that canine. Anything sub-Q that you're going to give, you generally want to give on the back of their neck, just because they have a quicker absorption rate there versus somewhere else. And then, like I said, the epinephrine, regardless of whether it's for a cardiac event or an allergic reaction, it has to be 1 to 1,000. And then lidocaine, atropine, we'll use those, for some of the same reasons we would for a human. If their heart rate gets below 60, we're going to go ahead and give them some atropine. Toxic congestion, one of the big things is just getting them out of the area. If you know that, hey, this is, this was spilled or whatever, this is what they got into. Get them out of the area, try to find out what it is they got into. If you know what it is they got into, you can go ahead and induce vomiting with peroxide. If you're not sure, it's best not to induce vomiting, especially if you're not sure, if it was an acid or something, that may make it worse. If they get into antifreeze, it only takes about 15 minutes for their body to absorb that. In less than about 3 hours, they're going to have kidney failure, and that's unfortunately going to be the end of it for them. If they get into antifreeze, a lot of times they'll act like somebody who's drunk. They'll just be stumbling around, kind of falling side to side. Narcotic ingestion. Most of these any of these they get into, you're going to see a lot of the same symptoms you would in a human. The biggest thing with these is you're basically just going to treat the symptoms. If you know it's an opioid or have a pretty good idea that it is, give them Narcan. Narcan's not going to hurt them. If you're going to give intranasal Narcan, you're just going to give it in their nose. Make sure you have their muzzle closed and then push it through their nose. Just know that they have a lot quicker absorption rate. So as soon as you push it, you need to be ready for that canine to pop up and be ready to go. As far as anything else, most of the stuff, we're just going to give them fluids to flush the system. Once again, you don't want to give them saline at all because it's got too much sodium in it and it will cause more issues very quickly. Otherwise, you can give them Valium, Versed if you're treating seizures. Like I said, there's a whole list of medications they can have. I'm just trying to hit on some of the big ones that we generally have on the truck and things that we're going to see. Deconning your canine. Anytime that you think the canine's been into something, you need to decon it. If we're going to transport it, even if that means we're wiping that canine down in the back of the ambulance as we're treating it, do so. Because that's just going to, basically, you're just ruling out that, hey, whatever's on them isn't what the reason is that they're acting the way they are. The only thing to remember is don't use alcohol wipes with canines. It needs to be baby wipes or even just sterile saline on a cloth. Using alcohol can cause them to go into hypothermia relatively quickly. And then obviously if you have the option to give them a bath, just water and dog dish soap is sufficient. This is just kind of some pictures of how to decon. Start the head, work your way down. Make sure that you get their tail, their scrotum or genitals, and then definitely their paws and in between the pads of their paws. Any questions?
With cooling, and trying not to break it down too fast, is cold packs and IV fluid, is that too fast or is it just?
No, so you can use, you can do that just like you would for a human. Just, you don't want to throw them into an ice bath. We're just the same. If they're super cold, you don't want to just throw them in a 100-degree room. Cool them down slow, but not too slow. And then same thing with warming them up. You want to warm them up slowly, just not too fast, because it'll throw them into shock just like a real human. Yeah.
So I was taught when I went to Shallow Creek Kennels that they told us if the dog is overheating, you could put alcohol on its paws to cool it down. Is that not?
Yes. No. So you can do that. Just saying when you decon, like if you're going to just decon them, don't use it because that's why. So they have a pretty quick absorption rate through their paws, which is why you want to do that. And that is a slow enough process for them to absorb to cool them down. That's not too fast, if that makes sense. So yeah, absolutely. And if you have alcohol wipes, that generally seems to be the best. Just take wipes and keep wiping their paws off. Any other questions? So I do have canine field operation guides that I make and sell. If anybody's interested in that, just let me know. I also have cards that have all the classes that we teach as far as canines and that stuff goes too. So any questions, comments, concerns? Anybody want to see the dog?
But as first responders, I would encourage you to get with the dog team. And if you ever go to another symposium and they don't talk about criking a dog, I would question its validity of how good it is. But we need to really become more familiar. First responders, you need to get with these canine handlers because special needs kids have affinity to water. So whenever a special needs kid goes missing, they're calling out everybody, and it's generally the cops are going to show up, and then they're going to call out the fire department because that's where the mass of people are. and try to go out and find, well, time is of essence. So if you have a local canine handling group, she said, get with them early. Put time on your side to help find them. So I encourage first responders to get with these groups, to let them come work and show how they can benefit. This is something that it's going to become more prevalent to run into, because canines are really becoming a big part of the society. She said that they're recognized by the state, the medical directors, they're recognizing these assets. So we really should be familiar with some basic stuff, and I picked up quite a bit. And Paige, being a brilliant person is what she is, she also covered medical assessment for humans, trauma assessment for humans. She talked about needle decompression. So subliminally, she got in all the medical stuff on a person while talking about the dog. So she covered several aspects just in one simple lecture. And it is great. We wanted to think outside the box and bring something that is going to become important to us that you just don't get exposure to at very many places unless you just go to a specific canine handling group. So any other questions for Paige? She's going to have cards, contact information.
Yeah, so our hands-on stuff, so I've got some simulators to kind of give you an idea of the difference in starting an IV in a canine or cracking a canine versus a human, just a little bit different. And then the other thing is too, like you said, with your autistic kids especially, they're more apprehensive to head towards water. So these canines, if they're trained in that, we can literally get them out of the vehicle and they'll start. A lot of times they'll be able to tell us that there's somebody in that water as soon as they get to the shoreline. So they're pretty brilliant. They can save a lot of time. As far as, your law enforcement guys, if it's a cold case you're looking for, it can be 100-year-old bone. We take them out to the cemeteries and they'll hit on those. So yeah, there's not a whole lot that dogs can't do. They make easy work, and keep the time down. Something that, like I said, may take us 12, 24, even weeks to find, they can find in a matter of hours.
So I've actually had a canine in a boat and was able to search the lake. The dog was hitting over the side, staying in the boat, but hitting over the side. We did circles, tighter circles. There's where you send your divers.
Yeah.
It's really saves time instead of just going in and just start doing a grid system and all that. Underutilized, need to be utilized more. Thank you for coming and talking to us, broadening our horizons and our knowledge of what other assets and tools we have out there. We just don't think about it. So a big round of applause for Paige Bush. I brought Matt up because we're going to take a break until 11. And then at that point, Matt, what are we doing?
So we got 2 different skill workshops. Paige is so kind to bring in her trainers that she's pretty much made up or bought and done. So we're going to have one skill station over here, probably in the little makeshift apartment area, since there's a nursing class going on next door, the room that we were going to use for them. So we're going to put them over there, kind of divide up equally. We're going to spend about 30 minutes with each skill station, and then about noon, lunch will be served, ready. We'll eat for about 45 minutes or so, and then get Miss Stephanie started on the next lecture. Get you guys out here at a decent time. So with that, if you go directly across the hallway, we've got pig lungs, crikes, safer airway. If y'all are interested in RSI, want to know how RSI works, practice it. We'll go over our safer method on how we do RSI here at PHI. So we'll run through that way. We also have a salad mannequin to practice airway decontamination while intubating. So there's gloves in there. Don't get anything on you. It's like ranch and orange juice and stuff mixed up. It looks and smells like puke, so don't get on you. The pig lungs are real pig lungs, so make sure you wear gloves. There's gloves in there as well. So that, and then if y'all have not seen the new AirQ airway device put out by Boundtree and somebody else, it looks like iGel and King Airway had a baby. There's that. I know some Louisville departments reached out and they were kind of looking at them, get a feel for it before you send it to your training officer or supply officer. They're like, hey, we should order this. And you get there and realize how good or how bad it sucks. So,
and for you out there on YouTube that is watching this being streamed, and Alyssa wants to be like a cool kid, and Trey is not a medic or an EMT, he just was looking for the information. So it's awesome you guys are there, but come back at
12:45.
At 12:45, and so you have until then, and then we'll reconvene and start with the next lecture around 12:45. Thank you guys watching online. We are now on break for you in the classroom, and then we'll split up at 11 o'clock. Dismissed.
There's a snack maker, the rodeo.
If I were to be here in just a little bit,
It's really nice.
get it done with it. She's at about her point.
Ah,
I think the cheapest knife I've found there.
Anything custom you want.
I talked more with Cassie.
Like, go look for a custom.
Yeah, Kendra's up doing the working girl and stuff. I can snap Cassie doing her thing. I'm showing her I'm doing education. First one I talked to.
No, but
I guess there's a QR code for that class. Oh, dang it. Yes.
I'm gonna have to do all the QR codes.
Let me grab that.
I would never.
Can you put the QR code up for that last presenter?
I knew that.
You know Charlie's dad likes that stuff too.
No shit.
Yeah, Tracy about Charlie. Yeah.
You gonna do the RSI workshop or they can get I'm still yet to do RSI.
Really?
I saw a doctor. It's exactly not, I gotta do anything cool. I'll take it along.
You almost get to
They had me in Litz last night, so when I get here on time, and of course.
Yeah, because I'm not at,
When I was supposed to, I decided to go to Fort Seymour.
Oh, our, Tracy?
I don't know.
Well, it's still late.
Yes, they get blood or not.
Yeah, I'll take it back.
This was Kelly.
You can put all my information in for us?
I'm not your.
You're my secretary.
I've been pretty good.
Trying to get out of your way.
My head prevents you.
My phone was here, your head is at the perfect angle.
Well, it's not the head, it's just the phone, it's just what gravitates to that face.
That's pretty cool.
Will she be here for the? So we have, I just didn't know exactly what we had offered. Page, Bush. Luke, please, can you get the one from the one before? Yeah.
Click back.
This isn't gonna bode well.
Yeah, I got it pulled up. This is the one that's,
Just go back where it says back.
there you go. So if you want
Just like,
to, you can change mine.
Oh,
There you go, we got it.
never mind, John.
Oh, no, I did it. You're gonna scan it. I did.
I don't know if you remember we met
So did I.
on the airfield with Alex
Oh,
when I was doing the ride-along. So, but Austin, working Plainfield.
thanks for coming all the way down to Plainfield.
Oh, I live in Edinburgh, so.
Oh, okay. So not that far. Good stuff. You got the stash going on?
Yeah, I will say I didn't have that probably when I, yeah, so.
One of our local cops, Jeff Neese, I think his is like 18th century out.
Yeah, I don't think I'll ever get to that point. I think this is probably as far as it's gonna go.
Do you see it out of the corner of your eye?
A little bit sometimes, yeah. I'm just trying to get to the point where I take a CBA off that stays. You know, that's when I know I've accomplished a lot of my, you know, so. Yeah, no, this is awesome.
We're glad you're here. Hopefully, come back
Dr.
next year.
is, you know, super smart too. We watch his stuff if we're on shift and he's doing his, one of the guys has his email, so we usually put it up while we're on shift and watch, so.
Because as I stated, he talks to us and not at us.
Oh, yeah.
You know, some doctors just, well, all of them are brilliant. And some of them just kind of lose track of their audience, or as they go on through their presentation, they revert back to what they know, and that's, you know, presented to other physicians.
When I was going through med class, the head physician for our class that oversaw it and everything, we were under his medical direction. He, it was one of those things, he'd be doing an A&R, then he's off in doctor lane where I'm like, I'm just trying to understand this at a base level.
Yeah, I don't care how many times that cell's going to split. Just tell me how oxygen's getting there. It's all I care about.
Right, exactly. So, thank you again for the opportunity.
Oh, it's PHI, it's Matt, and it's my boss. Because my boss is paying us all a whole lot of money to be here.
There you go. You need that.
So it's coming out of his budget.
There you go.
There was one intimidator instructor. He was a helper skill. I'll never forget when I walked in that little room. So claustrophobic. You and your son were sitting there and I'd never met you. Yeah, he was nice.
Oh, okay, then I'll keep
He was
talking.
sitting back like this and I thought, you just intimidated me so much. And then I got out later, you know, you're like, you're like, take your time, you got plenty of time. I know this stuff. And your son reached down to get a drink and I said, yeah, anything to eat or drink? Then it just starts talking.
He and I spoke because he's been with me on several. And I'll never forget what it was when I did my practice. There's so many people that want to just let you know they and they want you to know how great they are. And they have forgotten what it's like to be the one being tested. So I never forgot what it's like to be tested. And there's going to be a couple of things that we also know that if you go in and you're just everywhere, you have to kick a box of gloves at you or do something. And it's like, hey, I'm sorry, I didn't hear you because I'm deaf. Did you say this? No, you said that. Oh, okay, all right, good. That's all.
Well, I'm coming out of your scenario thing, and I just lost it. I just bawled. I was I said, I just failed that one. I'm gonna have to repay. And he said, well, maybe you don't fail it. I just feel like I did.
Yeah.
Unofficially said you. No, I will. And a lot of people I'm surrounded with do not do the spirit guide. It's not there to wait for you to make a mistake. I'm waiting for you to do great. I would expect you to do great. And if there are, I'm going to ask for clarifications to make sure we're both winning.
Right, and that was, once I got through that and started talking to the gas person, I realized, hey, when he says, are you sure that's it? He's prompting you. He's trying to help you and not say, okay, you failed.
I realized that
So you heard
after
some of
the fact. So yes, I caught that. It just was, you know, there was like 10 of us and I was the only girl there and hadn't been on the fire department in a year then.
I've been in EMS for 20 years, but I will never, because I had to do the practical for an EMT. Basically the same thing for the advance, except that IV, basically the same thing for a paramedic, except had some trouble leads, same thing to do a PI. And I did that assessment, and then every year, like Stephanie said back there, I have to go and do an assessment for them. So I am the student more than the person grading, so I will never forget what it's like to be on that side of that table.
Well, I knew what to do for an EMR because I went through EMT class. This is years and years ago. Hugh Gardner was my instructor. My Bill was my second year. And I would go to Jeffersonville and ride with Mike. And he would let me do hands-on up till what we learned. I did my first nasal pharyngeal in jail, you know. So I knew. So, do you remember Junkie? Okay, Ton Pub was my partner there in State Farm. And he would Annabelle, so he's choking with you. I said, I'm gonna tell you what to do. And he's so hard. And you know, of course, they're laughing. And I was smaller than
It's like the way you said, but you're speaking the truth.
and I was a lot smaller than I'm standing here. They said, now what are you gonna do? Yeah, well, I made him like, well, even with that, I couldn't hardly, there's no way I got like these. I'm standing there like this.
You're easy with the touch.
No, I'm standing there like this trying to do that. And they were like, oh, just keep our dogs. And I'm like, well, it's kind of hard.
Yeah. You still are, being successful.
I consider going back for my EMT again. Like and dummy me, I didn't do my state written.
Oh.
And then I had up to a year, I found out I was pregnant. And back then they said, well, you can't drive on the ambulance since you weren't doing it before you got pregnant. Back then was, we're talking 90.
I was 491. Okay, I'm lying. Get bullshit. Yeah, but I'm pushing hell.
Oh, no. Yeah. So, yeah.
I'm glad I was nice to you. It's rarity.
Intimidating at first, but not.
Oh, yeah, so we use we'll use those, I'm not. But no, yeah, I mean, absolutely. There's a lot of departments, I think Jackson County. I know, our part of Jackson County. They can be using on people.
My team's based out of Big Work County, Terre Haute, so.
Yeah, they work on that. We had a while back. Well, yeah, I know, it was as big as this thing. But it was about this big. I had a table to look around.
I had girls back in the day, like,
Fine, I would. No, it's more. Yeah, so you have, and some of them are just a lot more, some. And see, that's what most of us do. You got mine. Specifically for our down line. I mean, ultimately, you can use, we're riding a bit at 7 if it's long enough, or even 6 if it's long enough. Just trying to get more. So when you innovate that, you're gonna go all the way to and it's not a black one, you know, right side.
Oh, I remember getting harnessed.
But head on. So I can do it like doing that is like you said, it's not possible. Yeah, landlord wise, those are just the same as a lot of those, you know, depending on your dog is not going to come this thing. But yeah, there's. People don't really. Nowadays too, so there's a lot more. Yeah, I made, so I looked in other things, they made canine. I've seen gunshots down there. Yeah. 3, 4, I brought one of those. $72,000. So, I went to the trial, I made these up on my own, same splints and y'all. I thought this was. Yeah, so that's, so I have to say that. Yeah, you can do that, and then, yeah, this is literally what they, I pulled it off. Yeah, that's just a tape, that's like there.
I was gonna say, we're at.
So yeah, you can feel her. Yeah, you can feel her, it's very comfortable too. Yeah, size wise and stuff, it's very comfortable. Very nice. That looks like a lot of fun.
They remind me of you.
I'm not in passports, so I should know.
That's one thing I like about the scatter text.
Our guys were part of them.
There you go.
I think I'm like the only one on there who's not military. And I, when I got on that, I'm not the only one. Yeah, I was pretty proud of it, and I was like, you know, they're like all military guys, and I'm like, yep, nope, I'm just gonna do something, same here, wherever you guys. I know their passport.
I got it.
Oh, okay. What was the one that we had?
Yeah, well, it doesn't even, chiefly. I remember that one, Bill.
Okay, so it's like, that's something different.
And then just walk right back up and I can totally look for it and be like, oh, I'm gonna do it.
That's right.
But then it's a mom and then.
Yeah, sometimes it's better to.
On the very end of that table, my page,
Yes.
flyers and I got signs. There's a lot of stuff. Oh, that's good. No, you're not getting signed.
I said, why do I feel so low?
I'd rather do that. My opinion.
I thought for a hot minute that I didn't go on that. Like, I wanted to get all my dogs there, like I want to rescue.
I think it'd be cool. I'm on a squad now. Just like to be my guy. We do all those things.
You guys are on like all your specialty rescues and stuff, you do that, not so much.
So we go on that, but I want to sell it. We have 2 offers. I want to have one. You have one. So that
It's like we're trying to,
it's a network.
Right.
That's. They are contacting people or don't have the tax for it, then they.
Very nice. Yeah, I can back there.
This weekend, we've got a bunch of people coming from, out of state and in-state, but all different teams.
We met one time.
Yeah.
Yeah.
Some of the calls 3 hours away, call these guys, it's gonna be a lot closer.
Right.
I'm more so on the actual training.
Last summer.
Right.
That name of Michael.
I'm glad you guys got it. It was Sandy was asking if you brought her. We need to get her guy, she's got, Bill, my name was asking. Oh, yeah. Bill Matney. Yeah, I know Bill. I've been in those spots with Bill. I love
Great.
Oh, sweet.
I think next to this time.
Does he go up to ACC with them? I'll be there.
I didn't know.
Yeah, Bill comes. Yeah,
We're actually talking about the same thing.
Yeah, Bill, I love Bill. I've taken lots of classes with Bill.
Busy right now.
How do you do that?
Yeah. Was that last year? Yeah, last year I didn't make it. I was supposed to go, and I ended up having surgery like a week before. And it's like, yeah, I probably should be on the road. Oh, sweet. Yeah, this year I'll be there.
I'm excited.
Yeah, I just told you, I was like, hey, I'm going to UTC. I'm like, I'll be free.
Last year's the first year I missed.
Yeah, I'm comfortable. Yeah. Bill, where's he live at? Here's my guy.
A firm staff back there.
I mean, I figure he's down this way somewhere. Okay.
Yeah.
Okay.
Yeah, I know. I told Marcus. I got to know.
Okay. I know Chuck. Okay.
So I follow along.
Okay. Oh, nice. Yeah, I like it. I've done lots of classes. I've done all my water classes. I've done
Yeah, that's all right.
I don't know if it's so nice.
Yeah.
Yeah, the last time we tried to have an ice racing class with Bill, it ended up being like 6 hours. He's like, well. Yeah. Yeah, because like I said, I live in Seymour, so that's only 30 minutes of that. I'm good for all the time.
I think it's just.
Yeah, no, like I said, this was obviously condensed down version, so in February, I'm having a seminar in Seymour that I go a lot more in depth than all of this. But yeah, we're trying to push a lot, they're just.
You've got a cold part-time, so it's like kind of hit and miss. I live in town, so
Okay.
if there's anything.
Right.
Say what else we're supposed to do.
We try to staff.
We're gonna talk about
John works in Seymour. Yeah, I love John, he works in Seymour.
Yeah, yeah.
She's got.
Okay. Yeah, I love John. Oh, yeah.
I walked in all day and I never met.
I know we only meet like once a year, but I'm not.
Oh, I expect.
Right. Yeah, you are the smallest. I know you're so mad. Her parents in that, in the. Same one. Yeah. Does she need her coat on? No. You can take her coat back outside when you know. So I used to not, we were in Wisconsin, and I guess maybe in the dump, I didn't realize how much cooler it was when you're out there by the lake. It was like 50, 60 years, like, that's not bad. Yeah, it was like 30 degrees up there, plus the wind, so I bought her a coat. Oh, I have all kinds of, in fact, the coat she has now, I don't know where I got it, it was like $10, and I was like, you know what, $10, we're gonna see if we wear this or not. It's worth it. She was freezing when we were in Wisconsin. Oh, me and I forgot my. So that's the dog that I said would never stay in my house. That's my dog. She'd never sleep in my bed when she was a dog.
How are you?
About a day later after I had her, that all it is. Right. Oh.
Still like her. Still like her.
Oh, she has a child. Nice. I got that face. I got it. She's got a dog she wore it. She wore it at Halloween. Yeah, Nitro's got her, she's got her vest and her goggles. Where's the other one? She bring Nitro? She does great. That's the first time she bring Nitro? Yeah. Oh, yeah. Yeah. So I'm not gonna lie, I spent way too much money on her. I got that. So mad.
It's online. So.
I'm not gonna lie, that's why. My bike, yeah. Yeah, no. She's out of Debbie Triplet comes from, I'm here in the spring. She came down there.
And then it's still on my.
Okay.
Oh, look, you have the QR code for the canine.
I know,
Over by the arrow? Oh, there we go.
Yeah. I know exactly what you're talking about. I'm not on her name. She's, yep. Yep. I know exactly what you're talking about. I cannot make one her name.
Kaylin, I need to call.
I saw her.
They're getting ready to pack fly, so they won't have to.
Oh, so they didn't fly everybody first.
Okay. Yeah, like I said, I can see your face.
Back to free lunch, so like,
Yeah.
I,
Burn all the jet
Yeah,
fuel for that.
It's like, when I kind of get started with it, I'm obviously kind of for a while. And I work in Scott County, LA, I'm sure there, so. So in Jenkins County, I just, I didn't. The training director had a little bit more leeway, my boss. I think he was working, when I worked at Firehouse, my heart is up there. Yeah. This is pretty fun. But as far as teaching classes, especially this class, or law enforcement. And they get on there like maybe an hour when we go to like when they do their
BSSELMAN. I don't know, so I didn't register for it.
I thought they were going, but good buddy. He's like, man, I get like there, you know, have training, like, we want training. So I had Dr. Lisa Bruce come down and get it in the class. She's so hard to get a hold of. She doesn't, she's a full-time vet, she owns her own vet office, so she's like over there. I don't know, basically she does all of law enforcement.
The one where you can look, see.
I can't she's very much. So I was like, what can I do this? I go, what is her opinion? I swear to God, you don't have that target. You're a medic, you got experience, you got K9, you got experience. She's like, set in my class, all these more training. So I did training with her, I did stuff online. I did take care of she taught that class too. And I put my presentation together. That's kind of how I got into it. I didn't realize the lack of training there was for that. I didn't know how to do it. So yeah, I started out.
We got it.
Training. We're talking like one class. Yeah, they were all the kids, to be honest, CPR, for yours is tax write off for me. Now that I've got to pay now, it's out of two certain classes. I've got other people that come down. Kathy Adam, FBI.
He said they drove.
I don't know her. It wasn't.
They're gonna fly in for
it looks very gloomy.
Oh, yeah.
Yeah. Yep, so, yeah, so I got to know them because they're stuff, so we're so I get us to teach some classes too. I could just keep expanding here.
maybe. The whip bands are the same way they have to be.
So Jeff Craig and my ground teacher, I Washington County joint forces, and we're in their Floyd County. So we just go, we go out Indiana, we find search and rescue, this canine ground, let's get rescue. A lot of us are fire EMS, so like, there's several of us that are. Yeah, we're all over Floyd County.
She knows her like.
Right?
No, thank you.
Absolutely. Yeah, because the real rescue, I just assume send you down than I would myself. I mean, don't get me wrong, I love it, but there's. I guarantee it. I guarantee it. No, we would definitely.
It's about, it's about.
No, that's right, that's what I'm saying. Well, because mean, you're not just one guy, but like, my fire department, I'm the one that usually sit down for that reason, because all the guys are big enough, and I'm like, if I find somebody smaller than me. I got it, Eric. Yeah, I am.
Yeah. Brandon was attached to.
Easy way to see it. See it right there.
He pushed his feet.
Yeah, I'd probably try. I'd probably try. I'm not gonna lie. I don't mind heights, you know, when you really going. Right. Yeah, I don't mind heights. If you're like, hey.
I guess where the EMS is so close to a hospital.
We're supposed to, I mean, if we have to.
Yeah.
Even our, the one where you cut. And the there.
Okay. And you guys didn't even hit 5? I believe it. Jason's a big boy. I have just. Yeah, I was like, it's a boy. It's been a while since I've seen him, but I can't imagine he's changed the holes.
But we haven't, no. It's like a, there.
Right.
Oh, yeah, I did that. But those. When I've just been on that.
That's nice. Skype and not have that. I saw the time to manually do everything.
So you just do it when they're.
I'm back here.
You don't like here and there.
Oops. We have that leg fall off. Just so happy.
Yeah, you're gonna do it.
She was drunk and she lives out there in the cabin. Drunk and got too close and fell. That's the only reason she's alive. So the fire department was on structure fire, which they're just having some rotations. It just so happened I stayed over that night because there was class going on. Even though somebody else was teaching, I was like, I'll stick around in case they can. That call comes out, I got a basic. It's automatic.
Yes.
All right, cool. Thankfully, I don't know if you know Andrew Wiley. So he's a road tech as well. And I was like, Andrew, guess what? We're going. I was like, I'm gonna go with you. All our road rescues. He goes, that's good because I don't think we have any.
Right here, minutes, right here.
Like we talked about maybe how.
Oh, what am I doing?
Right. Plus. She probably had a rock.
Yeah, we went to, used to.
Right. Right.
I don't think so. We didn't even have Bruce here.
I'm scared. I don't think I've met him, but I think I know who you're talking about. I think I've. Okay. Fair enough. I mean, I guess you got to
It's like, you use a needle, you have to.
I guess there's pros and cons to being little. I mean, that makes for helpful stories. Oh, yes, I do know who that is. I've never met him, but I know who's around. I've seen him around. I know who that is. So it I was
His other half?
His other half told me it was supposed to be.
See, we didn't have one.
I couldn't tell.
As soon as you come in, then you would go.
You're fine, you're fine.
Well, I'm not with them, but I'm
Good,
just saying.
good. I would say keep it.
He knows who I am. I know, but he's the only one who can call me like. You should have seen it.
I like to make people together and
I got it.
No.
So now I can't.
Larry, what's wrong?
She said she got 24 friends. No, rescue 69 back in mid-80s.
1900s.
Mid-80s. Just a record, you're older than me. Yes. So you wanna go to the. Oh, okay.
The other shade, I don't know, there's the other shade where it shows you where to go. I know that, I know that.
Oh, I just have time. Carrie's done.
Yeah, that's right, yesterday.
And she was having a baby, walking out, she's got this big old.
Oh, there's the hospital, she is what she is, what she is. It's right, I love it, so.
It's full of Cheetos, cheeses.
Candy bar wrappers.
How the hell is that?
Take this, all you have to recycle machine. I was just saying, oh, you want chocolate?
It is.
Oh, you love it.
I know.
I'm working on it. So more of the healthier.
So y'all just look at me like, and I'm like.
Yeah, they don't.
And I've got 3 brothers.
They will. Probably not, I mean, not that good.
So do they let you like special service?
No, I'm not really, they just signed it.
He said that.
I was like, we're able to go.
Yeah, that's not great. I mean, I felt that was the longest.
Yesterday, I seen her coming out of school. The girls, Julie's daughter, Jessica's niece, picked her up. She gives her.
Abby and,
Hannah.
oh, that person.
They picked her from school. She just seen her at Walmart the other day. Her stepmom's name.
She's not on the part-time.
Yeah, well, she had her at Walmart the other day and I said, hey, Leila, come here. This lady was. I think that they told her, I think Tessa told me putting her out, so she could be just very good. See, they live in a gated Tessa and up there at Big Oak here, like $80,000. Up there right next to me. He's got his adjusted up there. Yeah, he said.
What else did he have?
They were buying stuff to make license and but she was so happy. She just smiled. And I see all this post and I just, you got it.
Yeah, he's made a few TikToks.
He shared this yesterday, and then, I mean, how people change and you know why they do that.
It's not easy to get sauce.
I was in charge of the food.
Did you see that they had different sizes out there?
Well, these are 18.
One of ours is so we can use tiny needles. Have they ever heard of 122? 122.2?
Big beans. Salad, steak chips, cupcakes.
All right, I've got to go ahead. We can go ahead and start eating lunch. That's been provided by Norton King's Daughters EMS/hospital. So if you want to go out here, we got some pulled pork, or maybe it's brisket. I have no idea. What is it? Pulled pork and some sides. So all kinds of stuff. So let's, whenever you guys are ready, we'll line up, start eating.
Do the rodeo. Let's go eat. Come on, girls.
I didn't know. The farm place will have enough. Yeah.
Saturday, maybe we're There you go. We do everything.
I don't care.
Yeah, my certification.
Yeah.
Until a year out.
So you can do it, you can do it?
It's well, it's not, it's right just past it,
They just got done with inspector one class.
This was the standard.
If you have a hard time getting hold of me.
I think we got it all.
Five large ambulance.
Excuse me, sorry.
No, I pulled it out thinking it was one of my Novell shirts and it had this, and I'm like, I'm not changing, I'm like, digging for it. I don't have my winter stuff on yet.
Jennifer, you got me? You're going back up.
I don't have all my winter stuff out.
No, I just got a message.
And no, I don't represent. Oh, idiots.
Leslie said yesterday that we're supposed to be getting. So I'm gonna start raising.
This time of year. Yeah, $100 I give it.
I'm still having to eat outside to put one back in.
No problem, yeah. You're kind of my boss, so I guess if you want the plan, I'll take another one. Guys, enjoy. We'll see you guys later.
Probably truck parts. It's probably the truck parts or radio parts. I don't know. You know what it is.
You never have any ER week.
When did you get an email from her?
A few weeks ago.
Now it's 3. Caitlin.
She's really sweet from the start.
I love you.
I started, she's so sweet. I like her.
She's funny. She's hilarious.
She's always so really sweet. Yeah, I saw her in math class. It's great. It's her class.
And the lid. Don't get it. Me with no lid doesn't get it.
That'd be better. Today's the first day when I put a charger.
This charge is makes you feel easy.
Will they get rid of dragging in the, yeah, and the sharks will take much of
I was there, I tried to show it from that, and it's rather than last time.
Yes, did it not go through my sentence? I'll remember this. Hang on. And then, I do my mind checks in the morning.
I just know that we only have 3 years free.
We had like our 2 days really big.
I can promise you the stock here and stuff has changed since we. So what's happened? I don't know if it always did a good job. Hank does every now and then, but it's so busy down there. But our stock. That's why when I work every morning, I usually go stock all the deals, I try to do all the exotics.
It doesn't really get done. It's more just like ordering the supplies.
I did it the other day, I don't know. So where Emily is or what she's doing, but we'll have to make it work. We're out of space.
And one day I was
Yeah, back on that.
wow. Three actually. I think that's 3 extra. 3 extra.
I don't know if you need it, but I figured you didn't have one, so.
Probably. Yeah, that's right. You don't want to play.
They didn't have an adult one either.
Yeah, just goes to the internal lab.
The only one that says secretary, mine is the secretary, because my school's and I have
Wait till the, yeah, I used to have to do, get ready for state. We had a lot of stuff. Like those cards, they don't stay stuck at all. We can't put that in. So we need to do.
I remember you go, oh, that's cool.
Yeah, she's always sucking up the one.
So Brent, we're gonna be at first Tuesday. Start rolling.
And they know I'm predisposed.
Oh, absolutely. I was up there.
I don't know, but you have to share it out loud.
Oh, yeah.
Get out of my face. I don't have time to read it.
Yeah. I wish we could do it. I really want to, it does, because.
No, I'm telling you that on top of that, and then you leave over.
And I'm kind of where you want to go.
Well, we're all talking about stadium, so stadium pretty much got sold. And every time you school, the only one requirement.
People say I'm loud.
Right after that, all I heard was, woo, that's cold.
They're allowed to be in a way.
And they allow them.
Matter of fact,
The radio. Why should I'm gonna go ahead and pay you.
Why didn't you want to try to think?
Yeah, it's slammed right against the wall.
No problem.
Caught on fire. Whole fire showed up. They laid probably 1,000 foot of fire.
I put it in. That's a lot of fire.
Because one only carries 800
There's not a good hike.
We've got another full pan of pulled pork that hasn't. So please feel free to get seconds or thirds, whatever the idea is. We want to, let's just obliviate it. The cupcakes were made by Tom George Johnson's wife. They are whipped cream icing. What did you tell me?
Cream cheese.
Cream cheese icing. I mean, she's a professional baker without a store to bake out of. So those are handmade especially for you for this day. So please go back as many times as you can. How much more weight loss? How much weight loss? How much do you want? Okay. Well, you know, how much you gain, as much as you can. Yeah.
or come out somewhere.
She told me I left. She said.
Driving around, girl? That's done.
She went to her room. They had a room. Did you go in there? No, cause I was first. She wouldn't want to go. She go back in there, she called and said.
She's still waiting for your answer, right?
He was introducing everybody to PHI. He was really proud about that. I said, what about learning? And for children, I know, like, to actually take it.
Now, she has drills. She was supposed to do strokes or something, but.
Blood pressure. I can make that with her. Just we need to realize, yeah. And then she come back the day after. I was there two. The other day, Randy was in Shell where you sit down.
Materials and 200.
Kill all this.
I was about to get that.
They're next to the road, we brought her to the hospital. And, they discharged her, she went back, and they had to pick her up, she fell on the steps.
It was
Down there,
not.
on her little face.
It was not.
Not bad. She was charged, didn't she? Yeah, but. You got. Well, you.
Arm was pulled out front.
So she sometimes does.
Oh, yeah.
They got lucky. Shoot a lot.
Next time we'll just call PHI and
This one got road rage. So,
He must have left.
Yeah, he had to have left. Took his backpack and everything. Yeah, oh, I guess it is.
I got to know where I can get care.
Somebody got killed and gone.
Yeah, it's a really early. Well, it's be Dr. It's on that, supposed to be in that, placement or something, it's like using that. Ever since he had his heart. I told him today that I gave him a nickname of Steve. Don't you just miss over there? I do too. I have one. Our AED is on, is, you know, and I'm like. You gotta use AED. I use my own. Did you ever know well, she was there. She would do your all of it. That's it. And it went with that secret, but she told me. She would call on the radio to be there, wherever. Before she started having aneurysms. And she started having brain aneurysms. I wanted her to drive.
Okay, let me just jump on it.
Marty one time. She said, now I'm not lying. And she had a big, she had tons of, she'll pay. Those coals in my hand. It probably won't go stop.
I really do your job. Like, she couldn't live. She couldn't go down there. She can't live her. I was gonna be able to drive to because she couldn't do it. And we were actually there. Little virus. I
remember Alan. I am not dealing with her.
Jeff and I went somewhere with them. And I was like, wow.
I just took.
Yeah, I did a good job. That's good.
Yeah, basically it is. Do I smell like it? My household.
Danny lives up there. It's a moment. That's different because the hospitals do
Someone across the street.
I was with them. He was driving. He was driving and said, I haven't tested you. I don't listen. We turned around and went back up to him. So the driver is letting us pay out the patient. The patient was in one bed. She went there and kicked off and put on her feet.
Wife and I are both on secondary, so, you know,
Yeah, Mark was yeah, for a while. I know.
and she's like, no, we like our chicken, we like our chicken. But, when I asked her, she's like.
And the blusher was new too. Oh, remember the day we lost that 11 film. What's his name? You're right. Him and I. God, kill it. Yes, right. That's what it was. God. Yeah, I know. That's the day we went over bread.
Separated. So I asked the kid, I said, sit down over here, so what's everybody want for?
That's what it is.
I got
Maverick, that's what he called him, Maverick. Oh, Ashley, that's with him, and Ashley actually went. He's sitting there in his chair with his, Maverick sunglasses on his set. The night we went to Deltera, they were driving my car, and they were fighting until we got there, and I was like, hey. Then we get in the elevator. Was it Diane was talking about that last week? We're sitting there looking at each other like, oh my God, we're so vintage. Yeah, I know I was drunk too. We just walk in the elevator. Then get back and take it out. That was bad. We went to had karaoke. We just knew we were. Jeff made a big old, I mean, it was big, oh my God, it was horrible. Yeah, I got there like 7. It's so bad, Rance, so bad. And he even asked me to go home with him. Thank you, Matt. We could just throw it away. Thank you. Don't work out. Thank you. Well, she figure Amanda, medically don't work out, you know. Might be an okay dance, but it's the first time we've ever.
Adam is a breaker.
Great.
Did you get that? My first couple of weeks, right now,
This class, you got
I don't know.
Codes for fire and safety.
Oh, yeah.
Well, I was trying to watch
I was just at
They were fun days. Yes.
Well, that makes
Oh, Allie, oh, Allie can't come out, she's not out somewhere. I know he is. You'll never see, you won't hear from him for years. So I got. When I yelled at him. So they had to go, I had to work my favorite.
I wonder how she ended up by half and then I know
I get the script, I'm driving, I'm walking, So I go on the station, I say.
I'm sure he got that. Even if it never showed. Honestly, want to go with the dance. Just because doctor says they're good doesn't mean they're good. Sometimes. It's a lot of. Go in there with a show.
Well, I like it. They're almost. Sure.
So we really don't know if he just going to be.
Absolutely.
That'd be good, that's a good I like him. He won't be. I went down there. Oh, Jeff. He cracks.
I get the emails where we can just sign up for it. To be fair, my schedule is work full time.
By the time
Like, I don't know how you felt your
Really?
Like, it started off real good.
Real good. They are sharing.
But at the very end,
I don't have my record.
but it's like.
Yeah. I'm gonna do it. I don't know. I was gonna do it here. But by the time I get all or I can do it at cheese. It's all online.
It's like that was silly. I get the idea behind it, but
What does it take?
all it took was at the end of the.
3 semesters. 2 years.
One of the guys I work with.
Did you do it wrong?
Is she still going after?
I got the email. So I have one to take the
Is that his first,
these. Well, you gotta take the team's test. It's math, but then you have I'd say that's an hour of physiology, right? Is that through? No. Science. No, I think all you gotta take the team in the hospital. I never pretty much.
You don't need to get that much.
It's hard, but obviously.
I wonder if there's other programs that you ask about. Could be, could be.
I was frustrated.
I go up there. I have a voice, but must be like, this is It said it was driving. But they wanted to set up.
I missed that. When I came down here, it was 6 out of 7.
That's something I definitely learned. Once I got a lot of the things that we let bother us, I tell myself now, I don't know what that's what I'm sorry that happened.
They don't want them in because it just says the piece is being weird thing.
How much is, a class, what do they? Because I know I'm not gonna get one. You're paying, you know what I'm saying? I'm paying this money. I know.
What was your second class like compared to our class? Like, did you guys do good? Because our class, I feel like was big.
Originally gonna buy. Going on the market by 10:30. We missed out on that. And it was one of those, kids on.
Yeah, he's in there now. Yeah, exactly.
There's some states that.
And he told me it.
There's some 63.
Yeah, you need some chapstick?
What do you want?
Keep them sucking.
That's correct.
Wait, maybe it's succulent.
That sounds better.
Oh, no, I was,
He's like, I think he I don't know what he is. He looks at me like, no, I don't need your help.
should be. You go find a seat. There's some guy. Don't do it. All right, we're going to get started in 10 minutes. If anybody would like to go back out and help yourselves to whatever's left, I assume Dave's probably going to take it down to EMS, but he'll probably take it back to his house because it's kind of cheap that way. But please go fill up a plate. It's all right if you sit, snack a little bit. So eat when you can. And so we'll be getting ready in 10 minutes. Where'd Dave go? You're messing up my scale, Dave. Well, whenever I say hold on, that's kind of a sign. So we want to be sure and mention our sponsors. Ivy Tech, Carmen Elliott was our point of contact to help set this up. She is in charge of the paramedic science program. Nucor, Kentucky, we work very closely with them. They supplied the breakfast this morning. We appreciate them for that. Norton King's Daughters EMS for providing lunch. The pulled pork was made by Dave Dilk. Stand up, Dave. Are you still doing catering?
Not anymore, no.
Wife makes too much money, you don't have to.
You understand.
Yeah. We know how that goes. So, you know, I've been around for quite a while, so I have personal stories with like 75% of you. Dave and I were neighbors back before he got rich.
But Johnny was rich at that point. Well, sorry, the wife was rich.
So he was working on learning how to smoke meat. So I did my part to encourage him by buying this meat. We'd sit in his driveway, smoke meat, drink beer, and then he and his family would come over for dinner, which wasn't part of my plan, but it's the way it worked out. So through all those conversations, me teaching him how to cook, he thought he wanted to be a paramedic. With all the assurances that I could muster, I told him, you don't have the stuff. But I was wrong. So he is a very fine paramedic. So Dave, thank you for cooking.
Thank you.
It was fantastic. Tom George Johnson, he's getting credit for his wife's stuff. Those cupcakes again, homemade for here.
Oh.
So thank you both for doing that.
I just said I need access. I don't think it emails her.
So our next presenter, well, we still have 10 minutes. I just wanted to get that out of the way because Dave was about ready to do things. So please go fill up a plate, grab some cupcakes. Even if you don't want them now, you will want them later because we don't want them to disappear without you getting what you want. So in 10 minutes, fill up another plate, grab some stuff to snack on the rest of the afternoon. We got Stephanie Steiner coming up. Use the restroom, and then we're going to get going with the second part of the presentation.
Whatever.
Love you, Dave.
It may be that word. Thanks. If not, she can put on her flash drive.
You got any bets for the class?
No.
I kept it simple.
I bid on a card though. It's a dual auto for both of them, and it sold for $4,800. It's a 1-of-1.
What do you at now?
No, it sold for $4,800. I got it to $600, and I was like, my wife would actually murder me in my sleep. So.
Yeah, because there goes your. Goes into your.
Cuts into our Disney right here.
Yeah, I just bet Tyson to win, and then him. That was his own bet, and then Tyson to win. He had knockout or TKO or not.
Tyson is pretty good.
He smacked the shit out of him.
Yeah, he did.
So Netflix had a 3-part series about the fight that Jason Lee, did you watch that? Tyson's working his ass off. 58 years old, man.
PHI.
He looks like he's 30 again. I mean,
He's still
looking good. Just out of the principle of Paul, I just want to be just for the principle. He's super cocky. I think Tyson put him in place.
She's gonna have to give us access. She's back.
Okay.
Does she not have that?
Tyson tried.
She's got a.
No, he's the underdog.
Really?
Tyson's the underdog.
That's right.
She just needs to give us access to pull it up.
If he wins, it'll be the amazing thing. If Paul wins. That's all I got. How you doing out there, Trail? How's the weather on that end, Tim? That's good.
Who do you think's gonna win round one?
Round one, Tyson.
No, I'm going with Paul. Just with,
You doing a parlay?
I don't know, just for the simple fact of he's younger, he's one of the best.
Either Paul's gonna come out super aggressive or he's gonna.
Maybe, did you hit open?
Yeah, I just did that. Let me see.
I put my.
Go to OneDrive and see if it's on shared with you.
What's it at?
You think it's gonna go to win in 60 seconds?
Whatever OneDrive is.
I shared it with Ethan, which I didn't.
Okay, go back.
You might just have to click on the email.
Dude, we're looking at catch a break. You see that Nugent St. Company's on fire?
But they call me and they're like,
Nugent St. Company off Fort Avenue, it's on fire.
Really? John did. Like, what they do?
They moved Rock and Sam.
There you go. Yay, technology, one thing worked today.
They guess they're on fire.
Now I just need to make sure that the slides that I hid stay hidden.
in the nicest way possible.
I don't know if it sends it.
Total knockdowns. Under one or over.
Well, under one would be 0.
Well, I'm sorry, under.
If I go too fast, it stays at the end, they just have blocked out. Okay, yeah, looks good.
How do you know that?
I don't know how that works. I can't do the overs and unders. I don't know. So do you think there's gonna be more than one on there?
I think so. Oh my God. They're decorating a cake. I was like, what? Tyler, do you understand that my life has been consumed with her that class? That's all I can say.
It's hers, it's up and ready.
Thanks.
So I got, put $5 on that, both of them will be. I took the under on, guess I should.
I really don't think
Was that
that's
just the
demonic.
name?
That
Oh, it's
is, that's it. Now, if there is, it's unbeknownst to me.
If you don't know, no one knows, I'm pretty convinced.
I'm so glad you came down here from
I thought you played with me.
Well, I did. It's Matt. He did all of this. I did nothing.
Just looking pretty.
Yeah, I felt bad about even doing that. I did nothing. I did nothing.
Yeah, it takes an army to put on something like this.
Are you Stephanie?
Yeah,
You have a lot of alphabets after your name. I support it. That's all.
you support it,
That's
thanks.
awesome.
You'll learn why, it's all required. So it's all annoying. It's just a way for everybody to get money off of you, right?
I mean, it is a pay to play.
It is a pay to play.
100%.
You're absolutely right. Does it work?
Side, left and right. I think so. Give it a shot. Okay. All right, and you can see the screen on the bottom right-hand corner. So if you don't see you,
That's right. We're in virtual world.
yeah, if you don't see you, nobody else does.
Oh, and they type in questions?
So they do.
Yeah.
Oh, cool.
Or there hasn't been any questions, just that fun stuff. Yeah, just chit chat.
Saying hi.
All right, for the, what, Tracy? I know you were, but you know, something for the rest of the class?
Are you embarrassing somebody? Got hostile fast.
I've been her brat for 20 years. So our next presenter, and as it's been pointed out, yeah, she has a lot of alphabets behind her name.
I'm sorry.
She is Bill, boy, you guys are killing me back here.
We just happy to see you.
Yeah, you're right. But she is an educator with the St. Vincent Ascension Program. So the helicopter people up there, everybody except the Madison base falls under her tutelage. She's one of those people that I had to go before her when I first joined PHI to prove to her that I was capable of doing my job. And there was something that.
Why did you?
They asked me why I passed you.
Yeah, I know. But I'm focused over here because Bill's
He's
not
ignoring you.
himself with laughing over something. that
He's
Tracy
smiling.
was
He's the friendly face.
But it took me about 5 minutes in front of her to respect her. There was something I probably should have known, didn't really know. It was no big deal. She stopped everything she was doing, walked me through this process, and then tested me out on it. So it was instant respect. You'll find out her demeanor, what she's gonna do, hoping you're good, is what you get.
About to find out.
So all of these letters, she puts them up there because she presents to all kinds of institutions, but I'm sure if it's up to her, she would just have her first name and that'd be it. So without further ado, Stephanie Steiner.
Thank you. That was quite the welcome. Thanks for inviting me down here. So as you can see, I work at Akron Children's, which is up in Akron, Ohio. I don't know how familiar y'all are with Ohio, but it's kind of northeast. Yeah, I got one in the room. I like it. I like it.
One is from Cuyahoga Falls.
That's where I live, Cuyahoga Falls. That's crazy. So that's why I did it I've been in the burn center now for about 10 years as a nurse practitioner. I worked there full time for many years. And then when I came back and rejoined PHI, I worked for a PHI independent program for a little while, 14 years, a little while. So now I basically am there mostly on the weekends. So if you ever make it up that way, if it's a weekend, you'll see me. And then during the week, I do the amazing job with PHI. So I do a lot of education and all the things that fall underneath that. So as I go through this, like he said, I do give lots and lots of talks about burns because I'm very passionate about it. I've done it for a long time because I love it. I truly love every aspect of burn care. So if I touch on something, I'm going to share with you information that probably isn't always super important in the pre-hospital side of things, but is good for you to know for the long range of things, because things that you do in the field are going to affect the patient all the way through their course. But also because sometimes you guys attend things like this to try to pass exams or get extra training or look at taking other tests to get more letters, right? Like you said, it's a pay-to-play system. So it's helpful in that because a lot of the burn teachings we do now is pretty standardized and every test should be asking you and defining the same answer. So with that, we are going to talk about lots of things. I'm going to talk about just initial management, very much part of your world, especially the airway piece of it, which is the part that I think people get most concerned about. The do I intubate, do I not intubate kind of thing, and what are the reasons that we do that. We're going to talk about a little bit about resuscitation. Resuscitation changes often in the burn world. We're in something now called a consensus formula, and I make fun of it because no burn center is in consensus with the next burn center. We all like to do things our own way. But there is literature out there with a consensus formula, so that has changed over the past couple years. And I'm going to dabble a little bit, depending on time, on hopefully electrical injury and chemical injury. Just the highlights of those. So I usually like to start with this scenario, which this is probably very real for many of you. So you have a 57-year-old male who is extricated from a fully engulfed structure fire with visible cutaneous burns. So the patient is wheezing, coughing, and sounds hoarse. He's covered in soot, which they typically are, right? Head to toe, everything's covered in soot. Oops, sorry. And you are 35 to 40 minutes by ground to the nearest burn center. So down here, that may change, right? Yeah, I think you go to Louisville or other places for your burns. So what are you thinking if you're on scene working this? What's going through your head? What are you concerned about? And where are you going to take this patient?
Calling PHI.
Thank you. And we will come.
That's another $5 for you.
Pay to play. Yeah, you're really worried about this airway, right? There's lots of things in this story that makes you really concerned. Yeah, and so his point is, I'm going to call a helicopter, and it really depends on where you're going to go. Are you going to take this patient to a trauma center? Are you going to take this to a burn center? Burn centers are set up very differently depending on where they are. I work in a burn center that is super unique. I'm adult and peds, both. I'm a regional center, but I sit inside a peds hospital, a level 1 peds hospital. So if it's an adult trauma / burn, they have to go to a trauma center first before they come to me. So just know, again, those capabilities that are around you. So you figure out where you want to take this patient and how they're going to go. So most commonly when I talk about burns is like, I get this face on people of like, oh, how do you do that? I don't like anything about burns. I don't like it. Like just saying that sometimes will give people a visual in their head of what they last saw or what they last smelled. And let's just say that it's, it's a horrific injury, just like lots of our trauma, but nonetheless, it's managed all the same way, right? So the focus is not on the burn, what you see, it's what you know is coming down the road and all the same immediate things that you treat anyway when you treat a trauma patient. So I talk a little bit up here about some airway stuff, circulation stuff, and we're going to go through this kind of step by step as we go. So the biggest thing is just have a plan. Have some knowledge about what's going to be important for these patients. And it's going to be if they need airway protection now versus later. There's many different decision points in that. And then just have a resuscitation plan. And it doesn't have to be a fancy calculation. If you haven't seen a burn lecture recently, you're going to learn today. There's just very basic pre-hospital rates now that we use that you don't have to even worry about getting past your primary survey. Primary survey, start initial fluid rates and you're gone, right? It's much, much easier. And then just knowing again, where are you going to take the patient? That's always a big question. So what do you think? So there's lots of experience. I see very young faces and I see some of us who are, I'm not going to say I'm old, but we're more mature, maybe. Seasoned, I like that. Seasoned well. So what is on your absolute list? And I know they're up there on the board, but I want you to think about patients you've taken care of. What's been the deciding factor for you? This is a red flag. I need to do this now. Right on scene.
If you have obvious soot and burns in the mouth or the nasal passages.
Yeah, certainly if they have burns inside their mouth, that's a problem. That's going to swell, right? Soot is a plus minus. I like to pair that with a couple other things. But I like where you're going with it. What else? Think back to what you see. Hoarseness. Because what does that mean?
Have an upper airway obstruction.
Yeah. There's some sort of injury here, right? They're making that noise for a reason. It's an inflammatory reaction to something either they're exposed to or the heat, right? What else? Anything else? Okay, that covers most of the ones you're really worried about, right? So what are the other things that happen? Those are all the other things. So lots of soot, singed facial hair, eyelashes, eyebrows, beards, things like that. That makes people nervous. It doesn't necessarily mean you're required to intubate them. Certainly if they have really obvious full thickness burns to their face or their neck, that's probably a sooner than later kind of situation versus if they have partial thickness. And we're going to dive into that a little bit about what that looks like. They probably aren't going to have quite the edema and the issue that somebody with a full thickness burn is going to have. The big burn injuries are always, do you have to take time to do it in the field before you move them? Or you call the helicopter? Maybe, maybe not. But if you're thinking this is a big burn, and by big burn, I mean at least a 40% threshold, but probably closer to 50 to 60. Most of my patients that I see, there's a lot of 40%ers that never get intubated till they go to the OR. But when you're approaching that 50 to 60%, that's massive fluid resuscitation you're talking about. And especially if they have smoke inhalation, they're going to be super sick. They're going to need an airway. I would never fault you for that. I would never fault you for somebody who's just in so much pain and not controllable that you feel like you can't adequately give them enough analgesia and sedation to get them comfortable to transport. Totally on board with it. If that was me, I'd want you to do it, right? And then if you're looking at a longer transport, and this is more for our, transport-friendly folks, whether you're doing ground or air critical care, if you're having to travel on the road with somebody to get them to a burn center and it's an hour, hour and a half, 2 hours away, a lot happens, right, in that 2 hours. So if you're on the border, then it's probably a good idea just to go ahead and do it now so somebody doesn't have a real hard time in the air trying to do it later. Well, that's supposed to be hidden. You don't need to see that one. So like the gentleman said in the back, the inhalation of superheated air. So probably a more rare event. You're probably not going to see this very much. The mucosa of your oropharynx does a really good job of heat exchange and moisture exchange, right? So seeing an acutely actually burned inside of the mouth is going to be pretty rare. But they do, if they're in an enclosed space, have that exposure to superheated air. If there's an explosion, it's an intense fire, and they're really in there for a long time, they're not only inhaling that smoke, but they're inhaling that super hot air. So usually that's from above the glottic opening. Those are your patients where typically you're going to hear the hoarseness, the struggle, or they're talking like they have a golf ball kind of in the back of their throat. Their voice is off, right? And they're probably going to tell you, I'm having trouble swallowing, I'm having trouble breathing, those sorts of things. So those, again, red flag, right? Those are intubate right away. The second part that you see most commonly is below the glottic, so subglottic. So this is inhalation of smoke. This is all those nasty, incomplete, all you firemen in the room and people who work in fire, all that nasty stuff that's in our houses. It's all synthetic materials, right, that we're inhaling. That stuff gets down into the lungs, so you've got a lung injury just from that, but we also readily absorb that into our circulation. So it now becomes a systemic toxicity as well, so it's twofold. So subglottic, all the things you normally see. They're coughing up sooty sputum, what we call carbonaceous sputum. They're wheezing, they're telling you they're short of breath. And some of these folks are hard too, because some of these might be those that have a lot of comorbidities. A lot of people have COPD. So it's hard to tell, do they have a smoke injury or is just like a flare of their COPD that's happening because they were briefly exposed? You don't know, right? You're doing the best you can. What's happening though is, as I said, you're inhaling that smoke and there's an inflammatory reaction. So most people know burn injury to tissue, there's a big inflammatory reaction that happens, but there's also one in your lungs. Your pulmonary circulation dilates out and it just floods the pulmonary circulation. All this blood flow, all this fluid comes. And so what comes out? All the sputum, right? They have lots and lots of sputum that comes out. So then it interferes with all the things in the lungs. So it interferes with cilia action, it interferes with surfactant production. So all the things that normally help us clean out our airways are basically fried, right? They're done. They can't move any of those secretions. So you have all of that happening. So let's practice. So if anybody is not good with pictures, I don't think anybody in this room should be having any issue with these pictures. I do this for a little bit of practice. So I'll start with, this is actually a young lady down in the left-hand corner. So obviously she has a tube in there now, right? But if you saw this initially, pretty easy slam dunk. So we have full thickness all to the face, to the neck. Depends on the history though. I still have more questions. Where was she found? What was she exposed to? How long was she in there? The gentleman up in the right-hand corner, what do you think about that?
Yes.
Why do you say yes?
We've got a significant burn surface area in third degree.
Big burn, and it's third degree. That's an easy one too, right? That, you can tell, anybody can look at that picture and say that is a full thickness burn. It's dry, it's hard, it's probably cold. It looks totally different than partial thickness, right? So that's what we're talking about, obvious full thickness. How about the guy in the middle? What do you think about him?
More info.
More info, please. I like it. You're my rock star back there. You want to come do this left? Yeah, so things on him. So soot is scary. So people see soot and they're like, he's got an inhalation injury, check, we're intubating, right? How many people have seen folks who have been smoking on oxygen? So, I just want you to know that almost everyone raised their hand. Hilarious. I feel like I get one every week at least. And sometimes it's the same person over and over again. How many does that happen to? Same person over again? Yep, they don't learn, do they? And then they just go to the next oxygen company and then to the next oxygen company until they finally run out of suppliers and nobody will give them oxygen. So they look like this. So they typically have some blistering, like right here on their nose, in the labial folds, maybe on the top of their lip, but they have a lot of soot on their face and they look really scary. Those patients don't need intubated. Unless they're in acute respiratory failure from their underlying disease, COPD and whatnot, those patients don't need intubation, right? They don't have the full thickness burns. They don't have mechanism. They weren't in an enclosed space. This is a flash injury that happens with oxygen. And those are scary ones if people haven't seen them before because you're thinking it's face, it's airway, probably stick a tube in that. But honestly, most of these patients will come to us and we're extubating them right away. And it's okay. If you can't decide, you do it, it's okay. But the COPDers, they're tricky ones. They're tricky ones. So how many of you have seen that airway on the right-hand side? I hope to God none of you. So I shouldn't see any raising of hands, maybe at least for surgical critics, because that's what that patient's gonna need. So this is what we're talking about. This is what we're concerned about with supraglottic, superheated air swelling, okay? Left side, I wanna see that all day long when I intubate somebody, right? The right side, no thank you. I have no landmarks there, right? You can't see anything. And so that's a surgical airway all day long. So this is what we see. This is a bronchoscopy, and this is how we diagnose inhalation injury. Patients will come into our triage. If they're already intubated, we're gonna go in with a camera and we're gonna take a look. There's no guessing game. If I see this lining the inside of my lung or my trachea, then I know they have an inhalation injury. And we have a grading system from 0 being nothing to 4 is the most severe. And so based on where they fall kind of in our grading system dictates of what kind of treatments they end up getting. But this is kind of what it looks like. And you can see on the second part where there's kind of the 6 squares, that's kind of the evolution of what you see immediately versus what you see over the course of a few days. So inhalation injury, treating it initially, taking a chest x-ray initially, everything looks normal. They kind of act normal. Maybe they're a little more hypoxic or hypercapnic, but honestly, this is a process that inflammatory response ramps up. The inner lining of those lungs start to shed. There's a lot of mucus. There's a lot of like fibrin and clots and all sorts of gunk that happens. Then they go into bad respiratory failure, okay? They're really, really hard to ventilate. So like I said, for inhalation injury, what do you need to remember? If you think that airway needs protected, protect it. If you got some of those red flag things, go right for it, okay? Don't wait. 100% FiO2 for all of these patients. We're gonna talk a little bit about carbon monoxide and cyanide, but anybody who's been in a fire or has any evidence that they may have inhaled smoke, just put them on 100%. Don't titrate, just leave it until you can get them somewhere that can draw a carboxy. That'll make sense. How many of you have like a little finger rainbow carboxys? Anybody have those? Do you think they're pretty accurate? Have you ever tried to correlate like what you get versus? It's not maybe a matter of like, is the level correct, but it's going to tell you if they're elevated or not, right? Yeah. So I'm still pretty hardcore about keeping on 100% until I get that serum carboxy back that's normal. Bronchodilators, you'll have those in your protocols. Bronchodilators all day long. What ends up happening when they get to us, remember I said that kind of grading system, we use some other techniques. We use a really good pulmonary toilet, lots and lots of tools for that. But we use actually nebulized heparin. Helps with the clots and the shedding of the tissue and the fibrin collection that's happening. And we use inhaled mucomist. So that kind of thins out the mucus and helps us with our pulmonary toilet techniques to get some of that crap out of their lungs. Usually by about day 3 to 5 is the worst. That's kind of the peak. And they are just pouring out secretions. It's just lots and lots and lots of secretions. So they get real, real sick within a few days. But for you, that's not gonna happen. All right, you guys could probably school me on this topic of carbon monoxide poisoning. I don't think I have to go through too many of the signs and symptoms. The biggest thing, again, getting them on oxygen because you're decreasing that half-life, right? You're kicking those carboxy molecules off of there and replacing them. You need that high FiO2 to be able to do that, to cut that half-life from 3 to 4 hours on room air down to less than an hour. And I've had some folks ask me, like, do they still use hyperbaric? Does anybody have hyperbaric around here that you have ever been taught or? Yeah.
Jewish have one.
Used to? Barnes Jewish has one?
Jewish downtown, at one point, what they still do.
Jewish.
Yeah. We've sort of gotten away from it for a couple of reasons. If you think about the half-life time and the amount of time that patients, by the time they get on scene, transferred to a burn center, triage, start resuscitation, get them somewhere else. If you're thinking of hyperbaric, there's enough time that's probably passed to half-life out. And damage is probably already done of what's going to be done, right? Of like hypoxic brain injury and things like that. In addition to a substantial burn with an inhalation, you're going for hyperbaric. I can't even imagine how hard that's going to be. And to have a hyperbaric that's big enough to dive them with all the people taking care of them, all the IV pumps they're on, the ventilator, all the things. So you're pretty much probably not seeing that as much as we move into the future. In my area, we don't really move anyone for hyperbaric. I think Toledo, Ohio might still have one that maybe the Detroit area tends to dump into sometimes. Usually those are found down bad anoxic injuries, so that they're trying to dive just to see if they can help anything. And most of the time, they don't get anything back. So signs and symptoms, you guys are aware. How many of you actually see the flushing, the bright red nose, bright red face? Anybody actually see it? A couple of you? Yeah, because it doesn't usually happen. That's like the most notorious symptom I think people remember, but it's the headache, it's the nausea, it's the vomiting, the dizziness, and as they go kind of over the curve of getting up to those higher limits, now you're talking hemodynamic problems, right? Hemodynamic rhythm issues, cardiac arrest, kind of into where you're finding them in cardiac arrest, inside the structure. Cyanide poisoning. So this was the smoke inhalation part. Remember I said lungs readily absorb all those things that you're seeing in the smoke are lipid soluble. They move right into the body, right into systemic circulation. So how do you know if you have cyanide toxicity in a patient that you're pulling from a fire? What's your thoughts? Anybody have exposure to this?
Skin run.
Maybe? Maybe? Anybody else have thoughts or have any? Who has cyanokits? I heard, sir. Did you say expensive? Somebody said, yeah, they are expensive. There was a time where lots and lots of people carried them. I don't feel like folks use them as much anymore unless they're funded like by a grant or something that all the departments get it. It is expensive, but it is life-saving for these patients. So one of the things, if you carry anything out from today, is burn patients typically are not hemodynamically unstable. If they're hemodynamically unstable, by that I mean, are they in cardiac arrest, peri-arrest, hypotensive, bradycardic? They will not be bradycardic. They are usually hypertensive and tachycardic. So if you're seeing something that's hemodynamically unstable, you got to think of either something else happened, trauma, STEMIs, things like that happen all the time, right? Or it's this. So cyanide toxicity causes basically a tissue hypoxia. There's an enzyme that you need to convert X to Y, and it gets in the middle of that, and you can't make ATP, you can't make energy, and you're basically in a huge metabolic acidosis. The only way to fix that is a cyanokit. So basically, cyanokit, people are like, well, should I give it or not? I don't know. Again, if you have somebody who's peri-arrest, cardiac arrest on scene, you're pulling them out of a fire, and their agonal respirations and they're hemodynamically unstable, those patients are going to get a cyanokit. For sure. I'm not going to wait for labs. I'm not going to wait to be convinced otherwise. The other ones are ones that we see in our world of where we arrive at an ER to take somebody to the burn center or a higher level of care. And they've done all the things. They've done fluid resuscitation. They've intubated. They're managing on the bed. They're doing all the things. And they're like, their gas will not improve. Their ABG is no better. They're still acidotic as all get out. And now their pressures are dropping. It's this. Okay. It's usually this. So, wow, I need even more glasses to read that, but hopefully you can see that. Cyanokit dosing is down here, 5 grams for adults, 70 mg per kid for peds. You can repeat that once. There's really no con to giving it. It's relatively harmless. There is probably the most common reaction that's in the literature is anaphylaxis, and some people take Benadryl and get anaphylaxis. It's a weird world out there. So I would not have that as something that I would withhold the treatment from. It basically just converts the cyano into B12. So then they just excrete a bunch of B12 and everyone's happy, cells are happy, they can make energy again, and you get your patient back that's more stable. They get that red coloring everywhere. Has anybody seen anyone that's got a cyanokit? Jamie's like, yeah, me. Were they nice and pink?
Everything, here's the red.
Yeah, it's like a magenta kind of color, purplishey pink. Their wounds will look like it, their urine's the color, tears are color, everything is stained that way. Oh well, it goes away. No baby. We're not gonna worry about it. Whoops. All right, so moving on to cutaneous stuff. So this is where we're gonna define more the first, second, third degree. Now terminology has changed over to superficial, partial thickness, and full thickness. In layman's terms, we still describe it as first, second, third because most people understand what that means. When I say first versus third, they're like, not so bad, much worse. But we're really talking about where it's hitting the skin. That would be good for a nurse if I did put a nice picture of the skin cell up there for you. So that top layer up here, which, I'm sorry for people in virtual world, kind of that peachy color, that's your epidermis. That's your very outer layer, very thin layer of skin, a couple cells deep. And that's our barrier for moisture, heat, all the things, right? So what does a superficial thickness burn look like? Who's been sunburned? Everybody has. Everybody's had that day where you're like, oops, forgot the sunblock. You've all had superficial burns. That's a burn by ultraviolet light, but it doesn't blister. It's painful, super painful, right? It could be very itchy. You can get a rash, what we call sun poisoning. So burns release a lot of histamine. That's just what we do in our inflammatory response. If you have a big sunburn, you're releasing a lot of histamine. You're gonna be super itchy. So NSAIDs and antihistamines are how you fix it. So yes, the big thing is there should be no skin loss, no blister, no slough. Partial thickness, blister, slough. Has to have those two things, right? So now you have skin loss. You've made it down through the epidermis, now you're into the dermis. In the burn world, we separate that even more to the top part of the dermis versus the bottom, because somewhere in the middle of that, it starts to determine if patients have big burns and they're really sick, if those wounds get better or if they convert to deeper. So it's kind of in that deeper layer of the dermis. But you can see in the dermis, what do you have? Hair follicles, sweat glands, nerve endings. This is why partial thickness is so painful, right? You break that blister, you open that up to the air and it stings like crazy, right? Because that's exposure of that kind of nerve ending feeling and it's real excited and it's real inflamed. So blister, slough is second degree or partial thickness. Deep is all the way through. You've gotten all the way through to the dermis and now you're either into subacute fat or the old fourth degree. You might even be down through muscle. Okay, that's not gonna heal. It's not gonna heal, unfortunately. But what's unique about full thickness? Anybody know? Do they have more pain or less pain? Less pain, absolutely. You guys are smart. You already know this. Yeah, the nerve endings are done, right? They're cooked literally, right? So if they have big burns or nasty looking burns and they're not screaming at you that they're in pain, it's a good indication it's probably full thickness burn. So same things I told you here, the moist, pink, wet, drains a ton of fluid, gets blistery, versus dry, leathery, looks much more pale. Sometimes it even looks like a beefy red kind of color that you see in this picture here. You know, it's got this like beefy red, a little bit different shade, if you will, than what this looks like, right? It's a real dark, beefy cherry red. That's usually almost all the way through the dermis as well. And then the far picture on the right, that's kind of the picture that you saw earlier, obvious full thickness. It feels different, has a different texture, has a different, when you feel it, palpate it, it feels different. All right, who knows the rule of nines?
Oh, I hate the rule of nines.
Everybody knows the rule of
I never
nines?
get them right on a test question.
I know, right? That's why I go over it to this step. Like, I know it's gonna be a test question, you're gonna see it somewhere. What's the difference between kids' rule of nines and adult rule of nines? Anybody know the spots that are different? Their melons. Right, it's their melons. Their heads have a lot higher body surface area than adults do. So a lot of that rule of nines goes to the head. An adult head and neck is 9%, on a kid it's 18. Okay, so much bigger percentage. And where they give it up, they have a little bit more in the leg down there than the adults. So you can see a little bit of difference here. This is a Lund-Browder chart. Anybody seen this one? Don't worry about it, but some folks will use this to shade. It's a nice picture. You can have a nice reference to just shade in, but it's divided into ages. Infant, 1 to 4 years old, 5 to 9. It's much, much more specific. Nowadays, this Lund-Browder chart has turned into lots of computerized programs that we literally just go in and color, and we put in the height, we put in the weight, and it spits out, here's where they are. There's this much second degree, there's this much third degree, this is what their total TBSA is. So we're kind of at that technology now. What's another cheat? Anybody know the cheat? Palm. Your palm or patient's palm?
Patients.
Patient's palm. That's also a test question I tend to see somewhere. So that's the real easy, right? Kind of make an estimation. Real easy. So how many of you are already familiar with pre-hospital rates? A couple of people? See a couple shakes of head. So the ABA, which is the American Burn Association that's responsible for the course for advanced burn life support, has now put this out. I feel like this is 2 or 3 years now that we're doing pre-hospital fluid rates, straight rate, no TBSA calculation. You basically have an age and a rate. So you can see on there 5 years of age and younger, 125. And this is if you look at a patient and think it's at least 20%. Right? We know that 20% TBSA is sort of the trigger for us to need to do fluid resuscitation on patients. So the old Parkland where we calculated everything out, that's still that threshold of about 20%. So if you're looking at a patient, you think they're about 20, start this initial fluid rate, okay? If you're not sure, you think it's 15, but maybe they're close, start this initial fluid rate, it's okay. This has helped to make your job a little bit easier on the scene, but also to make sure patients start fluid resuscitation with an adequate amount of fluid and not too much. How many of you have gotten a burn patient and immediately put on a pressure bag and gave a liter or two of fluid? It's okay. Can I tell you how many ERs do the same thing? Almost every one of them, right? So it leads to over resuscitation. That is more common than under resuscitation anymore. Over resuscitation, and it does bad things. So 125, 5 years of age and younger, 6 to 13, you just double it, 250. If it's an adult, you double it again, it's 500. Easy peasy, right? So if you never make it past primary, solid. This is what you do. For the rest of us that have to learn consensus formula, they made it a lot easier with not having to divide and do it over 8 hours versus 16 hours. How many remember that from the Parkland? We got the big number, we divided it in half. The first half went over 8, the second half went over 16. Well, what we found out finally over numerous years, and all of us that work in burn knew we never did it to begin with, is we have a starting rate and we never cared about where they were at hour 8. We didn't change it to this magical number for the second half of fluid that we needed to get over 16 hours. We just needed to find the starting rate. And that's really all we're doing now, finding a starting rate. So consensus is, for your adults, it's 2 mLs per kilo times their TBSA. Okay, so this is if you have time to get to secondary survey, where you're doing full body exposure, feeling all the things, right, head to toe. Now you have time to do this. It's once you've made it past ABCs. If you have a PEDS patient, it's 3 mLs per kilo. Okay, if you have an electrical injury, it's 4 mLs per kilo. And electrical injuries are tricky, and we'll talk about that a little bit later. So what fluid do we use for burn resuscitation? LR. Anybody know why?
Sodium,
Yeah.
effects.
Yeah.
Things.
Yeah, you get a hyperchloremic acidosis. If you dump tons and tons of saline into somebody, you're going to dump tons and tons of chloride into them. So the first liter or two, do you think it matters if it's saline? That's all you got, that's fine. But if we want to fine tune our practice and you have LR, give them LR. Okay, that's the balanced crystalloid we want. So you get that big number, so 2 times your weight in kilos, and we use actual weight. I know a lot of us are getting real handy with the ideal body weights. In the burn centers, unless they are morbidly obese, so BMIs of over like 31, 32, we might use ideal body weight for that. But everybody else is just actual body weight. Times your TBSA, you get that big number, and we divide it by 16. Math is done. You've got your starting point. Now I know where I'm going to start my fluids, and now I just monitor the patient every hour on the hour. Okay, and we're going to talk about all those parameters. So here's a practice. 70 kilo patient, 60% burn. So this is an adult, obviously. I hope we don't have any kids that weigh 70 kilos that are less than 13. So there's your number. 70 times 60 times 2 gives you the big number. Divide by 16 gets you 525 cc's an hour. How many of you think that sounds outrageous? Sounds outrageous, right? How well do you think that's going to go through a single IV, peripheral IV? Yeah. So sometimes we have to be creative until we get good access, right? If you have to divide it to 2 sides, you got 2 lines, you're given 250 in one and 250 in another. That works too. Whatever you can do to get it in. So if you guys are doing some of the critical care stuff or taking people from one place to another, or you have gone through the calculation, that's how you can get a little bit more creative, right? And it's going to be our problem to worry about what we're going to do for access when they get there. How do we know if fluid is enough? What's the gold standard still that we use if burn fluid is enough? If I'm checking them every hour, what am I looking at? Urine output, right? Am I using their heart rate? No, because they're all going to be fast, right? They're all going to be fast. That's normal. There's some other adjuncts we use in the hospital that you don't really have to worry about, but if you're curious to know what else we trend all the things, right? We do trend the vital signs, but we kind of have a good feel of what's normal and not normal for burns and how much percentage and what age on all the things. So do we take vital signs into account? A little bit. But these are some other things. My hematic rate, if it's going up or down, that tells me how dilute or concentrated my blood is. So that tells me if I'm falling behind or if I'm catching up, right? Base deficit, we talked about that this morning. That's a great indicator. What else do you think is an indicator then if base deficit is? And tidal, yeah, gold star. Yeah. And then all the fancy stuff. You can use point of care ultrasound, you can use all the non-invasive cardiac monitoring, blah, blah. But it still comes down to urinary output, honestly. Urinary output's still the thing. Escharotomies. Some people have scope of practice to do this, but you should not have to do an escharotomy early in burn care. So peak swelling or edema with a burn is usually somewhere between 8 and 12 hours. So we start their fluid resuscitation. I think I have a graph in here to show you. It peaks up and then it kind of slowly trends down as the time goes by, okay? Because we have this like third spacing phenomenon that happens, endothelial lining in our vasculature kind of spreads apart and everything gets super leaky. And those things start to come back together after we get over the 12-hour hump through the end of 24 hours. Things should start to come back to normal, and then patients hopefully will autodiurese. This is a problem right around 6 to 8 hours. So when you're at your peak edema and peak fluid resuscitation, you're going to start having problems on areas that are circumferential, typically your extremities, but it can happen to right the chest. That's the one thing, the big thing that everybody worries about, happening to the chest, that you can't ventilate someone because that dead tissue, what we call eschar, gets hard, thick, and it does not give, okay? So escharotomy means that we are only cutting through the dead skin. We're only cutting through the eschar. We're not doing a fasciotomy. We're not going clear down into the compartment that holds the muscle. This is just an outer skin problem. Most of the time, this is insensate skin, but patients still need anesthesia or deep level sedation before we do this. But typically, you're not seeing it until a little later. Now, are patients at risk if they have a delay in presentation? For sure. Any of you guys take care of an Amish population? How many delayed in care have you seen for them? A lot. Yeah, they're the ones that are at most risk because they don't seek care and they come in very late and you're trying to give them a massive amount of fluid because now they're in shock and yeah, you go down the whole gravy train, right?
That type of burn.
Does it shrink?
Just tightens.
It just is tight. It's thick and like hard and cold, and it doesn't expand. So as more and more fluid is leaking out, it has nowhere else to go. So it starts to compress the vasculature. So then you end up with ischemia, basically like compartment syndrome, but the eschar is actually what the compartment is holding. If that makes sense. So you're still going to have the same symptoms, that the pain, paresthesias, pulselessness, all those P's or whatever. You're still going to have those same things. But we know when to expect this. And so we're jumping on and doing it early. We do lots of Doppler signals. We do it in between digits, the end of digits. As soon as one thing starts to change, if it starts to get a little bit quieter and it's already circumferential and it's a big burn, it's just going to get done. We're just, because there's no loss here. This is dead tissue. It's going to be debris in the OR anyway. Doesn't matter. It's coming off. You're not hurting a darn thing. Okay. Questions up till now about inhalation injury, resuscitation. What's a third degree burn? Any of that?
As far as like getting access for these patients.
Yeah.
Do you like say, your vascular access is very poor?
Yeah, it's
Would
tough.
it be okay to start IVs or IO, and give them the fluids that way as well?
Absolutely. Absolutely. And I'll take it a step further. Can you put in an IO over burn skin? Absolutely. Yeah, doesn't matter. Now, your only problem is how to secure it, right? But y'all are MacGyvers, right? That's what you do. You MacGyver everything. So Curlex, Coban, whatever you got on there, because there ain't no sticky dressing that's gonna, if it's over burn skin, right? Because it's all leaky and stuff. Now, if it's full thickness, maybe it'll stick. But yeah, you can get wherever you get access, whatever you're allowed to do. Yep, you're golden. Good question. Any other questions? Quit laughing. Quit laughing.
Yeah, do it harder.
Might get too much. No, stop. Alrighty. Electrical injury. Who's seen an electrical injury? Yeah. Bad ones? Or the kind where like kiddo sticks their necklace in a wall outlet? No judgment here. They're all scary. Lightning. You've seen a lightning?
Yes.
Holy cow. You're like 1 in a million. Literally. Who else? What else have you seen?
I think where he got electrocuted on the cardiac arrest.
Yeah. Do you remember what was the events around it at all?
It was the rafters doing fluorescent lighting, someone hit the power on the other side of the building.
He got the whole hook it and caboodle? Yeah, so the dividing line now is about 1,000 volts. So you have low voltage is 1,000 or less. Higher than 1,000 is considered our high voltage injury. The high voltage is where we get worried because electricity travels and we conduct it. But those higher voltage ones are the ones that are actually going to conduct through the body, interrupt the cardiac conduction system. Typically, your low voltage, you're going to have a localized tissue injury. You might see a white spot where they make contact with it. Again, these are just contact points. We don't call them entrance and exit, just like gunshots and stabs, right? But they're not really going to conduct a lot of that. So high voltage is your threshold. So getting good information on scene about what they were doing, what they made contact with, how were they found? Were they awake? Were they in cardiac arrest? Just like you said, that's a high voltage. He probably got in contact with a big wire and he conducted it, right? The tricky thing with electrical injury, so the most important thing a burn center wants to know is all that history. So get as much from the scene as you can and how they were found or how long they were down. Not that you don't always do that anyway. But it's going to be a lot of internal injury now, right? So electrical injuries may not show you a lot. They're very, very sneaky. You might see a couple what we call contact points, and they can be nasty, right? Especially like over joints. You tend to see them at like wrist, ankles, maybe out the shoulder, and they're going to be nasty, probably 3rd degree eschar there. And it's going to be really obvious that that was a contact point. But where it went inside the body, it doesn't follow any kind of linear pathway. It doesn't go in one arm and come out the other, go in one arm and go out the leg. It goes all over, right? And so bone doesn't conduct very well, but muscle, vasculature, all of that conducts electricity very well. And that's where you're going to see a majority of the damage, but you can't physically see it. It's all under the skin. So they may have 5% TBSA on the outside, but underneath is where the problem is. And they can still get just as sick. So that's why you see in that consensus formula where it talks about the 4 mLs per kilo for electrical injury. That's why we give them even more fluid. Now, the trick is, you just told me that maybe most of them are 5% to the eye. How I'm never going to fluid resuscitate an electrical injury, right? Wrong. We still give them more fluid, but we have a way that we do it in the hospital of looking at labs, looking at urine, things that show us if they have rhabdo, or they have breakdown of that muscle that they're now leaking out. They have like T or pigmented urine, or their CK levels are off the charts. It might be just from what we can see, some of it starts to get very swollen hard. We know that there's a lot of underneath damage. So we do elevate their fluids that they get hour by hour, but it's not quite the same as a calculation, if that makes sense. So some of this too, I talked about contact points, heat generation can account for the injury. How many of you have seen arcs? So arcs are not necessarily electrical injuries the body conducts, but it arcs around them and gives off a ton of heat. So what ends up happening is actually their clothes might ignite, something to that effect, and then they end up being a thermal injury, as well as a questionable, maybe electrical injury. So it kind of compounds it. Check spots where there's metal, because again, that superheat, where their zippers are, where their belts are, bras, things like that, they're gonna have really, really bad burns where metal may make contact with that. I think I got through all of those. So resistance we talked about, right, of skin and bone being the least conductive, of course, unless we're wet, then it changes the whole ball game. We talked about the path's not always linear, underlying injury. I think I got through most of this. And again, cutaneous injury percentage might be pretty low. So look for contacts. We talked about arc. And I think I was talking way ahead of my slides, so that's probably a good thing. So how do we assess these patients? Any different? Same way you assess any other trauma patient, right? Were they working in a cherry picker and they got blown out? Were they working on an electrical box and they got thrown backwards? So they have, some traumatic injury as well. We approach them the very same way you do anybody else. If they have more than a 20% burn, we treat them the same way. You got to start those fluids, those initial fluid rates, just like you would normally. If you don't think they're bigger than that, you give your KBO or whatever's in your protocol, unless you want to call somebody and ask what you should do. Okay, you're just going to give them at least some fluid, right? And we're going to push their urine output goals a little bit higher. All right. Chemical burns. Chemical burns are also pretty sneaky. So chemical burns, often I see, if they know they've injured themselves or exposed themselves to something, they may call you to the scene for work, right? These are usually work-related injuries a lot. hey, I spilled something on me, it kind of stings, I don't see anything, but I don't really know what to do. Or these patients will present later to an ER and they're complaining of a lot of itching. They'll have a rash and it itches immensely and they get treated for, guess what? A rash. They get steroids, they get antihistamines, they get sent home. And then 5 days later, they come to my burn center and they have a big necrotic wound. Because it depends on what they're exposed to, but typically it takes time for chemical injuries to really kind of fully expose themselves as to how deep it is and how wide it was absorbed. But itching and a rash are super, super common. Okay, they do actually get a contact dermatitis from it. Itching is the dead giveaway, but it usually looks like either just a fine red rash or it's got that purpley kind of color, almost like petechiae or purpura, that same color that it looks like. You'll see like the splatter or the outline of it, but it doesn't look like a burn. Sometimes it doesn't always blister. Or they may come to you and they've got necrosis already. It's already dead. So it just depends on where in the pattern. So we talk a little about figuring out what the patient was exposed to. Google's great, MSDS is great, Poison Center is great. If you don't know what it is, just figure out, is it an alkali? Is it an acid? What is it? How do I decon them? The biggest job is your job, to decon them, and they need excessive decon. Now, is that soaking them in water? Of course not, right? This is about spraying them down, showering them. They have to be open running water to get the decon, and ABA says 30 minutes, 20 to 30 minutes. Most people that I see that come from like work-related injuries, they're like, they put me in for 15. And I'm like, is it really 15 or was it like a 5-minute shower? So most of the time they get showered again just to make sure we've fully deconned them. The solution of pollution is dilution, right? Most things, I think there's only one thing on the planet that I can think of that is not deconning them by showering them, by diluting it with water. So don't be afraid to look it up. Find out if it's an acid, if it's an alkali, was it an organic compound, right? The organophosphate kind of stuff, and have they been deconned? So alkali actually melts tissue. It literally just liquefies it. Proteins are denatured. This kind of burn is easily absorbed. The body actually absorbs it down to the tissue. It just liquefies and keeps on seeping in. So the longer the contact time, the worse the injury is, right? So oven cleaners, lots of cleaners have lots of alkali in it. A really common one I see is cement. Cement workers that are like down on their knees. They get the powder on them. They don't realize it. Maybe they're working out in the summer heat. What activates that chemical? Sweat. Exactly. Or they get it down in their boot and it's absorbed into the sock, then gets absorbed in their skin. And who has sweaty feet? Everybody, right? So though they may not even initially realize that they are getting a chemical burn until hours later. Some people will tell me like it kind of burned or it kind of itched, same thing. And then they get home and take off their pants or they take off their boots and they're like, holy crap, what happened to me? And it's cement burns. They're fairly common. Fertilizers, same thing. Another alkali, it's going to melt tissue. Acids, same, works a little bit differently in the cellular mechanism that it burns you, but it's a coagulation necrosis. So this one usually is, again, just contact time over the area that's had contact. It's not going to absorb as readily, most of the acids, but still eventually is going to cause some sort of necrosis. Bathroom cleaners, rust removers, pool chemicals, hydrofluoric acid or hydrochloric acid. That's a big one. I think that's the glass etching that people do, or etching with that chemical. Those are ones that we tend to see fairly common as well.
Those are a lot of the issues with inhalation.
Inhalation. So lots of bronchospasm, respiratory distress, swelling, all of that.
You also gotta think about some of the chemicals are reactive to water.
Some of them are. Very few are, but yes, you're right. You have to know what you're dealing with before, yeah. But most of the time, you're going to be 99.9% safe to, irrigate them with water.
Quick question.
Whoops.
Is there a point where you need to take someone to like the level 1? You know, obviously, if concrete just gets on the leg, maybe not as concerned, but is there a certain point where, you know, they are saturated with an amount of concrete where I'm like, okay, I need to take them to a level 1 comparative to maybe just somewhere that's going to irrigate and get it cleaned off of?
Yeah, like looking at area. My very next slide after this one talks about who needs to be transferred to a burn center versus going somewhere else. So let's save that question for one more slide and then we're going to dive into it a little bit before we wrap up. Hydrofluoric acid. Has anybody seen a hydrofluoric acid burn? You have seen How long have you been in EMS? What's that?
One factory.
You have a factory down here with it?
Carrollton.
Oh, then you should know this one. So hydrofluoric acid is treated differently. Do you guys know how it's treated? Calcium, yeah. Yeah, it adheres to calcium. So the big problem with it is, one, it is super painful. It is the most painful. So that is one red flag. If it seems like the pain is out of character to what you're seeing, have that concern. And especially since you have folks down here that are around it, that's really concerning. But yeah, it adheres to calcium. So it makes them profoundly hypocalcemic. So that's the big worry. And we all know calcium does what? Makes our heart go boom, boom, and things like that. Makes things contract, right? So that's the big part of that one. And how we treat that is we actually take basically sterile KY jelly and we put calcium in it and we cover them with it to reverse that process. If it's on their hands, we put it down in the gloves and just stick their hand down in the glove. There are some places that will do almost like an intra-arterial injection of it as well, but usually the topical gel, and that gives them immense pain relief. That's the ticket, is that definitely gives them pain relief. So that's a good one for you to know if you're down in this area.
This is gonna sound stupid probably. I had a 1-year-old that got into mom's epoxy stuff the other day. I didn't know anything about epoxy. Apparently this stuff gets hot. So they
Has an exothermic reaction.
So is that was the swelling from a burn that I'm
Yes.
seeing, or is that just allergic? It was just from making.
It's a burn. Yep, still a burn. And depends again on how long is the contact. If it stays down there long enough to have that high heat. But hopefully with an exothermic, you're not getting much more than a superficial, but again, it depends on the chemicals, and those are the ones that you don't want to add the water to, that water makes it have an exothermic reaction, because that ends up obviously having further tissue injury if you do. Yeah, that's an interesting one. I had a girl who was using alcohol. There's been a rash of alcohol ones where people have been putting this like alcohol or wintergreen stuff onto like their joints for pain relief, and then they get near a candle or they light up their cigarette. Dudes, they light up. No, not trying to be funny, but they literally light up. So I've seen that one. And also there was a girl who was using alcohol. She was an artist and like painted on windows. And she was at her house and she would decorate the inside of her window all the time. She was a great artist. This was a teenager, and she would clean it all off with alcohol. And she had a candle in her room. Oof. And she sustained almost a 70% burn. Terrible, terrible, terrible injury. So yeah, there's that. So your question on who do I take where? Whoops, it went too fast. There we are. That's kind of hard to see on my view, but so it gives you some guidance. Partial thickness greater than 10%. Okay, you can take a picture of it. It's on up to date. It's on the ABA website. You can Google burns transfer criteria. You'll find it anywhere. Burns that involve face, head, feet, genitalia, or major joints. That's because of the rehab and surgical process. Those are all very necessary, right, for all of us to come back to society and be functional. So we want to give them the best functional outcome possible. 3rd-degree burns, any group, any size. Do they have to go there emergently? Maybe not, if it's smaller, but they need to be transferred there, and then they need to be followed. Any electrical burn, any lightning injury, any chemical burn needs to come to us eventually. But the partial thickness of greater than 10 or any 3rd-degree burn in any group, those are the biggest ones. And again, I know it's giving you guidance on TBSA, but if you think to yourself, if this is a patient that could go home and do their own dressing change, or is this a big wound that's going to be really painful and going to cause some significant problems with trying to do a dressing change at home, they probably need to go to a burn center. That's probably a really, really easy way to kind of gauge that when it comes to size. If you think you could go home with this and change it every day, it probably can go to the local ER versus needing to get it right out to a burn center. Anybody with comorbidities and extremes of age, the very geriatric population versus pediatric. There's lots of specialty stuff that happens on that as well. Comorbids, we manage our own comorbidities. We're our own hospital of service as well. So we have to manage, their illnesses, their chronic illnesses, the illnesses that certainly come out. We get a lot of AFib, pneumonias, things like that. We have to manage all that in addition to their burn injury. And then concomitant trauma. Trauma has to be taken care of first. I know looking at skin that's burned is very distracting, and that's where your mind always goes. but just focus yourself back on the ABCs. What's on their skin isn't gonna kill them. Now, if they have a pelvic fracture, that can kill them, right? So they need to get the appropriate evaluation and then come to us later maybe. Did that answer your question?
Yeah.
Yeah? Did that helpful?
Yeah.
Okay, good.
Thank you.
Questions about any of that? No. I have a slide with my email. There's my email for both Ashland Children's and PHI if you ever have questions. Need just a topic expert to weigh in on something, look at a protocol, whatever, please feel free to reach out. Thank you for having me.
Thank you.
Hopefully that provoked a little thought because it provoked some of mine or some thoughts in me because Tyler, how long does it take to empty a liter bag through a 16 gauge and a pressure bag? Not long, we're talking 500 mLs an hour. And we think, well, they're going to get 8,000. Why not give them 1,000 in 30 minutes? So that really provokes some thought is like, well, maybe you overdoing it right off the bat. And then we started talking about chemical burns. And then it made me think that a quarter mile from our base is Madison Chemical. Chief, do you know what chemicals they have in there?
Shitload.
A shitload. And then Mr. Wright back there and Tyler, and then we have Meade County Supervisor. I mean, we get called for 911. We expect to just go up and to start dealing with anything. We should be pre-planning some of these things. We should know, from a fire point of view, what chemicals are in there, because that's your jurisdiction, right? We don't need any trade secrets or anything, but it'd be nice if we had some idea of what's in these places. What are we going to be treating when we go to some of these places? So I see a big opportunity to pre-plan to get into some of these factories in your area because we're always retroactive. We're never pre-active. Is that right? All right.
Well, safety director, she's actually doing that right now. We actually flew over. So we actually
help you. So if it involves things like this, chemical plants, how many chemical plants in front of fires? The burn community has a disaster plan. We have a disaster response. We're all interconnected, and one phone call to right on the ADA website, call, we will help you. And we will sort out where patients can go, who can help you, who can come into town and help you. They have very, very detailed disaster response plans, so don't worry about the victims. If you need help, have questions, please call.
Okay. Matter Luke, if you will come and hit some buttons. Any other questions? Anything that did you have an aha moment? Mine was I was giving too much fluid in the beginning, and the others, weren't we out pre-planning some of these places?
If you on the first one,
Hold on just a second, please. So do all of them or just ours? So if you'll stand up and say loudly. What you just said, I'm the only one heard you.
Emergency Planning Commission should have all the list of chemicals that's in your factory, that's in your area, that is readily accessible. They don't only have them, but our dispatch center has them. Whether they can transfer that to us or not, I don't know, but we also carry for just our area, which is 36 square miles with I don't know how many factories right off the top of my head, but we have that on our engine. So we have a list of chemicals and what they've got in there.
Yeah, and from the air medical side, if it is something like that and you're flying patients out, if you can let our comm center know what type of chemicals are actually there, because then we can Google real quick or get on the ERG book and look up, okay, wind direction versus how many miles do we need to even be away, and we're going to have people brought to us instead of landing at scene, and then what type of treatments we're going to have to start thinking about and where we're going to take those patients.
If you have everything pre-planned, you get everything set up right, and do your steps right, and then decon, you guys don't have to worry about if we do our decon there on site.
Yep. Yeah.
And decon, as she said, that's a big one because you don't want to be overwhelmed in your ambulance. Helicopters, smaller areas, so we don't want to be overwhelmed either. So
I don't want the pilot to be.
That 30 minutes of decon is, hopefully each one of these lecturers provokes a little thought. You learn some things. I'm taking notes on the board. I'm typing some stuff on my phone. Tyler's making fun of me, which is fantastic, but please, do a lecture eval. Stephanie Steiner, thank you so much for coming down. It was good stuff. It's always provokes some thought.
My course evaluation is good.
All right, you said that, Brian? Okay, hey, let's take a very quick 5 minutes like we did the first time. While we're changing over, getting ready for our next lecturer. Just get up, use the restroom real quick, just go straight there, straight back, move on.
Oh, yeah. Hey, Brian.
I sent you a copy.
And you got me in trouble.
How did I get you in trouble?
Reaction got you in trouble. I did not choose how you reacted.
How'd you not think I was going to shit myself?
Actually.
Oh, look at all today.
Did you put on a flash drive?
I did.
Oh, okay. Well, shit. I was going to say, be like, well, I can just forward the email to myself real quick.
So we're sitting there.
Dude,
All right.
it's so good to see you. Yeah, I'm sorry I keep missing all your texts.
Yeah.
Yeah.
You get a new number or something?
Right over here.
No, the same way, plug your own thing. You know, give you my regards. I know, right?
I love it. I would lose it. I would have to have it on a keyring.
I keep it on the carabiner.
On a massive carabiner.
No, we're going to go fast.
Sean, how much size is
So I
it?
took it this morning, I saw Sean, I'm like,
At least a terabyte.
No, actually, it's old. I think it's
I mean, I'm
a couple gigs, maybe. Not big.
Because I want to start getting it up there to leave at the ace. So like if we have like a good range, like thing, I can get the back from you, download it, send it to Drew.
Yes.
And him and he can dissect it, and then he can actually like I can set something up to meet with everybody. Like, hey, there was this. And
Yeah, because I know you probably know we can access
But it will be a lot of fun.
particular blogs. Yeah, no, I mean, that's it.
Okay.
I don't know why it's acting all funny.
but it'd be, well, you're only.
Microsoft Edge.
I'm so I'm like a year and 2 months out from yeah, I'll start making a little money for
It's some of their magazines like
I wish you'd just come down, we missed our motorcycle ride. Weather, that's fine. Christmas is coming up.
the fibers and stuff.
Ask Jamie what our Christmas party is. He's trying to come.
December 14th. Yeah, it's gonna be at like 7 p.m. If you got the kiddo and stuff, Santa Claus, Mrs. Claus, reindeers, all that's gonna be at the airport before that for the public. Oh yeah, we can go walk up a little bit earlier.
Oh yeah.
I took an art class.
Is that what, are you setting this up?
Trying to.
Because none of that is what I want to see.
Hey, will you come down?
No.
Do you think that I playing drums? I actually played my first show over the summer as a drummer.
I texted you 15 minutes.
Yeah, it was just like a little. We did like some Nirvana covers. But yeah, that's pretty fun. Yeah.
My son who's off in college and he's majoring in music, come out with his second album. So he's done that.
There we go.
You guys were like,
Oh wow.
yeah, a private college.
How are you?
His mom is doing well. He's very good. But, you know, in the meanwhile, I convinced my wife to get a faster airplane. So we got a faster airplane. So we can be out there in 2 hours and 15 minutes versus an 8-hour drive. But we went to all these state colleges, but we wanted to see this one because aviation. So we went out there and we stepped out of the car and he's like, I got a funny feeling. Of course you do. Yeah. Well, you guys haven't started
Actually, so the things like teaching
Lucas.
in my med school, and then her husband, the guy, so we're just like a little group of stuff.
Last year I got to see him twice.
All right. Yeah.
He said that.
All messed up, don't you, man?
Well, it's a PDF.
Hey, Luke, please.
What is that? It's not PowerPoint, it'll be converted over to PDF. I don't know how that's gonna work. So Brian's lecture's on PDF on Edge.
How's Amy? How's Eric?
Oh, gosh, well, Eric, I haven't really spoken to him.
I remember that. I can try to upload it to OneDrive and log in, but then you'd have to log the computer in.
I think what you're gonna have to do is just have to bring it over Mac's side and then Josh just have to.
Either that, I mean, it might,
It's open up space.
Johnny can just scroll.
yeah, either that or put it in presenter mode and the clicker might actually work.
How do you do that? I did it with Google, since we're already on Google with YouTube.
Oh, then yeah, you might not be able to.
There we go.
Pull that.
Exactly, that's, yeah, we're the only.
This is why he's.
We have
Now here I start to put this.
at our
Throw it.
But there was.
Presenter mode. And then here,
This is share.
So when I did the we also, in our lab.
There we go. Perfect. Is it clicking through?
It did.
Beautiful. I love when a plane comes together.
All right.
Yeah, we are.
All right. All right, if you guys kind of migrate back to your seats.
Thanks again. I gotta
All right, so you guys have every time we seem to do this, we just end up with great attendance. We have great lecturers. So the next two is no exception. The people that we've had this morning are just fantastic. The last two are just fantastic. And we're just so glad you're here. If you would, and I don't know how we would do this officially, but Matt, the big tall guy running around, on your way out this evening, if there's, or write down, let's do this, write down a little piece of paper. If there's topics that you might want to see when we do this year, Matt's back there. You can give some suggestions to Matt, because we try to find things that, one, just not a lot of exposure. Two is some things that are kind of hard to come by. And then there's things that we just need refreshers on. Burns, because anytime you come up to the winter time, you get the kerosene heaters in the house that sometimes things don't go well, or you get people that are trying to put charcoal pans under their car to keep them warm and burns. So we try to pick things that are coming up seasonally, things that are kind of hard to get education other places and stuff. So next year, we've already talked some things we would maybe like to do an OB and things. And I would really like to see, and it's something that we overlook, but I think it'd be awesome if we can have somebody come in to do EMS health psychologically, to get a therapist to come in, because whenever I would help teach EMTs, I'm like, if you want to be successful, I think it's a great idea to see a therapist at least every other year. I talk to therapists. There's things that we want to forget. There's things that we're not going to live long enough to forget, but we need to learn to take care of ourselves. We overlook that a lot. And so I'd like to see that put on the docket, just a therapist come and tell us how to help ourselves. So this next gentleman has come to us from Rushville. He has transferred to our base in Madison. So he has come here to help you all out and help us. He is really, it hasn't taken long to really get to like this guy, and you'll find out why. Super nice, super smart, we're glad to have him. Glad he's here. Brian Frander.
Thanks, Johnny.
All right, it's fine. Go ahead. Yeah. Wake yourselves up.
I will preface this with Johnny's use of the word fantastic as a presenter is probably a stretch. Bear with me, because not only did I have to follow the Stephanie Steiner, you were supposed to have somebody up here smarter and better looking than I, but alas, you're stuck with me. So, who loves cardiology? Who's just so passionate about reading EKGs and they can do it all day long? All right. The man in med school, okay. That is usually the general consensus. So there's not a lot of slides to this because I want it to be thought-provoking. Everybody can read an EKG. I want you to train your eyes to look for the things that do not jump out, because there's a couple of things that might seem minor, might not seem a big deal. Even the presentation of the patient might not be a big deal, but they can drop dead on you at any second. So this is, look for the fine-tuned things, okay? Who's heard of fascicular blocks or hemi blocks? Okay, okay. What's the difference? Kind of a trick question. Hemi blocks is an older term, but it is also more encompassing. Like, you know how a square is also a rectangle, but a rectangle can't be a square, right? So that's kind of where we're gonna go with this. Is it you or is it me? Chicken before the egg. What are we looking at? Did something cause it, or is it the underlying cause? So you see somebody, first let's go to the bottom. STEMI versus OMI. We start with an OMI. They're starting to get away from the use of the word STEMI for a myocardial occlusion. They are going to occlusive myocardial occlusion. Still an ACS, still an AMI. But as you'll see when we go through some of these ECGs, you won't always have ST segment elevation, but especially when they get to the hospital, they'll pull a troponin, they'll do a diagnostic cath and see that their heart is just garbage, right? So you get a patient and you're like, man, this has got to be a heart attack. Short of breath, complaining of chest pain, pale, cool, diaphoretic, just looks like garbage, right? Got to be a heart attack. Blood pressure is not great. Sats aren't great. No real significant history, right? And you're like, man, this is definitely a heart attack. What if I told you that's what his EKG looks like? How many of you would say that that's a relatively unremarkable 12 lead? Yeah? We'll come back to it. Do you have to have, by definition, a cardiomyocyte death for cardiac insufficiency? No, right? You get your CHFers, you get these people just with terrible cardiac output, their ejection fraction is 12. But what is causing that? What is causing that particular underlying issue of poor cardiac output? Is there cell death? Does there have to be? That's the question. Who can name all of the pacemakers of the heart? In order, of course. Nobody? There you go. So, all right, let's go back real quick. So SA node, AV node, bundle his Purkinje fibers. Who can tell me where the fascicles are? You'll see them there. They come off the septal wall, innervate different sections of muscle, some of the valves, things of that sort. So why do we do 12 leads? Right? Crappy. What's that?
Look at the different views, give you a different angle.
Correct. What are you looking for? Abnormalities. Okay. Broad term. There's a lot of abnormalities. Right? We can do 12 leads all day long, and you hand that same 12 lead to 12 different cardiologists. How many different answers are you going to get? Probably 12, at least 10. No offense. So, right, these are all the things that you're looking at when you see an EKG rhythm. I want you to think of it as like a different language. We're trying to read and learn a different language. Who's heard of a true 12 lead? Something that is actually called a true 12 lead. Because on your normal 12 lead, how many leads do you actually have? 10. So a true 12 lead is also called a 15 lead. Which, so yes, can you do a right-sided EKG? Sure, but you gotta move it. But there are 15 leads, and I've seen docs do it, and it's actually pretty cool. They need a little bit, obviously different equipment, but you can basically monitor all of your standards plus V7, 8, and 9. It was actually pretty neat. I saw it in an ED, this doc who was actually just happened to be doing rotations in this particular ED by trade. She was a cardiologist. And so everybody that came into the ED, everybody got a 15 all the time. Pissed off a lot of the nurses, right? Because they're like, man, how many more stickers you got to get? Especially you get those fluffy people where like now you're trying to reach around them and nobody wants to touch them and they're sweaty and they're gross and, you know, just all of that stuff that you hate going into people's houses for, right? Oh, did I break it? Did I break it?
No, you did not.
Johnny probably clicked off.
I did click off because Alyssa, I think she's going to have a question in a second. So I'm trying to get clarification, what she wants clarification
Perfect.
on.
All right.
We love questions from those that's watching out on YouTube.
Certainly, by all means, please do it. So part of the fascicular blocks, hemi blocks, you're going to start looking at axis. How many people look at, when the 12 lead gets printed out, how many people look at the axis? Okay, just a handful, right? Do you know what you're looking at? And how many axes come out when you print it out? There's 3 of them, right? Which one's the most important? That's it. QRS, that is your most important. And so this is kind of what you're looking at, right? So that section between 0 and -30, you see how it's still considered normal access, even though we've now actually deferred from the actual access. That is what they consider a physiologic left access deviation, right? And there's a certain percentage of people that have it, right? How many people go through their lives in AFib and nobody ever knows? It's about 10% of the population. So not just a few. Same kind of deal with this. And then you've got your normal access, so positive deflections, and then you've got your right access deviation, and then your ERAD, which is your extreme right access deviation. And that's, so let's go back real quick. Can anybody tell what is wrong with this? Like I said, it's unremarkable. We'll get to what this becomes, and there's some highlights. Look at the deflections.
Yeah, negative deflections.
The deflections are in the wrong spot, and some of the leads. So, Johnny. Oh.
No, Johnny, me pointed over here, not to the board.
Okay.
Amazing.
Weird how that works, right? So positive, right? You do the leads, looking at the heart. If it is going towards the positive, then it should be a positive deflection and it's moving away block, right? Everybody knows that. But this is kind of a visual representation of what you're looking at and how much farther it gets deflected across from its quote unquote normal pathway. And so there's a lot of things that can cause that, right? It's point being is that this doesn't, you don't have to have a STEMI. You don't have to have an MI of any sort in order for you to have deviated access, which will automatically pretty much reduce overall cardiac output. Their heart is not healthy. Who can tell me what this is? Any guesses?
Truly.
It is. That is a 12 lead of cardiomegaly. Why are the QRSs so long? So you've stretched your pathways. So now it's taking longer for it to go because your heart's bigger. So again, what was the reason that he has a big heart? Is it diet? Is it health? Is it congenital? These are the little things, aside from obviously the voltage that is pretty extraordinary. Other than that, it doesn't look like his heart is too bad, but it's big. He's got remodeling. So what does that tell you? So remodeling, so you get hypertrophy and you get remodeling. It's the size of the space, whether typically it's a ventricle. So you get thickening of the muscle walls, which is like your megaly and hypertrophy and whatever. Remodeling is the increase of that particular space so it can obtain more blood since the wall is coming.
So the common.
Yes, more or less. Yeah.
Okay.
Right.
I just never heard that term, so. Would that eventually lead to congestive heart failure?
It can. Because what are you now missing? If your heart's big, your ventricle's big, you don't have your Starling effect.
You don't have the ability to contract as easy.
Yep.
There we go.
So you have lost your Starling effect, you have lost your contractility, and basically your isotropic, right? The squeeze, how much kick you're getting out when that particular thing pumps. So you will eventually get congestive, but typically most people, you start with one or the other. You get left heart failure, right? It's not pumping, and now it keeps going. You eventually get right heart failure because it can't move the blood. So now your right heart strained, and then you go into complete total congestive. So maybe this guy hasn't seen a doctor. Maybe he has no clue what's going on. Do you tell? Go, hey, by the way, like this is the little stuff that especially y'all know those people that, when was the last time you went to the doctor? No. Cool. And you're clearly a non-compliant diabetic, yada, yada, yada. So you're not going to be able to convince them people to go to the doctor anyhow. But on the off chance, if he goes, oh, well, it's been a while, you're like, tell your PCP to do an EKG and maybe refer you to a cardiologist. Because if you catch this early enough, maybe it doesn't lead to all of that strain and additional. I mean, obviously we've already got some, but you might be able to keep him from getting tapped and doing dialysis and all that other jazz.
Brian?
Sir.
Alyssa would like to know, are we looking to the axis measurement for deviation to key us in on determining physiologic or pathologic causes?
Yes, to both, because like I said, that if you're a normal, that is all pathologic, and then you can have some deviation that is physiologic. Some people just walk around with it, but pretty much any other deviation away from where it should be going is pathologic in some way, shape, or form. That answer your question?
Well, if she types and tell me, I'll tell you.
Cool. All right, let me know. What else? So back to where this all began, vesicular blocks. Impulses, as you can read, conducted to the left ventricle via the posterior fascicle. So if you remember, so there's as your bundle of his, you got your right and your left bundles. And then when you get into your fascicles, you have a anterior, posterior. And so left ventricle, posterior fascicle, innervates it. And because the impulses reach the left side leads later than normal, there is an increase in your R wave and peak at the time. So has anybody heard of, typically you'll see it more in hospitals, that new onset left bundle branch blocks are basically treated as a STEMI. So kind of to that effect. So you'll get bundle his, whatever, you'll get these deflections. So not only can you get deflections away from its positive lead, You can also get those bundle branch blocks. And you have got right and left bundle branch. Everybody can tell right versus left, right, the whole turn signal thing. Anybody heard of the term just an IVCD, an intraventricular conduction delay? It's not specific, right? Just a general term for either. But the left bundle specifically is what will cause all of the issues down the road or even right now. So when you get those patients with new onset left bundle, and nobody's going to necessarily know that, right? Unless they follow a cardiologist. All you can do is be all like, has anybody told you you have a left bundle branch block? And they go, no. Has anybody ever checked? No. So what do? Do you treat it like a STEMI?
Depends on how they're presenting.
It does depend on how they're presenting. Point being, back to the whole OMI occlusion, you don't have to have a clot to have cell death. You don't have to have a clot in order for your heart to fail. So you're not going to treat the left bundles, right bundles. And truth be told, you're not even going to really treat, per se, the fascicular blocks or the heavy blocks. That is an electrical thing. This dude, it's cardiologist, nuke med, whatever it might be. They're going to go to the cath lab, and all you can do is treat how they present, treat your typical symptoms. Now, follow your protocols, but some of these people, depending on the etiology, may or may not benefit from nitro. It just might not do them any good because it doesn't have to be a clot in order for your conduction to be delayed or wrong. Does that make sense, everybody? So the little things. Train your eyes. Look at the millivolts. Print it out if you have to. Read it. Even if you print it out, obviously not in the moment because you got a patient to take care of, take it back. Study it. Look at it. Look at all the little different things. And then you can sit there at your chart or after you chart, looking at it, and you can Google everything. It's out there. We'll get to somebody that has really good information. So, Scarbosa criteria, however you pronounce it, doesn't matter. Has anybody ever seen this? Yeah, it happens. Who here uses LifePak, specifically 15? Do you know that the LifePak automatically runs your patient for Scarbosa criteria? Which means if your LifePak comes out as a STEMI, and say you know all there is to know about Garbosa, you'd be like, oh, well, he's, it's not really an AMI because he's got Scarbosa. Well, your monitor already ran it for that and it excluded that patient. So even if you think he's got this, so basically it's a STEMI with left bundle branch block and access deviation. Because all of those STEMI equivalents, that we talk about and that you hear and people are lecturing and make sure that it's not just a STEMI equivalent and, you can just let your patient ride. Well, like I said, and I think even Zoll, some of the newer Zolls are starting to do that too. It's already run some of these criteria. So you don't have to have ST segment elevation for your patient to present like crap, to be having all of the typical signs, and then they cath them, especially if you guys get follow-ups. They cath them and they go, they were clean. That happens. Because you don't have to have that. Anybody tell me what this is? That is Brugada's syndrome. Anybody know or treated anybody with Brugada's syndrome? I worked with somebody, so it is typically genetic. I worked with somebody, his twin brother at the age of 28 dropped dead. Out of the blue, for no reason whatsoever. There was no bringing him back. That was it.
You say it's pronounced Bargosa?
Brugatus. So there are 3 types. I don't think I wrote down all 3, but it will be on the next slide. But this is your typical presentation. If you see that on your patient, specifically so you will see that in leads V1 through V3. If you see that, be on your toes, because it's one of those things, like, if somebody gets hit during the relative refractory period, right, during the repolarization, they go into VFib, that's it, they're done. Very similar.
Well, go back. So, I mean, when you see this, are you talking about the inverted P's? You talking about the slides of the ST or
both,
what?
Both. So for this type 1, you have to have both. You have to have the extended QT with an inverted T wave. And like I said, that's type 1, which is, I do believe, the most common. So I don't know if you can read all of that. Basically, it is a genetic dysfunction in your sodium production. So basically, you don't have it. Your body will shut down. Like I said, his brother was healthy, kids, whole 9. Nobody knew what happened. Everybody freaked out. Autopsy, it came back that he had that. So the guy that I worked with, it was him, and he had 9 children. Now, it is predominantly found in males, but women have it too. It's much less rare. So him and all of his sons, however many that was, like I said, out of 9 children, figure it's at least half, whatever. He had them all tested for the genetic marker, because it can attack at any time. So those are the 3 there. I won't get into them. This is a very basic of the 3. Each one basically has different criteria that will make it Brugatus syndrome. Each one is a little bit different, and so you can go online and take a picture of that. Like I said, that is just a very brief rundown. But specifically, type 3 is basically type 1s and 2. So it meets all of the other criteria, and then it has the actual ST segment elevation. As you can kind of see, the J point's kind of weird because you don't have the actual beginning block, that you look at when you're on your 12 leads. That's what you use as your isoelectric line, right? Don't look at where this is in relation to your T wave, because the whole thing might be off. Look at your box. That is what it is capturing as your isoelectric line. So go back to the beginning of the page and then measure to see if your ST segment has come up or down from the isoelectric line. That's how you know if you've got depression, elevation, not necessarily with the line that it's next to on either side. Like I said, it's little things. I mean, you can sit here and you could have a whole day of nothing but cardiac lectures. And I think a lot of it gets missed because it can be a pain, right? It's a lot to remember. Everything is so different. It is. It's like you're trying to learn a different language plus all the variants of that particular dialect. Same thing. You're not going to know all of them, right? And so I think a lot of it gets missed, which is kind of why I wanted to bring this topic, right? Everybody can see a STEMI or an OMI. Everybody can see AFib. Everybody knows what VTAC look like. But there's other stuff out there just as dangerous that isn't as widely seen or isn't as widely recognized. Let's put it that way. And a lot of this can be clinical indicators of how your patient might do during that transport. If you see some of the classic signs, you might know, like, oh, well, he's doing fine now, but might not be in the next 5 minutes, depending on how long, whatever, 45 minutes, whatever your ground legs are. So all of the little things, pay attention, because it's neat, especially if you come back, like I said, print out your 12 lead, go back and just just look at it. You'll find a lot of stuff. Clearly, I'm a little interested in it. It's neat for me. Let me put it that way. There was obviously no super applause when I was asking who likes cardiology, right? It's a lot.
So question, since it's a sodium issue, is that something that if we bolus some saline, it's gonna help at all?
Not
or
really,
just-
no. It's because it's the body's ability to like use it, maintain it and whatever. It's a genetic flaw. So even if you pump them full, they still might not be able to utilize it. I mean, it's like the cardiac's version of a diabetic. You know, and anything else, obviously you don't want to fluid overload anybody anyway. So it's like, how much are you going to have to give in order for them to maybe make a difference without flooding their lungs? You know what I mean? Yeah.
Okay, too much sodium, not to stop fire.
Come again?
Too much sodium, stop fire.
Yep. So when your myocytes can't contract, when they can't interact with each other, right? Because in theory, you have pacemakers, but myocytes kind of have their own little internal one too, right? So yes, and that's typically what will kill you is you'll start with this, and then your heart will you'll go into a lethal arrhythmia. And like I said, despite resuscitation efforts, some of these people you just can't get back because it's too late. They needed, you know what I mean? They needed interventions and some type of therapy. I don't know what the total, like what the complete fix is, if there is a complete fix for it. But yeah, I don't know, but it will stop the heart. You will go into arrhythmia because you can no longer use those sodium pacing channels.
There's a lot of athletes that have been diagnosed with this problem.
Mm-hmm. Yep. Questions so far? Not a whole lot left. Like I said, I didn't necessarily want to teach you anything. I wanted it to be thought-provoking. I wanted your head to get the wheels start turning. Go back at all your patients who maybe presented like crap, but their EKG looked fine. How many things did maybe you miss? Not that it's your fault. By any means, that's not what I'm saying. Because I've done the same thing. Because I still run squat out where I'm at too. So, our transports are 20 minutes. And I'll get a follow-up and they'll be all like, oh yeah, they had this, went to the cath lab, blah, 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 needed an LVAD. They were fine for me. But you know what I mean? Like, I didn't see it. So it's going to happen. But that was just my point is to get the wheels turning. See what else is out there. See what else. Oh, gotten too far. So going back again, roundabout, all the way back to the beginning, fascicular block, tibia blocks. These are your typical signs for a left anterior fascicular block. So you'll have your S complexes, 2-3 AVF with small R wave and deep S waves. So let's start with that. 2-3 AVF, small R waves, deep S waves. So this is the one from the very beginning of the presentation. So 2-3 AVF, right there, small R, deep S, right? And it's negative. QR complexes leads one AVL with small Q and tall R. So your greens. See how this unremarkable 12 lead has quite a bit going on with it? And then your left axis deviation, which obviously the capture did not do it, but it's going to be, does anybody remember how far you have to be for left axis deviation? What the numbers were?
-30 to 90?
-90. -30 to -90.
Damn. I've underestimated you.
You taught me everything I knew, John.
So, same question. Does there have to be a clock? Did your answer change throughout this presentation? Did you initially like, well, yeah, clearly there has to be myocardial death, otherwise they wouldn't be having issues, which in part is true, right? There's still electrical activity not making it to where it needs to go, because it does not necessarily mean the cell's dead. Maybe not. So I do believe this is the last one. This is a nice, easy way. If you don't have the printout, or if you don't totally remember what the numbers say when you look at the wheel, this is a little easy thumbs up, thumbs down kind of game, right? And what you're looking at is just leads 1 and AVF. So 2 up, everything's great, normal access. Lead 1 up, lead AVF. So this is talking about deflection. So where it is, whether it's a positive or negative deflection. So lead 1 is positive, lead AVS is negative. You got left access deviation. Apparently I'm having a stroke. Lead 1 negative, AVF positive, you've got right access deviation. And then easy one, both down, everything's garbage. E-rad is your most dangerous. It is, which is why it's, because if you think about it, it's going essentially clockwise. So it's either getting kicked to the left or it's getting kicked to the right. So when you start moving literally in the opposite direction, not just off of where it should terminate, but when you start actually getting deflected all the way, like 180 degrees, that's a bad day. Bad day. How do you think that was it? Questions? Who loves cardiology now? Nobody. Like I said, there's a lot out there. A good source is, I forget what his last name is, but there's a physician. He's a cardiologist. His name is Kevin. Like I said, I forget his last name, but if you look up EKG Guru, you'll find his stuff. And he will take completely normal looking EKGs and just point out. And each one it's a different thing. So if you want to look at all the little different stuff, he's fantastic. I mean, it's not long. I think most of his stuff shows up on Life in the Fast Lane. And he'll pick one, somebody had submitted something and go, hey, what's up with this? And he'll pick it out. And sometimes it's AFib. Maybe it's a flutter. Maybe it's a heart block. Maybe it's normal. And he'll find all the other little different things about it. And so it's neat. And he does a very similar thing with the color coding, and, he'll have descriptions and, it'll point out a bunch of different things. But like I said, everybody can pick out the easy stuff. Try to find the minute stuff. That, again, not necessarily going to say that you're going to save your patient's life by finding it out, but you might. Questions?
All right. And some of you sitting there, you might have thought that was just way over. When you come up with a symposium, you have got all aspects of EMS. We have first responders and we have critical care paramedics. So we take some of your feedback. So when we do things, we want to hit all aspects of all of those disciplines. And one of the feedbacks we got last year is from critical care paramedics. It's like, hey, you mind throwing in something challenging is what the words that they used. So whenever Matt sets up the schedule, and we only have, 6 presenters, 6 subjects, and we try to hit the first responders, the basic EMS, advanced EMS, and the paramedics. So when some of that seemed over your head, and it probably was, but it's so we can hit each aspect of EMS. So what some of you might have been like, bull crap, and others like, dude, I've been waiting on something like this. So when we set up a symposium, it's to cover all aspects, everybody gets something out of it, and we still want to challenge you some. So that was an advanced lecture, but there are going to be some people, I'll get a text later, it's like, dude, loved it. tell Brian he did a great job. Well, I'll tell you, Brian, you did a great job. So keep that in mind. So next year, whenever you're writing down things, suggestions and stuff, so we take those and we implement them. So that's why this lecture came in at such an advanced level, because it was asked for. And then our next presenter is going to be fantastic. It's not going to be the axis of cardiology and things. It's going to be back down to some things that we can understand. So let's take a very quick 5 minutes. Matt is going to mess up the computer, holler for Luke to come to fix it. I'm going to go use the restroom, and then we're going to bring up our last guest.
Did you bring me a cupcake?
It's wrapped up and it's mine.
I just need my flash drive. Oh, yeah.
We'll throw away my garbage. He just couldn't wait.
Thank you. I mean, he was really trying to grab the guy, let's be honest.
Some ideas.
Okay, yeah, so at the end, before everybody leaves, I got my other infamous QR code that actually works. I like handwriting, that makes me feel special, like I'm back in high school.
Yes or
Teachers
no?
will get me in trouble,
Yes or
yeah,
no?
yes or no, hard and arrow. But yeah, I also draw them down as well. It's all completely anonymous. But I literally, once all the results came in, I literally had like a meeting at work. I was like, hey, this is what it was said. Right? Some of the stuff. So it's got various things, a lot of
Yeah,
free
well, he
text.
said write down ideas for
Yes.
things for next year, maybe.
Yes, I will totally do that. I got actually my work notebook with me, so I'll put it in there so I know where it's at.
Even mass selecting just that.
What's up, big guy?
What's up, buddy?
I got my little flash drive here for you.
Oh.
Yeah.
Okay, don't forget to do his submissions.
Oh my gosh, he's such a man.
He fucked up, I'll leave that there.
Oh, look at that chat.
Yeah. What's this? Some nurse over in it's somewhere or another sheet. I don't even know where I saw what's on there.
Where's that
I looked her up.
Yeah, probably.
Someone go for it, yeah.
Are you sure?
Yeah.
Okay. We'll see.
Unless that's. Hopefully that's not it.
That's what I told Kelly earlier. I was like, here's my flash drive. That's fine.
I just hope that I don't.
Do not upload by accident.
You said here's your flash drive.
Flash drive, yes.
Cool.
Hold on, Pops. I'm sorry.
Thanks.
You're welcome.
All the C.
Sweet.
If for some reason the sign-in does not work and you have attended the whole day, I will personally go in tomorrow and verify that your name is on every single roster. And I will copy and paste. But the evals you will have to do by yourself because I refuse to do that.
What was the last guy's name?
Brian Frainer. Franer. Don't confuse the A and the I in Brian or it'll be Brain.
You know, you said that and then I typed it the wrong way.
That's how it happens. Get on those big jobs.
I need him to get back to me.
You don't have it memorized at this point?
Do you not remember that stuff?
Like make presentations.
I think.
But as long as you don't get 50 ml of propofol instead of 50 milligrams of propofol, you'll be okay.
There's a nurse.
I'm sure there is. Yeah, I do.
You know.
I was so happy.
More work for Matt.
All right.
I would never wish death on anybody except for.
Give me the dry erase marker.
Maybe it's really not.
It really big.
Is this the little clicker thingy?
Yes.
Sweet.
Right wing, left wing.
Cool.
Oh, no.
Hey, will you go back to my QR code for a second? I just walked in, I had to go potty. Listen, I'm so sorry.
But I'm not the only one. Appreciate it if you're not.
Oh, no.
That's a nugget, it's not very good.
Our shirts have pin pockets.
I don't have the.
I did not know that.
Yeah, they all got all of that we received.
Yeah, I did not know that. I guess I never look over my left shoulder enough.
No, it's a good place to keep an ink pen.
That is.
Just imagining you walking around in a polo with like a spear catheter, like they're just ready to decompress them up.
Good go. It's going to
Who needs a
straight 14 gauge.
Yeah.
Straight 14 gauge.
In your beginning, you sign up for it, but you have to sign up for the thing. You need to add EMR to your options of what certification.
I will say that y'all are the first ones that actually came, so I did not have that as an option, but I saw it, and I will have that on there for next year. Hey, that's enough for me to put it on there. One would have been enough.
Well, there's more of us right here from one department.
They're representing. I just wanted, I have to take off so I can drive back home. I didn't want to leave in the middle because I'm totally.
Don't take it personally.
Don't take it
Yeah, from the person who helped hire.
They should have put
that
you
is-
on earlier in the day.
I know.
I know.
Even didn't come from lunch. She wouldn't have been here on time as it was.
He was really only here for the free grub. So, but thank you guys. I didn't want to leave without saying goodbye.
You're very welcome. Thank you for coming, Stephanie.
We talked to PHI uppers, tell them what a great job Madison is doing.
I hope so. I hope so.
Don't worry about it.
Are you guys still like crazy?
The last one that I.
Yeah, we did, what, 60 something last month?
Yeah, if we're not in the 50s. Yeah, you would hate it.
Yeah, what?
There is no night sleep in it. Okay, I think Matt has got things squared up. We're closing up the day with a very fantastic person. He helped us open the Madison base. I was his first and only full-time flight partner. What he managed to learn from me in a year was enough to get him through his first 2 years of med school. I'm usually stuck with troublemakers and newbies.
We're sorry.
Yeah, me too.
But to constantly prove my superior intelligence over him, each shift I would come in with a word of the day. And it would be a word that I'd hear on one of the shows or something I just knew, that's what I meant to say. And I'm like, I'm gonna throw that up at Adrian. So I go in the next day and he would say something. I just wait for that time to throw in this $20 word. And I'd sit down nonchalantly as if it meant nothing. He'd be like, Johnny, did you use that correctly? I'm like, you don't even know how to spell it, do you? He's trying to look it up. So this is the first time I've seen him in 2 years.
Yeah, just about.
He will not return my text. We are not friends, apparently. He is not going to give me royalties for all that I've taught him when he gets his first big doctor paycheck. And it'll probably be 3 or 4 years before I see him again. But I knew this day would come whenever I would get the privilege to introduce him in a setting like this and be so proud to do so. But before I give you his name, the word of the day is precocious. So I'm gonna keep you to save you the trouble of looking it up.
Oh, thank you.
But I'm gonna say this, I'm gonna use it in a sentence, and I'm not gonna give you the country of origin, nothing like that.
I'm from Henryville, so you named this guy a bit.
See, I do that around him just so he knows he's inferior.
And he wonders why I don't text. Like,
I am pleased to introduce this precocious young man. I'm proud to call my friend, soon to be Dr. Adrian Morales.
no, you don't. No, none of that. That's fine. Thank you, though. Yeah. So my name's Adrian. I won't bore you with like a bio, but I'm a former flight and ER nurse, current med student, and hopefully future emergency medicine physician. We'll see how that turns out. I still have like a year to go. And today I'm going to be talking to you guys about the management of unstable bradycardia patients. This isn't a topic that gets a ton of attention because no one's really passionate about bradycardia. Like no one gets excited for bradycardia. And it's also, we don't see unstable bradycardic patients nearly as often as we see unstable tachyarrhythmia patients. AFib affects like 1 in 50 people under the age of 65 and 1 in 10 over the age of 65. So we're going to see stuff like that way more commonly. Unfortunately, when patients are bradycardic and they can't compensate though, they are pretty much immediately in cardiogenic shock, which means that they're really hard to manage and that they benefit from early, aggressive, and more importantly, appropriate therapies. And unfortunately, the data suggests that like maybe we're not always giving them the optimal level of care that we could. Part of that is because this is a rare thing. We don't see tons of patients in an AV block all the time. And the other part of it is that the ACLS algorithm for bradycardia, in my opinion, leaves a little bit to be desired. So the point of this like little talk, discussion, lecture thing is to get you guys familiar with the underlying mechanisms that cause bradycardia or conduction disturbance. And then more importantly, just to discuss a framework with which you can approach these patients. We'll go over some meds, but the majority of our time is going to be spent just doing like case study work, because I feel like case-based learning is more engaging, more interactive, and just more interesting for everyone anyways. Those are my objectives. That's unimportant. That's just a mandatory slide that I'll say that you have to put in. This is a 68-year-old male. We are dispatched for reports of seizure or seizure-like activity. When we get there, we find that this patient is actually sitting on his front steps with his wife. She was the one that called EMS. We talked to him, and he tells us that he was just working out in the yard, raking leaves when he collapsed. Talked to his wife. She says that he had just hauled a big bunch of leaves to the yard waste bin and headed back to her when he just collapsed to the ground. After which he had like 10 to 15 seconds of like this myotonic like jerking activity, which she interpreted to be a seizure. He is complaining of a little bit of shortness of breath. He feels tired and he's got a sore shoulder from landing on it, but otherwise he's feeling okay. He's got a history that he tells us about, hypertension, diabetes, and then he also had aortic stenosis, which has been repaired with valvuloplasty. We do an EKG on this patient, and this is what we see. Yeah. So the interpretation was not supposed to immediately appear, but it's fine that it did. I know all of you guys would have been able to recognize this anyways. This is like a 2-to-1 AV block. We refer to it as a Mobitz type 2. And that's where we're going to leave this patient for now until we come back to him after we go through all the basic science stuff. But just keep this patient in mind as we talk about anatomy and pharmacology, okay? All right, yeah, so unfortunately we do have to do like short obligatory anatomy overview. Fortunately, we're not really concerned about much in the heart except for the conduction system. Even though electrophysiology can be kind of complicated, we're really going to dumb it down and only look at the sinus node, the AV node, and the His Purkinje system. We talked a little bit about how cardiac tissue has this cool feature where it has automaticity. So it's the only type of muscular tissue in the body that can generate its own impulses, can generate its own contractions, which is pretty awesome. The way that it does this, if you see this dude right here, this is a pacemaker cell. And that's what its action potential looks like. This slow slope here and the slope here, that is a gradual depolarization caused by these leaky sodium channels, which are actually, they're titled funny ion channels. That's like their textbook name because they behave unlike any other ion channel in the body. And eventually what that does is this slow stream of sodium into the cells raises the electrical charge until it reaches that like dash line across, which is threshold potential, and that actually opens up a bunch of other voltage-gated ion channels. And that's when we get the quick depolarization. And then as soon as it repolarizes, those ion channels are back doing their thing, just bringing slow amounts of sodium back in until they hit threshold again and depolarize. And this is why patients who have undergone like full brain death can maintain a pulse despite having absolutely no neurological input to their heart. And that's a feature that we take advantage of when we're doing like organ harvesting and stuff, because these patients, they have to continue perfusing their body while we're actually removing like a kidney, a liver, stuff like that. So the science node and AV node both have pacemaker cells like that with those unique features. Some other things that they have in common is that these areas are acted on by the autonomic nervous system. So sympathetic, which is like your fight or flight stuff, and also the parasympathetic, which is like your vagal tone, your rest and digest stuff. Both sides of the autonomic nervous system can affect these pacemaker cells and also the AV junction. The His-Purkinje system is quite a bit different. Typically, these cells don't display any automaticity. It's there, it's just that their rate is so slow, it takes them so long to depolarize that we never see it. They only depolarize at a rate of about 20 to 40 beats per minute. And considering SA node is like at a rate of 60, AV node is at least a rate of 40, we're just never gonna see them generating their own impulse unless there is a conduction disturbance. So keep that in mind as we move forward. I don't think there was anything else I want to talk about there. Oh, importantly, the His-Purkinje system not affected by vagal tone at all. You can upregulate the speed at which the His-Purkinje system functions by giving like a bunch of catecholamines, but even then, it's not as responsive as the upper chambers of the heart. And then we're going to move on to looking at a practical way to assess these patients. And really, it just boils down to like 3 questions that we should ask ourselves when dealing with a bradycardic patient. And the first question, the question we should ask ourselves about all patients ever is just, are they stable or are they unstable? If they're stable, then like no big deal, right? You've got some time, you can do some diagnostics. There we go. You can try and figure out what the it's a word of the day. We try and figure out what the underlying issue is. If they're unstable, though, we need to act. We need to be doing things to stabilize and temporize these patients. Bradycardia, like over half the population is walking around right now with heart rate in the 50s, and they're doing just fine. The body has tons of mechanisms with which it can compensate for a slower heart rate. It increases cardiac output by like just making the heart squeeze harder, for one, and then also increasing vascular tone to maintain blood pressure. When these patients can't compensate, though, that's when they become symptomatic and unstable. This is usually manifested by signs of just like malperfusion. So if they're not getting enough blood to the brain, they'll pass out or they'll get confused. If they're not getting enough oxygenated blood to their heart, they may develop chest pain, shortness of breath. It can also manifest as hypotension. And there's a clinical pearl here that goes back to that first patient that we talked about, is that over 50% of syncopal episodes will be accompanied by some sort of myoclonic jerking, like muscular twitching. And to a layman or like a bystander who has no medical training, they will often think that that is seizure activity. And so it's important whenever you get a call for seizure-like activity, you get there. If the patient is alert and oriented, that was not a seizure. If they're not post-ictal, that is syncope until proven otherwise, and there is a cardiogenic source until proven otherwise. The second clinical pearl here is that progressively worsening bradycardia is a bad sign. That's like if a patient starts out with a heart rate of 50, and then over the next 10 minutes, they're in the 40s, and then over the next 10 minutes, they're in the upper 30s. That is a patient that, unless you intervene, they are going to arrest. That is just a fact. It is imminent, and they need to be treated very aggressively. So that's the first question that we're going to ask ourselves when looking at these patients. The second question is the cause of the bradycardia proximal or distal? And what I mean by that, proximal is the SA node, AV junction. Is that where the QRS complex is coming from? Distal is the His-Purkinje system. And we determined this by just simply examining the EKG. Johnny, are you touching things?
He's gonna say no, but I bet it's.
I'm gonna pull you away from this keyboard, actually.
Your sound wasn't working. How many times did you hit the button?
I don't know.
Oh, no, 10, because that's how many it moved. Okay, sorry.
All right. So the way that we can tell if it's a proximal lesion, the QRS can be narrow. If the QRS is coming from SA, atrial tissue, AV node, AV junction, it's going to be a narrow QRS, unless there's some other conduction disturbance like a left bundle branch block or something. But 99% of the time, this will be enough to get you through to localize the lesion. And we see two examples of that. First is sinus bradycardia. There's P wave or QRS. Those QRSs are nice and tall and narrow. The second example there is a junctional bradycardia. We don't see any P waves there because they're hidden, but still a nice narrow QRS. So we know that the QRS is coming from the upper chambers of the heart. And in the distal disease, we're going to see a wide QRS. And the reason why we care about this is because depending on where the lesion is, they will be amenable to different pharmacologic therapies. We discussed just a second ago that the upper chambers of the heart can be influenced by vagal tone, right? Atropine is a vagal poison. So if the QRS is narrow, maybe atropine will work. If the QRS is wide, there's no point in giving it. You should just skip that step and just either move straight to pacing or to giving catecholamines like epi or dopamine, or if you're in a hospital, something like isoproterenol. You can hit it one time now.
And I bet it'll work. Holy shit.
Look at that.
That means crap.
And then the third question we're going to ask ourselves is there like an obvious findable secondary cause of this bradycardia that will either require its own unique intervention or change our disposition for the patient? I've listed the most common ones that I could think of up there. Hyperkalemia, we're going to talk about later. Cardiac ischemia, we're going to talk about that later. The low and slow poisonings, the antihypertensives and antiarrhythmic poisonings, we'll talk about that later as well. You can also get bradycardia from increased intracranial pressure. They've had like an epidural hematoma develop or a subarachnoid hemorrhage or something. It can cause Cushing's reflex, which will drop the heart rate. Those patients are going to need to go to surgery. You can temporize them with osmotics, but ultimately it's going to be a neurosurgical fix. Hypothermia, those patients aren't going to increase their heart rate until you warm them up, no matter what you do. Same thing with hypothyroidism. Those patients are metabolically deranged, and their pulse isn't going to increase with pacing or anything else until you get like synthetic thyroid hormone and steroids on board. And then there's also certain infections, which ultimately will need to be treated with antibiotics, but typically those patients will actually respond to temporizing therapy. Yeah. All right, so now that we have like a schema for analyzing these patients, we're gonna look at some treatment options. This is the ACLS algorithm that I'm sure like everyone here is familiar with. These are the options that it gives us. We can use epinephrine and transcutaneous pacing. So we'll just kind of go through and look at each individual medication one by one. So atropine, like I mentioned, it's an anticholinergic. It binds to acetylcholine receptors. Basically, for the purposes of this discussion, the only important thing about this is that it poisons the vagus nerve. So if your body is constantly bouncing sympathetic and parasympathetic tone, and we take away any parasympathetic tone, theoretically, the unopposed sympathetic tone should increase the heart rate. Unfortunately, this doesn't always work. Atropine will never work in distal disease. It won't work in patients who have cardiac transplantation because their vagus is no longer connected to their new heart. If you give small doses of atropine, it will actually worsen bradycardia. And even if you're giving atropine in the ideal setting, it's only going to work about 25% of the time on patients. I don't know why ACLS demands that we use this medication first. It's not a trash drug, but it's pretty close. A much more reasonable starting agent that you can use for unstable patients is either epinephrine or dopamine. Dopamine and epinephrine they're going to work kind of the same. Dopamine does bind to like D1 and D2 receptors, but really at the doses we're giving, what we care about is it's binding to beta-1 receptors, which are going to increase the rates of the heart rate, and then it's also going to increase contractility, so it's going to make the heart squeeze harder and faster. They'll also work on alpha-1 receptors, which are in your blood vessels, so they'll make your blood vessels squeeze down, increase systemic vascular resistance, which will raise your blood pressure. It's kind of nice to have that secondary benefit there, especially if their blood pressure is already like circling the drain, like systolic 50s or 60s. The dosing is there. Here's a little star asterisk thing by the adults epinephrine and pediatric dosing. It's because I don't know that there is actually a physiological top end for epinephrine, unless you're giving it at just absolutely ludicrous amounts, like 90 mics per minute. You're probably not going to cause any significant harm. I would just say if you're going to go outside your protocols, just consult your med control before you do that. And as I mentioned, beta adrenergic agonists work on the entire myocardium, so even if it's a distal lesion, there's still a chance that you'll get the ventricles to respond with this. Dopamine is more convenient than epinephrine because it's like shelf stable, so I'm sure like all of your ambulance, you guys have a bag of dopamine to use. However, it's actually really easy to make up your own epinephrine drip, so we're going to talk about how to do that real quick. You can, all you need is like some saline and a dose or two of cardiac epi. You can make a push dose by taking a 10 ml syringe of saline, getting rid of an ml of saline, and then drawing up an ml of cardiac epi. That gives you a push dose pressure that's like 10 mics per ml. And then the typical push dosing for adults is 20 to 50 mics. So you just give 2 to 5 ml pushes, and that'll temporize your patient until you can like get the pads on, get them paced, or get a drip set up. You can also make your own like dirty epi drip by just taking a full amp of cardiac epi and just injecting it in a liter of saline. That gives you a concentration of 1 mic per ml. So say you want to give 10 mics per minute, that's 10 ml per minute, or 60 minutes an hour. You just set your pump to 600 mLs per hour. It's pretty easy. You can also draw push doses up from the dirty epi drip if you want to. It's just a little clumsy because you'll need like at least a 20 ml syringe for adults. However, for pediatric patients whose push dose is going to be weight-based, that's actually like kind of useful because you're going to be giving much smaller doses than that. And the dilute concentration allows you to do that safely. So those are the catecholamines that we're allowed to give. And then there's pacing, which is like the simplest, most effective, and like kind of foolproof therapy. Its mechanism is just direct depolarization. We put the pads on, and then anything between those two pads is going to be depolarized by a current passing through them. Amperage, and this is one of those things where like most protocols you look at will say like start low and then escalate. If they're dying right in front of you, just start at like 100 milliamps. Like the goal is myocardial capture and mechanical capture. So don't like dick around wasting your time with like 30 milliamps or anything like that. Same with drugs. Like honestly, if your patient's passing in front of you, don't start low with the levofed, just start high. You can always back it off later. Those patients don't need like a nice gentle approach. They need to be like rescued from death right now. Sedation analgesia is kind of tricky because it is a form of torture just to leave like an alert and oriented person on pads and be electrocuting them 60 times per minute. However, you don't want to like fully snow them, because if you do that, like we would with an induction dose of ketamine or something, if you wanted to transport this patient intubated and sedated, keep them comfortable, we're going to remove all sympathetic tone from them, which can make their blood pressure worse for sure. If they ever stop, like if they ever fail to capture during pacing, they have no sympathetic tone to prop up their heart rate, so that'll also drop. And so it's a good way to kill an already unstable patient. I think a more reasonable approach is to either start with like small aliquots of fentanyl, giving 25, 50 mics just to kind of make them a little bit comfortable. You can also do pain dose ketamine. That'll not only make them more comfortable, but they'll just kind of stop caring that they're getting shocked. You can do a really low dose ketamine infusion as well if you have permission to do that. And then a clinical pearl and a clinical pitfall. So the pearl is that whenever possible, you should be using AP placements. It just more reliably captures the myocardium. One study that I read said that its efficacy is about 78% of the time versus 42% in lateral. That's just because if the pads are placed like this, there's a lot more air that electrical current has to go through, and air does not conduct electricity well. The second thing is that we really need to beware pseudo capture or false capture. It's surprisingly common. I couldn't find a lot of good studies that show like across the industry how frequently this happens, but I did find one. I looked at one EMS agency in New York, and 86% of the time that they were transcutaneously pacing, they were actually failing to mechanically capture their patients. Which, I mean, if you're pacing someone, their blood pressure will probably raise a little bit and their heart rate will raise a little bit as well because you're shocking the shit out of them, which can confuse us. We can think that they are responding to the pacing with that. But unless you have a pleth waveform that agrees with the heart rate that your monitor is reading out to you, you should not believe that you have mechanically captured the myocardium. I don't know why it is. We see the monitor saying like the heart rate is now 60. We see the little electrical spikes and we're like, sweet, looks great. And we see the pleth and it's still like 35. And we're like, well, that pleth has to be wrong then. And then we'll do funny things like, well, the capnography is like raised a little bit, so maybe it's captured, or we'll try and comfort ourselves by like checking a carotid pulse. We'll just feel muscle twitches. We'll be like, okay, yeah, that feels like a good pulse of 60 beats per minute. Just trust your pleth waveform. If you have an unreliable reading on the pleth and you have to check a peripheral pulse, femoral is always the way to go. And it's far enough away from the depolarization, distanced by several muscle groups that you're not going to get any like false muscle twitching that convinces you that you're actually pacing. All right, so that is, and then that brings us back to just going through a bunch of cases. So we're gonna go through them together. I'm gonna ask you questions. If you guys have any questions or anything at any point, you can just let me know. But we're gonna start back with that first patient of ours. So 68-year-old male, syncopal episode, not seizure, syncopal episode, AV block, narrow QRS, those are his vitals. Not terrible, right? Blood pressure of 88/50. I don't love it, but it's not like making me piss myself. SpO2 of 98% is awesome. Respiratory rate, it's probably fake. And then heart rate of 43. So that is a little slow. But he's left, he's sitting on the steps with his wife. What do we think? Is this patient stable or unstable?
Ish.
It's a trick question. He is actually unstable. He had a syncopal episode, which means he's not getting enough blood to his brain, right? So automatically unstable. He also had a history of hypertension. So assuming this guy runs like 140 systolic-ish everyday life, probably the systolic of 90, he's not loving. His body's not loving that. Looking at the EKG, do we think this is a proximal or distal lesion? Nailed it. Yeah, narrow QRS, so it's proximal lesion. Do we have an obvious secondary cause that we can point to suspect like this, a secondary reason why he's bradycardic? Yeah, not really. He had like valvuloplasty surgery, right? Sometimes when they're doing like TAVRs and stuff, they can kind of scar up the myocardium and it can cause AV disturbance. There's nothing we can really do to fix that, right? So we're just gonna have to move on to centralizing treatment. How do you guys want to treat this patient? What do you want to start with?
Maybe some fluid.
Fluids, yeah. Never a bad idea. Everyone gets a liter of fluids. That's like door prize for the ER or getting in an ambulance. What else?
Pacing.
Pacing?
Yep.
Might be a little aggressive.
Maybe start him on like a
I was thinking more.
Yeah, I mean,
Trash drug,
yeah. For this patient, he's sitting up, he's talking. We got a little bit of time to kill, right? We can probably try atropine. If it doesn't work, worst case scenario, we have to move to epi. But atropine may be enough to get this patient to the hospital awake, alert, fine. All right, cool.
Is the atropine actually going to work in a second degree type 2?
Actually, yes. Because remember what I said, vagal tone affects the AV junction, right? So not just the AV node, but also the junction or the cells around the AV node. Because the QRS is narrow, we know that it has to be coming from there or someplace higher. It may not increase it as much as you want, But the other thing to consider is with a secondary AV block, 1 out of every 2 of those P waves is conducting through, right? P waves are controlled by the SA node. SA node is definitely influenceable by a vagal tone. So even if we just increase the P waves on that page, the QRSs are going to go up by half that amount. So I don't think I calculated out what the atrial rate there is. It looks like 300, 150, like 75, 80-ish, right? So if we bring that up to like 100 with atropine, that means his ventricular response is going to go from like 43 to low 50s. It's not a huge difference, but considering that he's already like borderline stable, unstable, right in that line, it's probably good enough. Any other questions? Cool. All right, we'll look at the thing case.
Get it, Memo.
Yeah, cool grandma. Everyone loves a cool grandma. So 84-year-old female, her daughter was going to pick her up. She's going to take her to a skate park. She finds her down at home. Yeah.
Go straight it.
Exactly. Got to take the fingers out, and then she can just grind those rails. She got a GCS of 11. Component score is 2.5. Her capillary refill is sluggish. We look at her vitals. Those are a little bit more concerning, right? I don't love those at all. Heart rate of 45, BP of 79 or 48. Oxygen saturation still fine. And then interestingly, a blood glucose of 230, despite the fact that this patient doesn't have any history of diabetes. What she does have is mild dementia, and also hypertension treated with amlodipine. We look at her EKG and we see bradycardia, first degree block. Does anyone have a guess why this patient is bradycardic?
Well, for one, her glucose levels are high.
Yeah, and that actually gives us a clue why she's bradycardic. We know that she's older lady, dementia forgetful, she's on a calcium channel blocker. This is probably just a misadventure in pharmacology, unfortunately. These patients, they take their BID meds 3-4 times a day because they forget if they've taken them or not. And then eventually, even though calcium channel blockers that are designed for hypertension shouldn't affect the heart in their therapeutic range, once we get super therapeutic because we've taken too many doses. All right. Initial treatment with atropine, dopamine, and pacing is ineffective in this patient. We know she's unstable. I'm not going to bother you asking that. Proximal or distal lesion based on this? Proximal, good. Yeah. Secondary cause we already talked about. It's calcium channel blocker toxicity. And then treatments have already failed, so we'll talk about that a little bit on the next slide. Does anyone have a guess what we could give her to help improve her heart rate? Calcium, yes, no. Calcium channel blockers are competitive. You can just outcompete their ass with calcium if you get enough of it. Clinical pearl, calcium channel blockers, beta blockers, and other antiarrhythmics, other antihypertensives, clonidine, sotalol, any other like type 1, type 2, type 3 antiarrhythmic, they're going to be resistant to our normal means of improving their heart rate. Pacing will probably fail. Atropine will definitely fail, and usually, unless you're doing like really high doses of epinephrine, that won't even work for these patients. So we have to go and treat them with the specific antidote for that medication. So this is the group of like low and slow poisonings. Calcium channel blockers, beta blockers, digoxin toxicity. I didn't even know people were still on digoxin toxicity, but I've seen 2 cases of digoxin overdose in the last year. So apparently there's cardiologists out there from like the early 1900s still dishing this out. And then sodium channel blocker toxicity. Calcium channel blocker and beta blocker, very non-specific EKG findings. They can present with anything from sinus bradycardia to full AV node dissociation, so like third-degree heart block. Digoxin toxicity has this cool Salvador Dali mustache sign at the top there. So it's just like a scooping out of the ST segment. That's relatively stereotypical for that type of overdose. And then sodium channel blockers present like this. So we have a weird wide QRS. You may look at that and be like, hey, that kind of looks like Brugada syndrome from earlier. And this is actually termed a pseudo Brugada pattern. And they will have this big terminal R wave and ADR. Calcium channel blockers, make calcium, like you said. We could also, if we're in the hospital, do either insulin or intralipid. The way that insulin improves like chronotropy is kind of complicated. Intralipid is way more simple and it's pretty cool. There's just fat, like they take total parental nutrition that we would give patients who can't eat, right? They just take the lipids from that and they inject it into the patient. And because these drugs are lipophilic, they will just bind to the fats and then be excreted by the patient. Pretty awesome and super effective. Beta blockers, like I said, we can try and outcompete with epinephrine. We can also use glucagon. So glucagon is cool because it binds at a different site than the beta-1 receptor, but it still does the exact same thing. So you're getting the effects of epinephrine without needing the channel that epinephrine normally binds to, which if that's blocked by a beta blocker, glucagon will usually do the job. We could also use high-dose insulin or intralipid for this as well. The insulin research is actually pretty interesting because a lot of it was done up in Indianapolis. There's a really, he's like a rock star in the toxicology setting, so still like super nerdy, but like he's a big name. His name's like Dr. Raciniak, and he took a bunch of dogs, put them on high-dose insulin drips and dextrose drips, and then found that he just could not kill them no matter how high a dose of beta blockers that he gave them. It has to do with like metabolic substrate use in the heart and stuff like that. I won't bore you with that, but it is really cool if you ever are like develop insomnia and need a way to put yourself to sleep. You should give those trials a read. Digoxin toxicity, we have a specific medication called Digifab, which binds to digoxin. And sodium channel blocker, if it's not Brugada, it's pseudo-Brugada, we can't actually correct this by giving big boluses of sodium bicarbonate because same principle of the first two, we can just outcompete that receptor site. All right, and then the clinical pearl is, if you don't know whether it's a calcium channel blocker issue or a beta blocker issue in patients on both, it's a good idea to get a glucose. Calcium channel blockers increase insulin resistance, so put the patient in like a pseudo-diabetic state, so their blood glucose will be high. Beta blockers do the opposite. They potentiate insulin, although they also decrease the amount of insulin that's released, but they potentiate native insulin's effects, which will give you either normal glycemia or hypoglycemia. That's a cool thing to know. All right, case 3, 55-year-old male. He's got crushing chest, like, do I even need to read this? We all know what this is. Like, he's having a heart attack, right? Yeah. Those are his vitals there. That's his history. That's a big old inferior MI.
Hoops.
Yeah.
Everything's what I'm seeing.
Good one, Scott.
And then I don't think we need to wonder if this patient's stable or not. No, it's definitely not stable. Looking at the EKG, proximal or distal disease? Proximal, yeah. Okay. Secondary cause. Pretty obvious, he's having an MI. MI can cause bradycardia through a couple different ways. So if you have an inferior MI that includes like an ischemic focus at the SA node, you can just take out your SA node. If you have a lateral MI that covers the territory that supplies the AV node, you can just completely take out your AV node. There's also this thing called the Beazle-Jarisch reflex. Crazy, everything in medicine is named after someone else. And it's a cardioprotective reflex that's actually mediated by the ventricle itself. So you have an MI, your ventricle isn't moving like it should. There are actually mechanoreceptors in the ventricle itself that can kind of tell that something's going wrong. And then they release a bunch of chemical mediators, which increase vagal tone to drive down heart rate and myocardial oxygen consumption. And that's actually what's going on with this patient. He just has insanely high vagal tone, which we could probably guess at, right? Because he's in a sinus rhythm. We see P waves there, just going really slow. There's not even like an extension of the PR interval. PR is fine. So yeah. So how do we want to treat this patient? What do we want to give him? Emma? Who wants to, like, show of hands, who wants to just immediately pace this guy?
Or I'll do speed of that.
No? Okay. Who wants to give this guy epi? You have Tiger, 2 Tigers. Who wants to give this guy atropine? Okay, sorry, yes, we're not like, incompetent, so we are gonna give nitro, we're gonna give aspirin, we're gonna do all the normal stuff. Yes, that's a good call, yes. MI is the priority here. However, that ischemic focus is only going to expand if we don't get his heart rate up, right? So that's the second issue that we're trying to fix. Obviously, we need to get this guy to a cath lab, that's definitive treatment. In the meantime, to keep him from arresting in front of us, atropine is actually a good drug to choose in this case. I would be pushing atropine at the same time that someone else is like slapping some pads on him, because I don't trust atropine to work, but theoretically in this situation, it could work. So it would be a good drug to use. Why wouldn't we necessarily want to give epinephrine or dopamine?
It's a constrictor. Slow the heart. It's the alpha. Too much.
Sorry, what?
Wouldn't it cause constriction, right? Increased contractility and.
Yes. So if we're having an MI, our heart's already not getting enough oxygen, we make it work harder.
Yeah.
More cells are going to die from lack of oxygen.
Yeah. Why would we give atropine to speed that up?
Because
for confusion.
Yeah. So you're in an undesirable situation here.
Right.
The patient's having an MI, but they're also malperfusing, which means that the area of ischemia is only going to get bigger. If we increase their heart rate, maybe we can perfuse that area and prevent spread of ischemia. However, atropine doesn't come with the other effects that are inherent with epinephrine and dopamine, which is to cause the heart to squeeze harder and to also provide more vascular resistance for the heart to squeeze against. That's gonna
eliminating that ability.
Yeah, it's gonna greatly.
And allowing it to. Okay.
Yeah, if you give epi or dopamine, it's going to raise the heart rate, but it's also going to make the heart work a lot harder, which is going to increase myocardial oxygen demand and potentially make this patient worse. That said, if you try pacing, you try atropine, nothing's working. This guy's about to die in front of you. I mean, he's going to be dead either way. Go ahead and try the epinephrine and get him to the hospital as quick as you can.
What are the toss due to the inferior side of the MI?
Yeah, inferior MIs can be preload responsive or preload dependent, specifically if they take out the right ventricle. You could do either like a right-sided EKG or look for signs of posterior ischemia and just a normal 12 lead. Yeah, that's a good thought, yeah. Yes.
Say for instance, we know that he's having a heart attack with compromises, blockage. Even if we decide to give him atropine or epinephrine and speed up his heart rate, can that cause a rupture? Of the blood vessel?
A rupture, but that's very unlikely. Talking about like ventricular wall rupture or ventricular aneurysm, usually that is something that develops, I think, 3 to 5 days post-MI. So it's actually, initially the tissue, it just dies, and then it will eventually scar back over and become like really firm and immobile. But in between period, it kind of just degenerates and becomes very weak.
Pretty much what was I saying? What I was trying to say is we probably could cause more problems, but that's what I was trying to say.
Yeah, I mean, yeah, like I said, it's not a situation you want to be in.
Yeah.
But the patient, if they're dying right in front of you, you can do nothing. Yeah. You could do nothing and just race this guy to the nearest cath lab and hope for the best, just knowing that at some point he may arrest and you may have to do something about it. Yeah.
It's fine.
Case 4. 46-year-old dude, he's a farmer. He rolled his combine. He was left pinned under it for 2 hours. First responders just pulled him out 15 minutes ago. Thank you, guys. He's got obvious crush injuries to his bilateral legs from the thigh down. No obvious hemorrhage. His vitals are all pretty trash. And his medical history is irrelevant because he's a farmer. He doesn't go to a doctor. This is his EKG.
Oh.
Anyone want to guess what his problem is?
What's a disc crash?
Yes. Nice. What'd you say? Crush syndrome?
Yeah.
Yeah. Nice. And what? Yeah. Yeah, very good. So this is a potassium issue. It happens in a crush injury. All your cells that are crushed, they lyse. Potassium is very high in concentration inside of cells, so when you explode those cells, potassium just kind of goes everywhere. Usually the mechanism of crushing provides a nice little tourniquet until we remove it. And then as soon as we remove that, that potassium can now get back into systemic circulation. And it's like giving just a big old bolus of potassium, which is the way that we kill death row inmates. So yeah, it's gonna lead to some bad effects.
That's all. I've seen also prevalent in agent trauma.
Yes, yeah, exactly, yeah.
No, wait.
Patients unstable, proximal or distal disease. This is a good one for this question. That's a super wide QRS, right? Is it distal? It's actually proximal, which is why you can't always rely on the QRS. 90% of the time. But it only looks wide because the depolarization and repolarization rates are so blitzed by the extra potassium in the bloodstream. It changes the differential between resting and threshold potential. So usually your resting potential is down here. Threshold potential is here. You make it up to here, then you have an impulse. With hyperkalemia, your resting potential ends up here above this. So you are basically stuck. You cannot depolarize, which is why it drives the heart rate down a ton. You have to wait for passive diffusion of potassium ions to get you back down to threshold, and then you can depolarize again. Yeah, so I think I covered all that. That's a nice little chart just showing you how hyperkalemia marches out on EKG. Calcium reestablishes the differential between threshold and a resting membrane potential. So that's why we give calcium. You could also, what are some other things you can give, I think, in the field? So what? Albuterol, yeah, exactly. Albuterol will shift potassium into cells, get it out of the bloodstream. If you're in the hospital, you could also give insulin. Does the same thing. This patient is like a dialysis patient. You can just take them to DaVita, just dialyze that potassium right now. Case 5 is our last patient. 11-year-old female, called for altered mental status. Her mom kept her home from school today because she's been running a fever for the last couple of days. However, she's becoming increasingly lethargic. Level of consciousness is rapidly depreciating. They recently got back from a camping trip in Michigan. There are her vitals, by far the most unstable patient we've had. No medical history, she's a healthy 11-year-old girl. This is her EKG. Anyone have a guess what this is? So what? No, that's good though. Lyme carditis, nice, guys, that's really good. All right, real quick, proximal or distal, what do you think? Distal, yeah. We have a complete AV node dissociation. These ventricular beats are coming from the Purkinje system. So, patient's unstable. We already covered proximal versus distal. Secondary cause is ear tick, I guess. Treatments. How are we gonna treat this patient? So what? Antibiotics eventually, right? That's what people in the hospital will load this kid up with Rocephin or something. Only after you guys have saved the day and gotten her to the hospital alive. So how are you gonna do that? Who wants to immediately go to pacing for this patient? Love it. Anyone else? Yeah, pacing. Who wants to immediately have their partner start pacing while they're mixing an epi drip or getting a dopamine drip? Yeah. Who wants to recruit a third person to pull up some atropine and give it right away too? Sure. Give all the shit to this patient. Give them everything. Hopefully, if you throw enough at the wall, eventually something will stick. And that is actually the last case, I think. So some other resources, if you're like super into EKGs, Life in the Fast Lane has like a compendium of them if you want to review. If you like critical care, there's MCRIT podcast, and it's also a blog that covers a lot of cool subjects. Emergency medicine cases is actually based out of Canada, but I've forgiven them for that because they have really good case-based discussions. And if you're a super nerd, maybe you would like this book by Firster and Hurst, which is just called The Heart. It's something we had to read in medical school, and it's just an incredibly thorough resource for anything cardiac physiology, pathophys, disease, anything. And then that's it. That's all I got for you guys. Is there any questions? I want to talk about anything?
How much glucose should we give?
All of it. All like literally empty out the glucagon in your ambulance.
So one.
Yeah.
One dose.
One dose. All right.
1 milligram. That's good. All right. Everybody give Adrian a big round of applause. I was very much looking forward to you being here. I was hoping you didn't suck. You didn't disappoint me.
Thank you, John.
All right. So how many presenters do we have here? So Brian and Adrian, please, if you'd step back up. Are there any other presenters that are still here? Just those two? Come on back up. This is the part that we kind of put to the side for a little group discussion of anything that you would like to talk about. Luke and Matt, if you'd like to join us. One thing I do want to point out is everybody knows that this is put on by PHI. Our boss, Luke Lamar, has approved everybody to get overtime and all that to put here. But I want you to recognize that this has not been a PHI infomercial. We have not pushed, well, here, PHI, this. None of us are even in flight suits. We put these on because we want to get paid. So
t-shirt.
Whenever when we put this on in the beginning, just keep that in mind, push that on the others because, we're not pushing anything on you. We've got very unbiased presenters, and there's some of your peers, some of our peers. So I am most proud of what this does not represent. It doesn't represent us just shoving stuff down your throat. These are just our people, your people here presenting in an unbiased way, just going out the education that we're getting. And we're not trying to shove anything. We're not trying to shove, who's putting this on. When you see our sponsors, we thank them for doing that. So that is what I'm most proud of about this. Matt Spicer, again, putting this on second year in a row, did a great job, Matt. Even though last year he titled it the first annual. That's all right, we'll give him that.
You never came up with the word for me. You came up with all the words.
Well, I never see you as a threat to me like I did others. All right, group discussion. So you can ask any one of them a question, or because all the brilliant people in here, if there's something you want to talk about, we'll come up with an answer. If there's something you just
we'll make it up.
But anybody else see any similarity in between two brilliant people up here? It look like they may be brothers.
Hey.
Yeah, you might be one of them. I just think it's astounding that two of the smartest people I've had the privilege to work with recently, because Matt, I don't work with you and I don't work with Luke. But it's just, I saw them back here side by side and I'm like, damn. They could be brothers. But group discussion, anything, clarification, anything you just want to talk about, or if you want to throw out some ideas for something you'd like to see next year. This is a great time to just throw stuff out there.
As you say, I guess we can preface that. So starting in 2025, we are going to kind of start doing more outreach education, probably bi-monthly, quarterly. It's going to be at the base out in the hangar. Topics that you all choose, 1 to 2 hours, just come, some hands-on fellowship, some free education, and then hopefully if it expands, we get enough pushing it out, maybe an agency can sponsor it around our service area and invite other people in as well. So with that, whatever topics you all would want, need, desire that you can't get someplace else, if we don't know nothing about it, we'll call somebody that does. Or he can reach out to some medical folks. We got tons of contacts down in Norton's, U of L, UK, things like that, that we can reach out to and actually bring in some subject matter experts to get you guys some education. We're all passionate about it. Unfortunately, we have to mainly do PowerPoints for this type of event, but as Jennifer and Amanda and others can attest, if we come into their agency or hospital, we do hands-on. That's the best way to learn that we feel like. It's better for that group discussion. You'll see that we hardly ever present a PowerPoint unless we just absolutely have to, like an LZ class or something. But other than that, it's a whiteboard or a piece of paper explaining the thought process on it. That's kind of what we're passionate about. So whatever we can do for you guys, let us know. Whatever topics, if you even have a run that you're like, hey, could we have done something different, or kind of, we don't need patient information or nothing like that, ages or nothing. Say, hey, is this asthmatic? We did X, Y, Z. What could we have done different? Anyone at the base is happy to discuss that with you guys. It's nothing bad. We're not going to go tell your supervisors or bosses. It's an educational moment, learning opportunity that we like to do, and it's also something that we can learn from as well as a family or as a base. So with that, anybody have any topics, anything that we covered today that you kind of want to know more about? Further explanation about anything or runs that y'all had that you kind of want to talk about?
What about, introducing more of the political side of education?
Okay. Yeah. We're always willing to participate with Mass Cali events, especially I think something like that. We need to get fire, EMS, police all involved in the hospital and get everybody together, because with that, like we learned during the burn lecture, even with hazmat, it opened up a whole entire new arena of networking and possibilities that's there with that. So definitely, yes, Mass Cal, if it's within the service area, we can kind of land the helicopter. We do it for like Project Prom a lot, the car wrecks or other like school events that they have. Like I know some colleges will do like integration with nursing students and the EMS students, and kind of like co-collaborate, see that continuity of care evolve. So anything like that, we're more than happy to be involved in and kind of bring out some education with that, and kind of show that process of what we need to do or what we're looking for from the helicopter side.
Well, that's a great suggestion. So mass casualty, because we always think trauma mass casualty. You said medical mass casualty. So I'm thinking, all right, we had a chemical plant. I've not thought of a medical mass casualty. We always say trauma. And trauma's easy. Find the bleeding, stop the bleeding, trauma over. But
We
medical mass casualty,
we
that's
understand what we're trained to do, but when the actual incident happens, it's a whole nother ballgame.
But I've never trained for a medical mass casualty. It's always trauma.
It should be medical because you got the rescue side of it, and you got the medical side of it. So.
I think it's
do hazmat, large exposure.
Yeah.
And logistically, it's.
Because we treat, we do, we decon for hazmat, and then we give them to you guys to do the rest. I mean, that's.
I used to work with Madison Chemical with that. We do exercises with them. The whole hospital would, EMS.
Yeah, that would be something, because he's the president of Madison Chemicals right there on our airfield.
Yeah.
Well, on top of that, we also have, you think about, we got Madison Chemical, but you also got IKE. IKE has a lot of stuff that people don't even know about.
All right, good idea. All right, what?
Pediatric trauma.
Pediatric trauma. And you really tried to get.
Yeah, everyone's out of town.
Yeah, so, but that needs, you're right.
Or pediatric medical.
Um,
We have a lot of
Yeah,
special needs or sick patients.
So what we can do with that, I can reach out to the JFK team. They actually have mannequins and can bring in all this stuff, and they do literally a whiteboard lecture. So if we could get enough interest, I can send something out to everyone that registered and find a place one to host it and see if they'll be willing to come up and bring their truck and all their training equipment and kind of do a joint venture with that. They're very, very good. I've sat through several of their simulations before. The girls know what they're talking about.
Maybe that's one of those things whenever you start talking about it,
Yeah,
that we're gonna do something at the base, we do something in the evening time on a Tuesday evening or something like that.
Yeah, have them up.
One subject, one topic, 1 2-hour block, move on.
Yep.
That's great. Yes.
Water emergency?
especially where we live.
Yeah, like for both swift water and slow water rescue? Or you mean more like
Swimming pool,
Drowning.
river.
Recovery.
Yeah, so Gallatin County, we did that. We actually went over to the fire chief's house and actually put somebody in the swimming pool. The first responders there, EMS person actually got in the water with their backboards, their equipment. And we kind of just facilitated the teaching points in the discussion with that, and they actually carried it out. So that is definitely something that we could do. I know I talked to several of the people down in factories when there was that diver drowning, I think down in Louisville a couple of years ago, on what they would do for diving emergencies, because then that relates, okay, we can only fly at a certain altitude versus we can only go by ground depending on if they have the bins or not. So that keeps it very up to date even for us, because Jewish has a hyperbaric chamber and then UK does. So there's only 2 places that we could even transport to with that, and we would have to know ahead of time depths and things like that. There's a couple lakes in Kentucky that would be deep enough where somebody could get the bins. Same way, depending on what oxygen system they're using.
Johnny, that would be good. Usually because they've divers now, I can't.
IKE do have their own numbers.
Yeah, so that'd be something, because I talked to the program at Jewish and they're like, yeah, we actually do get more divers and stuff that you don't realize, because it could be 20 minutes later or 3 hours later before something develops.
Here's an idea, you can get fire involved with it, but I don't think it happens often here, but like, say there's a pool and there's a structure fire at the pool, one of us firefighters fall in it.
Yep.
Full gear and air pack, yes, if you think about that.
Great. What else? That's a good suggestion. I mean,
Know where some of your resources come from, like, and that happens over at the airport, the LEP, local emergency planning commission, that gathers all the data for hazardous chemicals. Maybe have them come in and tell us how they gather it. And, they try to direct your alls.
Yeah, and
Airports where those.
what's the initials? What is it?
LEPC.
LEPC.
That's where all the chemical information comes that transports through the town, what plants has what. And
Yeah, we gotta have the whatever act like that. Yeah, but
I know it doesn't necessarily apply to the helicopter side a lot, at least I don't think it does. But I think it'd be cool to see classes on like responding to treating medical emergencies as far as, suicidal patients or people that are going through mental health crises.
Oh, that's a
I
good.
think in EMT medic school, it's kind of, hey, here's your things people are diagnosed with, but not necessarily.
it's a one
Here's a
page.
one psych rotation.
Yeah.
Yeah, it is.
He actually did make a difference for him.
And I'd love to have a psychiatrist in here because they can cover a couple of things. You take 30 minutes and tell us how we're going to approach X, Y, and Z patients, and then finish your other 30 minutes with this. How do we approach taking care of
Because I
ourselves?
mean, it does apply to us, because I mean, we get people in the helicopter that's never flown before, or they're intoxicated, head injury, or having that mental health crisis that's, done something that we need to get out of there because they're traumatically injured or medically injured. And it's like, how do we approach that? So.
Oh, we approach it by
Yeah, well.
paralyzing and intubating for safety.
But
Should something develop, say maybe they start herniating, maybe it is a TBI, they start herniating, and now they're combative when they were fine before. So I'd say still, same result, but.
Okay. Any other ideas? Any questions at all? Anything you want to talk about at all?
So I think, like, I've worked with Scott County part-time, so obviously we utilize helicopters, I feel like, more than I'm ever going to in Louisville. But what do you all expect from a provider as far as report goes? If we're giving a report over the radio prior to you all landing, and what do you all expect us to give you information-wise once you're in the back of the truck?
yeah, so basically, normal LZ, we can always come in and do an LZ class. PowerPoint, it goes over all that, but basically where the obstacles are, trees, power lines, big tall towers, if something's marked, anything like that. And then
whatever other information, is a hazmat scene, is there an active shooter still going on, any other hazards to us. That's what we're looking for mainly. We can figure out the patient side of it when we're on the ground.
The other thing, as far as the patient side is concerned, that would help us before we land is a patient approximate weight.
Yeah.
That way the pilot can go ahead and start doing his weights and balances while we're working with you guys. So like Matt said, safety stuff is what's important. We can all figure out the clinical stuff. I mean, how many times does the CAD come over and it's all like, oh, it's a leg lag and this dude's missing it? You know what I mean? Like,
yeah.
So we'll work with it, but
yeah. So just obstacles where everything's going to be marked. Hey, you got 100 by 100 field. It's going to be marked by blinking lights, and you got fire trucks under all the obstacles of power lines and trees. That's good. We'll make sure the pilot's okay with it, because ultimately the pilot's in charge. So if he says, I don't like that, I'm going to find a different one, we radio to you, hey, we don't like the way this one looks, we're going to go over here. And then once we land, you bring the patient over, type of thing. And then at nighttime, we have to have ground contact, or we can't land, or we'll have to say, hey, can you take it to the hospital? And we'll meet you at the hospital helipad, type of thing.
I want somebody to specifically ask Luke Lamar a question.
I will not have an answer. I was gonna tell you too, for like patient report, once we get in the back, if you haven't told us, we're gonna ask the question anyway. So if you forget the glucose, I'm gonna say, did you get a glucose?
Comment and report though is what I guess.
If they're intubated, say, hey, we intubated them, or hey, this patient's going to be intubated when we get down here, or hey, this patient's going to need blood. At least then we know, okay, do we need to turn on the vent and hook up the oxygen, or do we need to go ahead and get that blood prepared and have everything out ready to rock and roll? But we go down for Louisville International's big drills that they have at the airport, so they will be utilizing air medical to get patients out. That's part of their disaster plan down there. PRP Fire, where they're down there along the river, Rubber Town and all that, they've even said, we'll utilize that. Then they got the mutual aid to come across the river for any technical rescue stuff. So there is.
I mean, I'm in Oklahoma, we cover the UPS side of the airport. So
okay.
I guess that is plausible.
Yeah, because we can go to UK. We can go to UK in 15 minutes, where you guys are going to transport into Louisville. We're going to shoot over to UK to offload U of L. Yes, Teresa.
And then we're going to come back.
I was just gonna ask, we can personal question to Luke. Do you still have your-
Oh, thank you, Teresa. What's your question to Luke Lamar?
Do you still have your llama picture?
Oh, yeah.
Or is it?
Ember's room. And we've got it all decorated with little flowers and made it part of her nursery. There you go, Johnny.
Really? You let him off that? It was a question.
Set up you a question for Luke.
Touche. All right, did anybody happen to look up precocious so you can tell Adrian what the word of the day means?
Oh, yeah, I'm dying to know.
I did look it up.
All right, any other questions while he's going to tell Adrian what precocious means?
I would love to be able to say all the words of the definition first off.
All right, just go to the last
Do the
line.
clip notes.
Yeah, the last one.
Having developed certain abilities at an earlier stage than usual.
Okay, thank you. That's my brilliant little buddy right there. All right.
Can you put the code up for the last one?
Yeah.
We're proud of you for using that way to work.
I was laying in bed, I'm like, damn it, Adrian's gonna be there tomorrow. Word of the day, word of the day.
Dude, stop thinking about me when you're laying in bed.
We did share something special, Adrian.
Then after this one, there is an actual just overall symposium eval, just topics that y'all would want to see next year. Make sure the lighting was perfect. Johnny's hair looked great. Anything like that you can provide back, because we do look at that. And like Johnny said, we took what was submitted last year and applied it to this year the best of our abilities with that. So there was actually more workshop time than there was last year. It ran a whole lot smoother than it did last year. Y'all were here last year. So we're continually improving. We would like to make it bigger and better every single year. So please tell your friends and family. 80 people signed up. Half of those were online or had to move to online, unfortunately, to other circumstances. But tell your friends and family, come up. I mean, there's people all the way from Meade County, Kentucky, and then we got people that were on Federal Fish and Wildlife Service here, and we get a great array of people. So,
was this recorded?
Yeah, it will be. So I'll have to do the final stuff for editing and publish it. So then you can go back to our YouTube channel. Last year's is still on there.
And then this year's will also be on there as well. So if you miss something, it'll be like, oh, what did Adrian say, or what did Brian say about this? You can go right back and kind of just go to it. So if you have issues with any of the sign-in sheets, everyone pretty much stayed the entire time. If somebody had to leave early, they told me, so I know which ones they missed. I'm going to go back in tomorrow on shift and start looking over all the sign-in sheets and looking through, and I will make sure your names and everything is on there. So don't fret about that. It's mainly for Indiana and Kentucky. The evals are mainly for Kentucky people. Just the way that the KD and KVs wants it done with outreach education. But if you're Indiana, you don't have to worry about the evals, but everyone likes feedback. It's all anonymous. So like, you don't have to put your name in there. We're not going to be like, yeah, they're not allowed back next year type of thing. So, and then just as opposed to an eval, that way we can have feedback as a base on how we did and what topics y'all like next year, what went right, what went wrong. It's not going to hurt any of our feelings at all. So be blunt, please.
And for those of you online, we will double check and make sure that you have your names down, that we get
Let's close this up
the credit you deserve as well. Okay.
If you have trash, we put it in the trash can because we have to be out by 4 and they're gonna start breathing down our necks here in just a second. So we gotta take all the trash out. Please.
Okay, 5 seconds. Anything else? 4, 3. Thank you for another great year. Dismissed.
Yep. Thank you guys for online. Indiana people,